السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. I think we should start. My name is Dr. Mohammed Al-Fayfi. I'm an associate professor at Al Faisal University and pediatric emergency consultant at Department of Emergency Medicine, King Faisal Specialist Hospital. First of all, I would like to thank our Saudi Pediatric Association for sponsoring this conference with Al Faisal University in collaboration with the American Academy of Pediatrics and American College of Emergency Physicians. We are so happy that by now we reach almost 2,500 attendees from all over the globe watching and attending our online conference. This is like a continuation of cooperation between Saudi Arabia and the United States in the medical field education, since we have so many speakers, local speakers from Saudi Arabia, in addition to international speaker from American Academy of Pediatric and American College of Emergency Physicians. This conference will continue for 3 days, today, tomorrow, and after tomorrow. And we have expert speakers also local from King Faisal Specialist Hospital, as well as Prince Sultan Medical Military City, and also University Hospital, King Khalid University Hospital. As I told you, in addition to our international speaker from AAP and ACEP. I would like really to thank the Saudi Pediatric Association again, Professor Saidi and Professor Al-Umair for their support for sponsoring this conference. Also, I would like to thank Dr. Professor Al-Hayaza and Professor Qattan from Al Faisal University for their continuous support for the last 14 years for having this conference in Al Faisal University. Now we are doing online broadcasting from Al Faisal University. And I wish you will enjoy the conference. And I will start my lecture with the pediatric emergency in Saudi Arabia as a current status, as you know. And just to give you an idea, this is King Faisal Hospital in 2010. As you can see here, this is the old construction of the hospital. And in the last 10 years, there was a lot of changes in the hospital. As you can see here in the center, there is the emergency. This is the aircraft where it landed, and here is the emergency department. If you can see, if my pointer is clear to you. This is the plan. Was released in 2015, where they have King Abdullah Center for Cancer and for transplant, and also the research center, and the emergency center, as well as the other areas. This is the real, in 2017, when they finished the King Abdullah Center, as well as the emergency department. This is the image of emergency department in King Faisal. It is the state-of-the-art emergency department, which has like 3 floors. The emergency, it's in the basement. And as I will show you some photos. As you know that Saudi Arabia, it is like considered the 5th largest country in Asia, and considered the 2nd Arab world in terms of area. And it has a lot of regions, more than 13 regions. That's why it makes it difficult for the medical health and medical services to be provided for all over the area. However, in the last 10 years, there was a lot of achievement, okay, to cover all these areas. Just to give you an idea about the population, It's, as I mentioned, it's about 2.24 million square kilometers. And the population was in 2002 was around 21 million, while in 2020 was 37 million, and we are expecting to reach 40 million by 2025. And most of them, they are in the major areas, like 80% of the population in Riyadh, Mecca, and the eastern region. Demographic indicator, usually the pediatric population around 40%, while the age over 65 around 30%, and most of the population in the country were youth and younger adults. Are we unique in Saudi Arabia in terms of like events, in terms of facility, in terms? Yes, and for example, we are having a large incident of diabetes, as well as also vitamin D deficiency as well, and we consider one of the largest country, and because this is related to genetic and also to the lifestyle. Okay. Also, we are unique. There is some youth, they are having some high risk behavior, okay, at young age, and also they have a very good like an attitude, good attitude, just to show you that this kind of changing wheel of the car while it is moving. And this is just showed in one of the famous TV show in United States, and considered one of the best clip during that time. Also, you know, our youth, our young, they are doing a major job during Ramadan. You know, they are providing the breakfast to all the people outside. They are, for example, breaking their fast on the street, providing food, providing everything to the people in the street, or the poor people. Also in 2015, as you can see, women, they have the right to drive, and women, they have a strong role in the life in Saudi Arabia. They are participating on all kind of activities, okay, even in soccer, in hospital, everywhere. Also, we have a high incidence of motor vehicle crashes. This is an old slide where it showed like that was more than 10 years ago. It is like, you know, the number of deaths, 40 deaths per 100,000, which is considered the highest. But with this, with the new established rule of traffic rule and enforcing the traffic rules, there was an announcement from the Minister of Interior that the number of accidents has dramatically decreased. Okay, and this is with the improvement of the and enforcing the traffic rules. Also, there is an important thing even during Hajj. As you know, our kingdom, we are proud to have all, we call them the guest of Ar-Rahman, Duyuf Ar-Rahman. They are coming every year for Hajj season, and also during Ramadan. And now throughout the year, our government, they made it easy for everyone to come and get a visa to do Umrah or to do Hajj. And this like like annual gathering of more than 2 to 3 millions in this small area of almost like 5 square kilometers. It is a huge event, and with minimal incidents of accidents, and this is considered like a credit for our government in Saudi Arabia. And as you can see here, the Holy Mosque, this picture was taken during Ramadan season. Okay. And we are proud to have all these people coming and visit Mecca. What about the health sector? What about emergency, since we are talking about the emergency? As you know now, that an emergency department, most of our people, most of our population, they prefer to go to visit the emergency department to have a short access and to have a modern, services in the emergency department. And in one study, it showed that more than 30 million ED visits per year, more than 30 individual, okay? That means each 100 individual had like 90 to 100 visits in our country. So it means that every one of our population used to go and visit the emergency department. While the world standard, like in USA, the only people go per 100, only 30 to 40 visits. And the rest, like 60%, they go to their family doctor or to the primary care center. And this is, we have to look into it, and we have to consider by improving the infrastructure. And this is what the Ministry of Health is doing, and encouraging people, and also for the media, improving the system, like to build more advanced primary care center, so the people can be encouraged to go and to the primary care center instead of going to the emergency department, where there is, so many sick patients, okay? As a specialty in the emergency department, it's considered a new specialty. It's not like other specialty like pediatrics or medicine, OB-GYN, surgery. Emergency department, emergency medicine, it's a new, considered relatively a new specialty in the last 20 years. And based on the study that, and the need, and based on the population, and per how many physicians per group of patients, we need around 1,500, and in some study up to 2,000 emergency physicians. So that means, and as you know, that we are graduating almost like 40 to 60 per year. So we need at least 20 years to reach this number, which is 1,500 physicians. And for this reason, all the hospital, they start, or all our colleagues as an emergency physician, they start to establish like a program or training, so to have more trained emergency physician graduated to serve and to reach this number and to be covered soon, before, instead of 20 years. This is just to give you an idea about the major events in the history of emergency medicine. As you can see, our partner, like American College of Emergency Physicians, it was established in 1968. And I don't see here yes, American Academy of Pediatric. I think this is one of the oldest society. It was established in 1930, okay? And our the program, which is here highlighted as a Saudi pediatric emergency physician, which was recognized as an emergency specialty, because initially it was started as in 2000, but it was under surgery, under the Scientific Board of Surgery. That was in 2000. But in 2005, it was established as isolated, as a dependent emergency, Saudi Pediatric Emergency Medicine Board. And also one of the important event here in 2005, that was our first fellowship program was established in 2005. And I feel honored that I'm the one who established this emergency pediatric emergency board fellowship, I mean, in King Abdulaziz Medical City, in addition to Dr. Al-Hussein Muhammad in King Faisal Specialist Hospital. And we have at that time in 2006, 2006, I think, or 7, we graduated the first 3 fellows in pediatric emergency, and I still remember them: Dr. Ma'touga Gadi, Dr. Abdullah Tamimi, who is one of our speakers now, and Dr. Ahmed Saleh, who is now the head section in pediatric emergency medicine in King Faisal. That was like around 20 years from now. Saudi Board of Emergency Medicine, it was started, as I told you, in 2000, and the number of trainees for, I still remember their name: Dr. Sagga, Dr. Rasab Tamil Anizi, Dr. Saeed Dathil Al-Kharji, I'm sorry, and the 4th one, I don't remember really now. This is the first, this is one of the meetings. As you remember, the one in the center, this is Dr. Al-Freh, who was the first director of the Saudi Council. To his right side, this is Dr. Abdullah Al-Hudayb, who established the Saudi Board of Emergency Medicine. And to the right here, close to me with the white thobe, this is Dr. Khalid Al-Jihani, who established the Saudi Society of Emergency Medicine, SASM. Okay. By now, mashallah, we reach a good number, more than 22 center, and this is like an old slide. This is about 2 years old. I think now we are getting more and more centers and graduating more and more residents in emergency medicine. This is in adult emergency medicine, okay? And the trainee graduated till 2021, more than 500, with the current adult training now, more than 300. So I think we can reach soon, as a vision of 2030, reach the total number of emergency physicians that can be optimum and enough to cover the emergency departments and all of the kingdom. What about the Saudi Pediatric in Pediatric Emergency Medicine fellowship program? Usually we are accepting fellows graduated from pediatric or from emergency medicine after they finish, and it is like 2 years. Okay, it is the same, almost like a North American standard. And this is like a picture of here in the center, me and Dr. here to the right, to the right side here, Dr. Muhammad Al-Hussein. And as you can see here behind him, Dr. Al-Hajri, who is now in National Guard. And these are the one who now one of the expert senior pediatric emergency consultant in the kingdom. What is the history of pediatric emergency? Actually, in 2003, we submit our proposal. As you know, in King Abdulaziz Medical City, it was the first center in pediatric emergency medicine, like in the kingdom or in the region even. Okay, Dr. Abdul Jabbar at that time, he launched the Pediatric Emergency Center. And at that time, I felt and I decided that we should go ahead and establish our fellowship program instead of keep sending people to North America with the North American standard. In 2004, it was approved. In 2005, it was the first 2 center, King Abdulaziz Medical City and King Faisal. And 2007, there is a first certified examination done, okay? By now, we have more than 250 fellows graduated from Pediatric Emergency Fellowship Program. And in the training now, the current training, we have 100 trainee, F1 and F2. And in just 2 months ago, in February, we did the final examination for our F2. More than 50 people, they applied for the exam, and with a 100% successful rate. Now we have like, at the center, we started with 2 centers only, King Faisal and King Abdulaziz Medical City, and now we reach almost more than 20. This is an old slide. This is 2019. We have in Riyadh 6 center, in Western and South 7 center, and in Eastern region 3 center. Almost like 16, but I'm sure it's more. This is 2017. The governor of Riyadh opened our emergency department in King Faisal with the presence of His Excellency Dr. Majid Al Fayyad. And this is the building. It is a state-of-the-art building, emergency department, considered one of the best department in the region. And as you can see here, the reception, and this is the nursing station, and this is the resus room. It is already equipped with very advanced equipment to help for providing the best service to our lovely kids and also for adult emergency. And this is the station for the physician. And this is also a hall for teaching and for giving lectures and activity. Okay. So at the end, this is my end. I'm sorry, I took 1 minute extra at the end of my lecture. This is what we are. I think the most important here for our society and for our population, to encourage them to come to the emergency when they are really sick, when they need the emergency, because this is an emergency. But this cannot be done without improving the primary health center quality of care, and also through the media by educating the society when the need for the emergency department and when should I go to the emergency department, and also to improve the hospital efficiency and patient flow, because most of the time we have a lot of patients in the emergency department, and most of them already admitted and boarded in the emergency department and considered like admitting floor, and this should not be done. And also coordinated, regionalized, accountable system to increase resources and invest more and more in the training centers. Sorry. Thank you very much. And if you have any question, you can leave it in question and answer. And I will be more happy during the break to answer all your questions. Thank you very much. Just to let you know, our next speaker will be Dr. Catherine Remick. And Dr. Catherine Remick, just to give you an idea about Dr. Catherine Remick, she is a co-director of the National EMS for Children Innovation and Improvement Center. And she is Associate Chair for Quality, Innovation, and Outreach, and Associate Professor of Pediatric at Dell Medical School at the University of Texas at Austin. And she also serves as a co-director of the National Pediatric Readiness Project, executive director of the National Pediatric Readiness Quality Initiative, and a member of the Pre-Hospital Pediatric Readiness Project Steering Committee. Both a pediatric emergency medicine and EMS physician, Dr. Remick focus on system-level quality improvement effort to enhance national emergency care system. She is best known for her work in pediatrics. And Dr. Remick, she will talk about how to improve quality measures in pediatric emergency medicine. Okay, she can start, Khulud. Dr.
I am an associate professor of pediatrics and surgery perioperative medicine at Dell Medical School at the University of Texas. Thank you so much for having me, and I'm going to be speaking about quality measures in pediatric emergency medicine. I have no disclosures, and I assume full responsibility for the scientific validity of the content of my presentation. These are the objectives that I plan to cover, describing the importance of quality improvement science in pediatric emergency. Hello, my name is Kate Remick. I am an associate professor of pediatrics and surgery perioperative medicine at Dell Medical School at the University of Texas. Thank you so much for having me, and I'm going to be speaking about quality measures in pediatric emergency medicine. I have no disclosures, and I assume full responsibility for the scientific validity of the content of my presentation. These are the objectives that I plan to cover, describing the importance of quality improvement science in pediatric emergency care, identifying some foundational as well as advanced quality measures for adoption, and understanding some of the strategies that we can use to improve pediatric emergency care delivery. So before we get started, it's important to recognize that quality of care is really defined as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Now, in order to demonstrate any kind of degree of quality, we need to be able to show that through data or some form of outcomes or visualization. And Peter Drucker once said that you cannot manage that which you do not measure. So foundational to any kind of quality improvement activity is the degree to which we can actually measure it and thereby not only demonstrate it to others, but hold ourselves accountable to ongoing improvement. About 2 decades ago, an effort was undertaken to really define what we mean by quality. What are the pillars of quality of care that we should follow? And the Institute of Medicine really took this on in an effort to say, how do we break quality down into its parts? And they were able to identify 6 pillars that really define what we mean when we say quality in healthcare. First and foremost, and one that we often take for granted or don't think about regularly, is safety, meaning free from harm, free from preventable medical errors, free from missed opportunities, diagnoses, processes. These may be errors of omission or errors of commission, but it's really about ensuring the safety of our patients. Second is effectiveness, how we really provide care in a way that we know will lead to the best possible outcomes. And this is really centered around evidence-based practice and ensuring that our decisions are in line with what we know will lead to the highest levels of function and survivability. Third is patient-centeredness, and this is really getting at the values of our patients, putting them first and foremost in our decision-making, allowing patients and families to actually engage in that decision-making through informed consent, and ensuring that they have a good understanding of why we're doing what we're doing and are able to make decisions that most align with their values. Fourth is the timeliness. Nobody wants to wait an unnecessary amount of time for appropriate testing or diagnostics, but this is particularly important when it comes to time-sensitive conditions, be they diagnoses like stroke or myocardial infarction or trauma, where we know that time to initial interventions makes a huge difference in terms of outcomes. Efficiency is really ensuring that there's a lack of waste in the care that's being provided. So really avoiding any unnecessary hospital stays, any unnecessary costs or testing that really are not associated with improved outcomes. And lastly is equitable care, really moving to standardization of care. When we see variability in care, it by definition means that some people are getting better care than others. It's variable. And so the goal of equitable care is really to remove any kind of implicit bias and ensure that we are following the same standardized pathways, regardless of whether that patient is male or female, regardless of their skin color, regardless of how much that they can afford to pay or the payer source, but really trying to move towards standardization and best practices. When we talk about quality, we have a framework that we often follow. This was set forth by Donna Bedian and colleagues, and really the idea is that within quality, you can't have the best outcomes unless you have both the key foundational structures to be able to provide that care, and you have clear processes or actions that will guide us to the best possible outcomes. Now, within every aspect of quality of care, we don't necessarily have the ability to change the resources that are available, so we have to work within the framework of our organization. And that means that sometimes we may not be able to have the most optimal design, but even within the design that we do have, what we're trying to do is optimize it to get to the best possible outcomes. We have really taken this on within the United States on a national scale and really tried to understand what our emergency care systems look like in order to deliver the highest quality of care, particularly for the pediatric patient. The Institute of Medicine provided a 3-part series or report that really highlighted some of the deficiencies or challenges that exist within our emergency care system to best meet the needs of children. And in this report, what we know and what has helped to guide us is that we know that While we have many robust children's hospitals or hospitals that are really dedicated to the needs of children, the great majority of children are actually seen in general emergency departments, where the majority of patients are in fact adult patients. In fact, children only account for about 20 to 25% of all patients within our emergency care visits. We also know that because of this, critically ill children may be seen somewhat less frequently. And when there are limited resources, there tends to be a prioritization of adult metrics or adult outcomes, which leads to very few resources that are really directed towards the needs of children. And because of this, we often see gaps in standardized structures or the day-to-day readiness to meet the needs of children. And subsequent to that, we see delays in the uptake of pediatric evidence-based guidelines or resources to drive optimal outcomes in children. Pediatric readiness really defines the structures of pediatric emergency care, or the structures that lead to the best quality of care and outcomes. Pediatric readiness is based on 7 key domains of infrastructure. And those domains are listed here. The first is ensuring that we have appropriate oversight, ideally in the form of administration and coordination of all aspects of pediatric emergency care, from equipment and supplies to policies and procedures to ongoing training and assurances. And they really are the foundational backbone to what we mean by pediatric readiness. These individuals are in charge with ensuring domain 2, which is that all of the staff within an emergency department are maintaining their pediatric knowledge, skills, and competencies, ensuring that we have a quality improvement program in place to be able to monitor the care that's being delivered, ensuring that there are pediatric specific policies, procedures, and protocols, making sure that there is steps or protocols underway to ensure safety for our pediatric patients, ensuring support services are in place to select the appropriate laboratory values and conduct the necessary radiologic studies. And lastly, that there are equipment, supplies, and medications in place, of course, for every age of child and therefore sized accordingly. What we've found in the United States is we undertook a national assessment to really say, well, what are the current pediatric capabilities within our emergency care system, i.e., what are the structures? Do we even have the baseline infrastructure in place to care for children? And we sent this out to every emergency department in the country based on the pediatric readiness guidelines that I just described. It was a comprehensive assessment. It went out to 5,000 emergency departments. We had a very high response rate in the most recent assessment with over 3,500 emergency departments responding. And what we found initially, and this was really helpful, is that the majority of emergency departments see fewer than 10 children per day. And this is really critical because it allows us to understand the resources that currently exist, the current landscape of how emergency care is being provided, and allows us to really hone in on the basic needs within those emergency departments, because that's where the majority of pediatric emergency care is taking place. What we found from this national assessment, which was initially conducted in 2013 and then again in 2021, is that there really are significant opportunities to improve the basic infrastructure to care for the pediatric population. In 2013, we found that the median score on a 100-point scale was 68.9. In 2021, we found the median score on a 100-point scale was 69.5. And not surprisingly, in those emergency departments that see high volumes of children, they were much more likely to have the infrastructure in place to meet the needs of that population, whereas those emergency departments that had lower volumes of pediatric patients, they were really struggling to prioritize these needs through basic infrastructure and guidelines. Not surprisingly, one of the items that we found from the pediatric readiness assessment is that having a quality improvement plan in place is associated with improvements in all other aspects of pediatric readiness to the tune of about 25 points on the 100-point scale. And this is adjusted, so removing any points for quality improvement. And this really had the ability to shift an emergency department's infrastructure, because when you're constantly looking at the quality of care that's being provided, you're able to identify gaps and therefore take strides to make improvements over time. Unfortunately, what we found is that only about 50% of emergency departments in the United States had a quality improvement plan in place to be able to look at specifically the needs of children. And so, subsequent to that, we've seen many scholarly reports demonstrating that there is a significant degree of variability when it comes to pediatric emergency care delivery. We see variability when it comes to imaging and radiation exposure, like head CT, decision-making around children with blunt head trauma. We see differences when it comes to resuscitation performance, be it cardiac arrest or septic shock. And we see differences when it comes to performance around other types of patient-centered outcomes, such as asthma, appendicitis, and the like. But we now know that structures lead to improvement in outcomes. And a number of papers have recently come out showing that pediatric readiness, the basic infrastructure to meet the needs of children, is associated with increased survival in kids. And this is a study that was initially published in 2021, and it looked at injured children across the United States and how their care related to the pediatric readiness score of the institutions in which they receive care. And what this study demonstrated was that when emergency departments have a high degree of readiness, in this case, scoring 93 or above on the 100-point scale, that the risk of death for critically injured children was about 50% lower than those children who were seen at other lower ready adoption emergency departments. This was an effort that was taken about 15 years ago, really looking at what measures can we look at for children. And you'll see of the 15 measures that were ultimately prioritized in this work, 6 of those measures were structural measures. They very much align with the pediatric readiness guidelines that we've described. 5 of the measures are process-based measures, and many of these you'll see have also been adopted into this next set of measures. And then 4 of the measures are really outcome-based measures, many that really focus on flow, medication error rates, length of stay. I will say that medication error rates we have found to be one of the most challenging items to get at because of the complexity and the variability of medication dosing for different conditions, and it's made this one particularly challenging. So in order to really get at measures for lower volume EDs, it's important to really think about the 4 phases of emergency department care. What does a patient go through? What is their experience when they enter the emergency department? And really thinking about this from the aspect that most children who present to the emergency department are undifferentiated, meaning they don't carry a sign that says, I have septic shock, or I have a sickle cell pain crisis, or I am in diabetic ketoacidosis. Rather, they present with a complaint of, I have abdominal pain, or I have a head injury, or I'm feeling agitated. And so we really wanted to look at the most common reasons why children present to the emergency department. And we found those here as being basic patient evaluation, for perhaps chronic complaints or acute complaints, depression, aggression, or suicidality, acute or active seizures, head injury, difficulty breathing or respiratory distress, and lastly, vomiting and dehydration. And that if we can focus on the foundational processes of care, that these will ultimately affect every patient who presents to the emergency department. And when we look at these common presentations, we wanted to look at how are we dealing with these in terms of assessment, interventions, diagnostics, and disposition. And ultimately, we were able to identify 28 key measures that can be used and adopted in any emergency department setting, but particularly in those lower volume settings. And you'll see the measures are shared here. The goal here was really foundational processes of care. So as an example, what % of pediatric patients have pain assessed? What % of pediatric patients have who are triaged at a higher acuity level have a full set of vital signs reassessed? What % of pediatric patients with head trauma have a Glasgow coma scale or a mental status, not just initial assessment, but reassessment? And are we aligning with evidence-based practice guidelines regarding which patients should receive head CTs? And this is just a few of the measures that are presented here. These are the second tier of those measures, really looking at bundles related to specific chief complaints: seizures, respiratory, vomiting, suicidality. And you'll see again that these are really foundational aspects of care. What % of patients who presented with seizure had a neurologic reassessment? What % of patients who are ultimately diagnosed with asthma or croup had steroids given, and what was the time to steroids being administered? What % of patients who presented with vomiting and dehydration were given an antiemetic, and what was the time to that antiemetic? And lastly, what % of patients were screened for suicidality? At least speaking from the perspective of what we've seen in the United States, we see that mental health has reached epidemic proportions. And unless we're screening, we're not able to identify these patients and really address their most acute needs. What we do know, though, however, is that measures alone may not be sufficient, and really creating the technologies, the tools to be able to assess performance. And because right now, for many of these measures, there are no gold standard thresholds of performance. And so what we've tried to do is create a open access quality improvement data dashboard or portal, where not only can we measure our performance over time, but we can begin to benchmark that performance. And so this is really just a diagram of what that flow would look like. Starting in the left-hand corner, emergency department would decide to look at perhaps every 5th pediatric patient that comes into the emergency department, extract certain key variables, enter that into a data system or a data portal, and it would immediately transform that data into any of these 28 quality measures and be able to show them how they're performing on each of those measures, but also importantly, how they compare to other emergency departments in terms of their performance. And we now have a global national dashboard that allows sites to participate in this. This is showing, 86 emergency departments participating all across the United States. And as we've worked over time, you see that these emergency departments have made extraordinary improvements in care being delivered, even over just really 1 year's time, where we're seeing improvements in ensuring that weight is only measured in kilograms, that pain is being assessed in the pediatric population, and that in those patients that are of high acuity in terms of triage are having vital signs reassessed at least once so that we can intervene quickly. In another talk that I'll be giving later in this series is focused on septic shock. And for more advanced EDs, they may undertake more advanced bundles, such as this septic shock bundle that's described here. And this was another national quality improvement collaborative, really focused predominantly on children's hospitals, higher volume centers. In this case, they looked at 40 hospitals where they implemented a pediatric septic shock bundle, where they tried to optimize recognition of septic shock, fluid management, and antibiotic therapy. And what they found is that there were significant improvements in overall survival and overall 3-day mortality for those centers that were otherwise compliant with the sepsis guidelines. And what they found, however, was that it didn't matter if their pediatric volumes were lower or higher. What mattered was that they were adopting clinical practice guidelines that were evidence-based, and that led to the best possible outcome. So while some of these measures may have been adopted initially in higher volume EDs, we know that even lower volume EDs, when we adopt these sorts of quality measures, that we can make enormous differences in terms of outcomes. This was another study looking at the evaluation between these sepsis care protocols and in-hospital mortality for pediatric sepsis. And again, looking at 3 steps within this pathway, antibiotics being administered, blood cultures being obtained, and intravenous fluids being provided, they found that certainly each of those individual bundles alone made a difference in terms of overall outcomes and survivability. But altogether, they made a much more significant difference in terms of outcomes. And so this is where we really start thinking not just about one single measure, but really bundling these measures to get to the best possible outcomes. And what we found is many EDs really are struggling to meet the needs of children because the majority of their patients are adults. And so these are some quotes that were obtained from qualitative interviews with general leaders, emergency department leaders in general hospitals. And they found that there was a lot of, challenges that they were facing. Here are some examples. Kids are just a black box mystery. So we just assign them all an ESI or emergency severity index score of 3, and they do okay. I need antibiotics. I'll be honest. I wish I had a faster response from our ED pharmacy staff. The emergency medicine physicians really hate automated alerts for sepsis. It's those advantages and disadvantages of being hooked into a general hospital. And if I want to give a gram, very easy. But if I want to give 450 milligrams, that becomes much more challenging. And I've also given a more generous dose of ceftriaxone in order to just meet a full gram. So these are the sorts of experiences that many leaders in emergency departments are facing. And so the persistent gaps that we know is that PIM measures have not been widely adopted, but they exist. And I encourage you to think about how can we really pull these measures and begin to adopt them in our emergency department. There are no gold standards or thresholds for performance on many of these measures because we're just starting to move towards standardized measurement. We know that the majority of emergency departments do see lower volumes of patients, and that even in these places, ongoing quality improvement efforts provide a mechanism to measure, reflect, and improve pediatric emergency care delivery. There are many, many strategies and resources that are available to support evidence-based clinical practice, but real-time performance dashboards, either specific to a healthcare system or that are much more broad at a regional, state, national level, can really help with benchmarking and help drive continuous quality improvement. And so with that, I just want to say thank you so much for the opportunity to speak about quality measurement in pediatric emergency care, and I hope this was helpful.
Thank you very much, Dr. Kate. Our next speaker, please. The question, as it was announced early, you can keep your question in the inbox box for question and answer, and we promise you we will answer all these questions during the break. Now, our next speaker is Professor Kathleen Adeliges. She's a professor in pediatrics, emergency medicine, and she is a principal investigator, Colorado EMS for Children State Partnership Program, Emergency Department, Children Hospital, Colorado, University of Colorado School of Medicine. Dr. Kathleen Adeliges is a professor of pediatric and emergency medicine at the University of Colorado School of Medicine in Aurora, Colorado, and she works as a pediatric emergency medicine at Children's Hospital, Colorado, and as an emergency medical services physician for 2 EMS agencies in Colorado. Dr. Adeliges will talk about EMS for children, models, and challenges. Okay? Claude, you can start, please.
Kathleen Adeliges, and I'm a pediatric emergency medicine physician and EMS physician at the University of Colorado and Children's Hospital Colorado in Aurora, Colorado. I'm very proud to be invited to present at this conference, and for the next 30 minutes, I'm going to discuss EMS for children, models, and challenges. As objectives for this talk, I'm going to spend some time covering the background on the development of the modern system of emergency medical services, and also cover the different models of EMS care. And finally, I'll conclude with some of the challenges and future directions in the EMS care of children. Let's just set the stage with a case. There's a 6-month-old female with cough and congestion rhinorrhea for 2 days, who then turns blue. The parents start rescue breaths and they call 911, which is the universal number for emergency response in the United States. EMTs arrive with firefighter paramedics who find the baby awake and alert upon arrival. The baby is transported by a basic life support crew to the hospital for continued evaluation and becomes apneic during transport. The emergency medical technicians then initiate bag mask ventilation in the field. What is emergency medical services? An EMS system is one comprised of organizations, individuals, facilities, and equipment whose participation is required to ensure the timely and medically appropriate response for each request for prehospital care and medical transportation. It truly is an intricate system that sits at the intersection of public health, healthcare, and public safety. The history of EMS goes far back, originally reported by historians during the Napoleonic Wars. Baron Dominique Jean Leray is credited with developing the first ambulance system. He had horse-drawn, quote, flying ambulances, end quote, that were dispatched to deliver medical care in the field, and it emphasized the role of hemorrhage control, rapid transport, and medical care during transport. It was developed on the face of frontline battlefield hospitals. And so as you can see, EMS care really was started to address the need for trauma management. In the United States, however, there was a movement to recognize the current epidemic of injury in the modern US. In 1966, the National Academy of Sciences published a white paper called The Accidental Death and Disability, the Neglected Disease of Modern Society. As noted, injury was seen as an epidemic. Ambulances were recognized to be poorly designed and poorly equipped, and responders were poorly trained. And this paper came out making 29 recommendations to improve care for the population as a whole. Following this, there was the first nationally recognized emergency medical technician program for training established. And the current design of the modern EMS system is based on the epidemiology of modern disease, specifically trauma, cardiac care, and stroke. The EMS system is very complex, and it includes issues around access to an emergency response through accessing through a central phone and dispatch, the presence of first responders, the provision of basic life support, advanced life support, and then transport either through on the ground or through air medical transport. The destination of these patients include the type of patient, whether they're a child, whether it's a patient with an illness, injury, or ingestion. And the destination includes emergency departments, possibly the transfer for specialty care, with ongoing considerations of patient rehabilitation, and even the components of prevention, awareness, and public education. And this cycle continues all the while with the hopes that every time a patient becomes injured or ill in the community, there is a ready and available EMS system that has prepared and has the right resources and tools to care for them. EMS delivery models are quite diverse, and we often use the adage, if you've seen one EMS system, you've seen one EMS system. And EMS systems here in the US are fire-based or hospital-based. However, there are multiple other models, including the presence of a private service or even a public utility model. EMS providers themselves are also a very diverse group, There are paid EMS providers. There are volunteer EMS providers. EMS providers can be unionized. There are EMS providers based in wilderness areas and EMS providers specifically trained and on call for disaster response. EMS care also is variable and has different components and characteristics based on whether it's located in an urban environment or in a rural environment. Urban EMS systems are characterized by having shorter response and transport times, but a very high demand. The ability to provide both advanced life support and basic life support, often the presence of paid professionals, and complex decisions based on the type of condition that EMS is responding on, with decisions around whether to go to a cardiac or stroke center, a trauma center, and even decisions around obstetrics and pediatric care. This is in contrast to rural EMS agencies who have often increased response and transport times, have to deal with challenging terrain and access issues, being able to reach the patient who may be injured far away from where they're based. There's the issue of infrequent calls, particularly when we consider children. Radios and other communication tools can often be out of range or even offline. There is the need to consider advanced transport to a regional facility to expedite care, and also the need to consider whether or not air ambulances need to be mobilized or activated for transport. EMS structure is different globally, and there are two primary structures that are most recognized: the Anglo-American structure and the Franco-German structure. The model of the Anglo-American EMS system is the use of emergency medical technicians and paramedics as your first response. These practitioners operate on a delegated practice model with physician oversight that is distant. There's a primary focus on transport and destination, a quote, scoop and run mentality, where patients are not necessarily stabilized before being loaded into the back of the ambulance and medical care is delivered en route. The Anglo-American system is financially supported by municipalities or actually through billing for direct care. As mentioned, it can be protocol driven, and the physician role is really limited to off-site medical direction, often with online medical control from receiving hospitals without physicians in the field. This is in stark contrast to the Franco-German model, which tends to be physician staffed. There's more of a focus of scene stabilization, a quote, stay and play model instead. It's often financially supported through a national healthcare system, and the care is predominantly with a focus on treat and release, alternate care, and or deferral of transports. In many countries around the world, with EMS may not actually even have opportunity for patients to have response in the field and be transported by an ambulance, with most care being sought by individuals being transported by private vehicle only. In preparation for this talk, I did do some research on the Saudi Arabia EMS system and found this recently published article in the Annals of Saudi Medicine. This article really detailed some of the characteristics and distribution of emergency medical services in Saudi Arabia. Some of the findings described were notable. The EMS provider to population ratio is very low, approximately 1 EMS clinician to almost 4,000 members of the population. And this results in response times that are much longer, 13 minutes versus the standard 8-minute that has been generally accepted in most EMS systems around the world. Only 3.5% of EMS clinicians are female, and this means there are some challenges when caring for women who require emergency response and don't have a guardian present. The majority of EMS providers are basic life support only, and the article finished with a call to expand the workforce, really to be prepared for disasters and a growing population, with even considerations in the growing tourism trade within Saudi Arabia. As part of this, I was able to find this article and on the new education of female EMS providers to meet this demand. And I'll take this moment to transition to discussing EMS professional scope of practice and some of the other design elements, including dispatch and tiered response. So EMS systems have divisions in terms of the life support, as well as the tiered type of response. So there's basic and advanced life support, and these have different characteristics. Basic life support is really limited to the provision of cardiopulmonary resuscitation, the use of automated electronic defibrillators in the field, splinting, and really the transport of patients. Advanced life support provides the ability to do advanced airway management, EKG interpretation, and medication administration in the field, so there can be more definitive care and route to a receiving facility. Single and two-tiered systems use the presence and availability of both basic life support and advanced life support in the field. In a single-tiered system, usually there is advanced life support globally provided for all responses. This is difficult to staff often because of the need for very high-level providers being available all the time. There can be some skill dilution for paramedics because most of the calls that they run on may not necessarily require advanced life support. There's often shorter definitive response times, but overall increased utilization. In contrast, a two-tiered system uses basic life support and advanced life support based on the dispatch information received and the decision around what kind of care in the field might be necessary. It results in more complex dispatch decisions, but could be a better use of resources and skills. Finally, the longer time for an ALS response could occur in the event that BLS requires calling for backup. EMS provider scope of practice is divided into several tiers, with the first tier and the most common and largest group of EMS clinicians being the emergency medical technician. The typical training is between 100 and 110 hours, and this training involves some basic review of anatomy and physiology, basic life support skills, history and exam skills, very basic airway management, spinal motion restriction and splint application, and the assisted medication administration of medications that patients administer to themselves, including glucose and or inhalers such as bronchodilators and or intramuscular epinephrine in the event of anaphylaxis. Advanced emergency medical technicians have a broader scope of practice and more hours devoted to their training, up to 300 to 4 hours of training. They have more advanced airway management skills and advanced procedural skills, including the placement of intravenous lines and intraosseous lines. They are trained on ECG interpretation. They have an expanded scope of medications, and they also have the ability to administer pain medications, particularly opiates, for good and better pain control in the field. And this is in contrast to the paramedic, which is really considered an allied health practitioner. The training of the average paramedic is between 1,000 and 2,000 hours. Paramedics have training in advanced triage, a very broad scope of advanced airway management, including the surgical airway, continuous positive airway pressure administration in the field, and pleural decompression, interpretation and intervention for 12-lead ECGs, including the management of a cardiac or myocardial infarction or cardiac arrest, orthopedic emergencies and newborn resuscitation, central line management, and even the administration of medications that require infusion pumps are within the paramedic scope of practice. And finally, comprehensive pharmacologic intervention and advanced burn and ingestion management are also part of that scope of practice. Given the different scopes of practice of EMS clinicians and the method of dispatch and the presence of a single or two-tiered system, EMS decisions also have to occur in the system of a regionalized healthcare. So imagine a patient is injured on the scene. EMS providers have many decisions to make, including whether to treat and release the patient, whether to go to the closest community hospital or an urgent care center, which may have to transfer to a community hospital, whether to go to a closer community hospital that may have more capacity, such as a stroke center, or whether to even cross over into other municipalities to a community hospital or even to a tertiary care facility. These EMS decisions are complex, and EMS clinicians may not necessarily decide to transport to the closest facility when, one, they need to take into consideration whether it's appropriate to the needs of the patient, if the patient might require specialty care, if the patient actually requests a different destination, or if the closest facility is actually overwhelmed with its current patient load and actually requests a diversion. So with that, we'll pivot to discuss some of the issues around the pre-hospital care of children. First, I'll cover the epidemiology and then some of the other complexities of pediatric care. Pre-hospital pediatric epidemiology is divided almost equally between medical and trauma. Most of the medical care that EMS provides to children include the management of respiratory illnesses and/or seizures. However, there's a growing group of children that are medically complex and technologically dependent. And then there's also a growing rate of EMS calls for behavioral health emergencies. For trauma, the majority are minor, and the type of injury will vary based on age. The recognition and management of non-accidental trauma poses a specific challenge to EMS, given that most victims of non-accidental trauma may be nonverbal or pre-verbal, and often the short period of time that EMS interfaces with a child and their family may make it difficult to get adequate history and evaluation to detect non-accidental trauma. That being said, most of the diagnoses of non-accidental trauma also does involve X-rays and subspecialists. These are things not available to EMS providers in the field. EMS and pediatric behavioral health emergencies are a growing issue. In many communities in the United States, the behavioral health emergencies have now surpassed trauma and respiratory as a single cause of an EMS activation. And despite the increasing need and frequency and incidence of adolescent and child behavioral health emergencies, there is still very limited mental health resources for children. There's also very limited data on how EMS should support the care of acute agitation in children. And what's most important is that there's EMS crew and patient safety that is maintained during the transport of a combative patient. The medical legal issues around the impaired adolescent also require specific care and attention, and protocols really need to kind of focus on this. And EMS care of children with medical complexity, or we call CMC, is also a growing population. There is an increased need for medical emergencies and transport to specialty centers among children with medical complexity. And these children provide unique challenges for transport, including their use of specialized equipment. The need for interpretation of their baseline often requires the presence of a caregiver, and some of the emotional and behavioral health challenges, as I just mentioned. The most common emergencies include the presence of seizures, or perhaps a ventricular peritoneal shunt may be malfunctioning. These children may have complex heart disease and specific medications. They may have airway obstruction if they have a tracheostomy. They often have chronic lung disease and/or can have metabolic crises. And there's a limited ability for basic EMS and basic life support to care for some of these more complex conditions. The state of pediatric emergency care has been something that is growing in complexity and in flux. Our EMS and general community hospitals have historically not been well prepared to care for children. On the hospital side, about 80% of children will present to a non-pediatric specific facility, and the average emergency department in the US sees 13 children a day. There are known gaps in the overall day-to-day readiness for children, including imaging and radiation exposure protocols, patient-centered outcomes, and the pediatric overall resuscitation performance. On the EMS out-of-hospital side, only 7 to 13% of all EMS patients are children, and most EMS agencies see less than 8 children per month. And the known gaps in the out-of-hospital environment include the lack of standing protocols, the lack of pediatric equipment, and the lack of universal education requirements for licensing of EMS clinicians in states and territories. These challenges were described in a series of reports by the Institute of Medicine published in 2006, almost 20 years ago. So there's been an effort to address them through pediatric readiness initiatives that have been happening in the US for the last several decades. For pediatrics, the average challenge is really a numbers game. If we think about the total of 1,000 EMS calls, only 10% are going to be children. Only 100 of those children are actually going to be critically ill, so only 1% of 1,000 EMS calls. And then finally, only one child may actually really require any advanced airway management or other care. The average EMS professional intubates only one child every 3 to 4 years. It is almost impossible to maintain skills in this area. So we are now in an era of working on pediatric readiness for EMS across the United States. And this is the National Pre-Hospital Pediatric Readiness Project, which I'm fortunate enough to work with both Dr. Marion Gachet-Hill and Dr. Kate Remick, two of this conference's other speakers on this critically important work. The Pediatric Readiness Project in EMS began with the publication of a joint policy statement by 5 organizations that have focused on what EMS agencies should be doing to be ready to care for children. This joint policy statement gives guidance on and recommendations around the need for planning and collaboration between EMS and medical professionals, public health experts, and families, the need for pediatric-specific direct and indirect medical direction for EMS, the call for EMS to have considerations of children and families in emergency preparedness planning, specific recommendations around pediatric-specific education, including the unique developmental aspects of children, and the pediatric equipment and supplies always being available. The joint policy also gives guidance on practices EMS can put into place to reduce pediatric medication errors, pediatric-specific measures for quality improvement and quality assurance, the recommendation for EMS agencies to track pediatric patient-centered outcomes, to provide pediatric and family-centered care and culturally competent care, and finally, recommendations around the safe transport and destination considerations for children. There is a call for EMS agencies to have what are known as pediatric emergency care coordinators. This first call came in the Institute of Medicine report published in 2006, and there was guidance and follow-up in by the National Association of EMS Physicians and their publication, a resource document recommending the coordination of pediatric care in EMS systems. The presence of a PEC highlights the importance in EMS, the importance of leadership in EMS systems. PECs are incorporated into EMS as either a single provider or a team of providers. They oversee the system-based care of pediatric patients. They promote integration of pediatric elements in day-to-day services and disaster planning. And they serve as a really critical pediatric healthcare liaison. The Pre-Hospital Pediatric Readiness Project has a checklist and a toolkit to support EMS in their efforts to be pediatric ready. And this QR code here on this slide brings you to the toolkit and the website where this is available. The PPRP toolkit has over 200 resources available to EMS agencies for the provision of pediatric ready care. It does include an orientation video for new users, and many of the tools on the website are multimedia in nature, including curricula for training, template protocols, quality and process improvement measures for pediatric emergency medical care in the field. And finally, we will be embarking next month on the first national assessment of pre-hospital pediatric readiness. This assessment will be conducted over the months of May, June, and July of 2024. And EMS agencies will be completing this assessment and getting a score on how ready they are to care for children. This score will allow them to do a self-assessment and identify gaps and redirections. The score is weighted based on various things that have been developed by experts in terms of what is most important for pediatric readiness. When EMS agencies complete the assessment, they will get a gap report with their overall score, and they'll also get information on specifically what they are doing and what they are not doing. And this will be accompanied by important statements that will provide guidance to EMS agencies on why certain things that they may not be doing are critically important to institute in their agency. And so with that, I'll conclude. As a summary, emergency care for children is complex and difficult given the low numbers of pediatric visits and out-of-hospital encounters that EMS agencies have with children. And our work across the country here in the US to promote pediatric readiness, we're very excited to see some of its future outcomes, and perhaps we'll be able to bring that to future international conferences of pediatric emergency medicine meetings. Thank you so much.
Thank you very much, Professor Kathleen. Our next speaker is Dr. Timothy Dribbin. Dr. Dribbin is an associate professor of pediatric emergency medicine at Cincinnati Children's Hospital Medical Center and the University of Cincinnati Department of Pediatrics in Cincinnati, Ohio. He is a nationally renowned anaphylaxis expert who seeks to optimize the community and emergency department care of children and adults with anaphylaxis. His ongoing research efforts include a 30-center retrospective anaphylaxis study conducted across North America emergency departments, and a 3-center prospective emergency department anaphylaxis study that integrate clinical data and serial biomarkers to enhance diagnostic and therapeutic decision-making. Dr. Dribbin is a co-chairing an international study to develop revised anaphylaxis clinical criteria to support anaphylaxis recognition and management. His research has been funded by the National Institute of Health, has been published in leading pediatric and allergy journals, including the Journal of Allergy and Clinical Immunology, and has been featured in national health care product podcast and news outlet. Dr. Dribbin will talk about the many presentation of anaphylaxis in children. Dr. Dribbin, you can start, please.
My name is Tim Dribbin. I'm an associate professor of pediatric emergency medicine at Cincinnati Children's Hospital Medical Center. The title of my talk is The Many Presentations of Anaphylaxis. It's an honor to speak with you today. My funding is shown here. I have no conflicts of interest to report. The objectives of the talk are to review the epidemiology of anaphylaxis, the diagnosis, management, the different clinical courses of anaphylaxis, and key discharge care. Before we begin, a little background about the incidence of anaphylaxis. Our group has shown that from 2008 to 2016, there were over 400,000 emergency department visits for anaphylaxis in the U.S. And during this time, visits doubled among all patient ages, including in children and adults, and tripled among children. Here at Cincinnati Children's, we see almost one patient a day who has anaphylaxis. The most common triggers of anaphylaxis, especially in pediatrics, are foods: peanuts, tree nuts, milk. Medications are another trigger, as well as insect stings. We don't see a lot of insect sting-induced anaphylaxis here, but in other parts of the world, it's more common. Patients with mast cell activation disorder or hereditary alpha-tryptopenia are at heightened risk of anaphylaxis. And then viruses can trigger anaphylaxis, and then in up to 20% of reactions, the precise etiology of what caused the reaction may be unknown. Unfortunately, there's limited data to inform guideline recommendations, including diagnostic and management, as well as therapeutic decision-making. This is because there's a lack of prospectively obtained data to inform management, and pathogenesis data is predominantly based on mice models or other animal models. There's also been no randomized controlled trials of systemic steroids or adjunctive therapies that are commonly used in clinical practice. Thus, there's significant variation in the use of these therapies based on data that we have obtained. In 2006, the National Institute of Allergy and Infectious Disease, Food Allergy and Anaphylaxis Network established these landmark clinical criteria for diagnosing anaphylaxis. The goal of the criteria was to standardize the diagnosis of anaphylaxis across different clinical settings. However, it's important to know that they are not diagnostic criteria, as there's no gold standard diagnostic test for anaphylaxis. They're also not prescriptive epinephrine treatment recommendations. The guidelines clearly state that there are patients who may not fulfill anaphylaxis criteria who would be prudent to give epinephrine, such as a patient with a history of severe, life-threatening anaphylaxis to peanuts who accidentally is exposed to peanuts and then develops whole-body urticaria. In that patient, even if the patient does not yet have multi-system involvement, it would be prudent to give the patient anaphylaxis. These are the 2006 NIAID-FAN clinical criteria for anaphylaxis. They state that anaphylaxis is highly likely when any one of the following three criteria are fulfilled. This is important because the criteria are designed to help clinicians establish the likelihood that a patient is having anaphylaxis and not whether they are truly having anaphylaxis. This means the criteria do not have perfect sensitivity or specificity. However, they have been validated both retrospectively and prospectively. The first criterion defines anaphylaxis as a patient who has the acute onset of an illness with skin mucosal involvement and one of the following, either respiratory compromise or reduced blood pressure. This would apply to situations in the emergency department where it's unclear what the trigger was. The second criterion is probably what is most commonly applied in emergency department situations, and is widely known as having two organ systems involvement. For this, patients, if they're exposed to a likely allergen, they have to have at least two of the following organ systems: skin mucosal, respiratory, cardiovascular, or persistent gastrointestinal symptoms. Now, it's important to note that the criteria say persistent gastrointestinal symptoms. However, like many facets of clinical care, determining what persistent is up to the clinician. But there's no hard or fast definition of what persistent is, and there's no binary cutoff to say persistent versus non-persistent. However, it's important to know that when these criteria were developed, it was intended to make sure that gastrointestinal symptoms were not brief, such as a patient who just has one episode of vomiting. Most clinicians would say that that patient would not fulfill anaphylaxis criteria if they also have skin mucosal. The vomiting would have to be more than one episode. And then the last criterion, is probably the most uncommon, would be that a patient would fulfill anaphylaxis criteria if they have a known allergen and then after that exposure to that allergen have reduced blood pressure. So just isolated cardiovascular involvement. This is uncommon, but it has been shown to happen, especially in the perioperative setting. In 2020, the World Allergy Organization proposed modified anaphylaxis clinical criteria. They're very similar to the NIAID-FAN criteria. Instead of three criteria, there are two criteria. And then, unlike the NIAID-FAN, these criteria also state that if a patient develops isolated respiratory involvement, either bronchospasm or laryngeal involvement, after a known allergen exposure, that patient would likely have anaphylaxis. There's an important footer, though, with this criterion that says that isolated respiratory involvement does not include patients who develop isolated respiratory symptoms after aerosolized or ingested allergens. So if a patient's around a pet and they're exposed to pet dander and they develop wheezing, that would be an inhaled or aerosolized potentially, and that would not fulfill anaphylaxis criteria. That patient instead should be treated like an allergen-induced asthma exacerbation. However, if a patient were to eat, let's say, a peanut and then develop laryngeal involvement, so stridor, that would fulfill anaphylaxis criteria. The same if a patient was stung by an insect and they had isolated wheezing, that patient would also likely have anaphylaxis. However, it's important to note that it's exceedingly uncommon for patients to have isolated respiratory symptoms without other more common features, such as skin or mucosal involvement. I just want to reiterate again that anaphylaxis is a clinical diagnosis. Clinical criteria, again, designed to help you determine the likelihood that a patient is having anaphylaxis and not whether they are having anaphylaxis. The decision about whether someone has anaphylaxis and whether to give the first-line therapy epinephrine is up to the treating clinician. Our group has published a severity grade system to assign the severity of acute allergic reactions. And what this figure shows is that acute allergic reactions, including anaphylaxis, occur along the severity spectrum from more mild reactions to life-threatening or potentially fatal reactions. So just like other conditions that we treat in the emergency department, anaphylaxis is not one size fits all. A lot of reactions are less severe, while there are the rare reactions that if not treated emergently and with aggressive resuscitation, the patient may die. Unfortunately, there's not a significant role of obtaining labs in anaphylaxis. Mast cells and basal cells are key cellular mediators in anaphylaxis, and they release potent mediators such as histamine and tryptase. Tryptase can be obtained in our clinical lab. It does not result quickly. Histamine can be obtained both plasma and urine, but those are send-out labs. Elevated tryptase levels have been associated with hereditary alpha-tryptosemia or mast cell disorders. The positive predictive value of an elevated serum tryptase is high, though. It's up to 93%. Unfortunately, though, the negative predictive value is quite low at 72%. Australian Emergency Department study, which was a prospective study, did, though, find that elevated levels of tryptase were associated with increased reaction severity among patients with food and other causes of anaphylaxis. A landmark study published by Dr. Hugh Sampson in 1902 in the New England Journal of Medicine showed a case series of patients with fatal or near-fatal anaphylaxis. And in this study of patients with food-induced anaphylaxis, the tryptase level in quite a few patients was actually normal. And this has been shown, and these findings have been replicated in other studies showing that tryptase levels in food-induced anaphylaxis can be normal. The American recommendations, so practice parameters from 2020, said there's no routine need to measure tryptase. The European recommendation said that there's a very low certainty of evidence and that there may be a role in obtaining tryptase, especially if you can get a baseline level. However, in the emergency department setting, obtaining tryptase really is not helpful in the acute setting, given that it will take time to result, and the results will not come back in time to influence management decisions. However, if the diagnosis is uncertain or if the patient's going to follow up with an allergist, it may be helpful in some situations to obtain a tryptase, especially if the clinician is uncertain that the patient had an anaphylactic reaction. So there is a future need to obtain different biomarkers that can be obtained quickly and readily in clinical care to influence not only helping influence diagnosis of whether patients are having anaphylaxis, but also to inform other management strategies, including whether to give epinephrine and to inform how long to observe patients to monitor for recurrent or persistent symptoms. Key point with the treatment of anaphylaxis, epinephrine is the first-line treatment. It is given intramuscularly, 0.01 mg per kg, up to a max dose of 0.5 milligrams. Common auto-injector dosing is 0.15 milligrams or 0.3 milligrams. We do here in the U.S., through the product IVQ, have a 0.1 milligram auto-injector. However, some insurance companies here will not cover that. For patients with refractory anaphylaxis or anaphylactic shock with respiratory failure, though, starting a continuous epinephrine infusion is essential. However, that requires appropriate cardiovascular monitoring and for the clinician to be experienced with starting and titrating an epinephrine infusion. This is an important figure that just shows epinephrine dosing and the influence of patient weight on the proportion of epinephrine dosing. Along the x-axis is weight in kilograms, and along the y-axis is the proportion of the target 0.01 mg per kilogram dosing. And as you can see, as patients exceed the 15 kilogram dose, 15 kilograms, the proportion of correct epinephrine that they're receiving goes down. So by the time they near 29 kilograms, they're getting significantly less epinephrine in mg per kg than they should receive. The same is once they exceed 30 kilograms, if you're using a 0.3 milligram auto-injector, they are not receiving anywhere near 0.01 mg per kg. This just raises the point that clinicians need to be attuned that for patients between 15 kilograms and 30 kilograms, if using an auto-injector, that the patient may need multiple auto-injectors, and the same for very obese patients, that are 120 kilograms, that just one single dose of 0.3 milligrams may not suffice, and the patient may need 2 doses. That may be because of the nature of the reaction, but it may be a weight relation as well. Adjunctive therapies, like I had said previously, are commonly used. These include antihistamines, H2 receptor antagonists such as famotidine, systemic steroids, either methylprednisone, prednisone, dexamethasone, inhaled bronchodilators, racemic epinephrine, and fluid boluses. Like I said before, there are no randomized controlled trials for these therapies, so the use of these therapies is based on data from mainly observational studies, many of which are retrospective studies with significant biases. However, it may be prudent to use some of these therapies based on targeted signs and symptoms. Antihistamines may be helpful for treating skin or mucosal involvement, H2 receptor antagonists for those patients with gastrointestinal involvement and sometimes with significant urticaria. Systemic steroids may be effective in patients with a significant asthma phenotype, as those patients who continue to wheeze despite receiving intramuscular epinephrine, or those patients with refractory anaphylaxis. The same can be said about inhaled bronchodilators, that after a patient is appropriately treated with epinephrine and they continue to wheeze, it may be prudent to trial inhaled bronchodilators. Racemic epinephrine may be an option for patients with signs of upper airway obstruction. However, you would never want to use this therapy instead of using intramuscular epinephrine. And for patients with upper airway obstruction, every attention by the clinician needs to be paid to whether that patient may need to be intubated in case that their airway progresses to go from partial to complete airway obstruction. Fluid boluses should be strongly considered for patients with refractory anaphylaxis and shock, given that there may be a lot of third spacing as well. The 2020 practice guidelines said that antihistamines and glucocorticoids, like I said, should not be used to prevent biphasic anaphylaxis. However, the certainty rate of this evidence is still very low. In terms of which antihistamine to use, whether diphenhydramine or a second generation, such as cetirizine does have a longer duration of action, up to 24 hours. So that can often be preferable because patients may have recurrent urticaria that can be distressing. So it's nice to have a medication that lasts longer in case they are to have recurrence of those skin or mucosal findings. Specific to the management of refractory anaphylaxis, these are the sickest of the sick. Refractory anaphylaxis probably occurs in less than 5% of reactions. These patients have to go to be admitted to an intensive care unit where they can undergo advanced cardiopulmonary monitoring and resuscitation. These patients frequently require continuous epinephrine infusion, and this is preferable because it can be titrated to effect. These patients frequently also require aggressive fluid resuscitation and potentially inotropic support. And then every attention also needs to be paid to their respiratory system. Patients may have significant bronchospasm or lower airway obstruction, but they also may have upper airway obstruction that necessitates early intubations if there's signs of impending respiratory failure. And now I want to discuss the different anaphylaxis courses. Anaphylaxis is a dynamic condition where patients frequently have symptom resolution, either after one dose of epinephrine, and sometimes patients even have symptom resolution before arriving at the emergency department, even if they don't receive epinephrine. Some patients will have what are called persistent anaphylaxis, where signs and symptoms of anaphylaxis may last for at least 4 hours. And then there are those patients, like I said, that have refractory anaphylaxis. And this is to note those patients that, despite receiving multiple doses of epinephrine, have persistent symptoms. We define refractory anaphylaxis as those patients who need 3 or more doses of epinephrine or started on an epinephrine infusion to manage their symptoms. And then biphasic anaphylaxis is classically described in the literature as a recurrence of anaphylaxis signs or symptoms after an asymptomatic period. Initially, reports about the prevalence of biphasic anaphylaxis were up to 20% of reactions. However, newer data that uses more consistent definition shows that biphasic anaphylaxis probably occurs in 5% of patients or even less. What are potential risk factors for biphasic anaphylaxis? Again, data from this is mainly from retrospective studies, observational studies. Hypotension has been shown repeatedly to be a risk factor for biphasic anaphylaxis, and that's why those patients who have hypotension usually warrant either ongoing or prolonged observation or admission to the hospital to monitor for biphasic reaction. Also, there's been associated with delayed epinephrine administration as a risk factor, those patients with wide pulse pressure, wheezing, history of asthma, and then also an unknown trigger. The 2020 U.S. anaphylaxis guidelines that extended observation is reasonable for those patients who need more than one dose of epinephrine, and for those patients who have risk factors for biphasic anaphylaxis. However, like a lot of the data, the certainty rating of this evidence was very low. Back, though, to what I said earlier, is that anaphylaxis occurs along a severity spectrum, and thus it's essential to tailor observation periods based on how sick the patient is, including how severe their signs or symptoms are, and to include potential other risk factors for bad outcomes. This is unpublished data, so it has yet been peer-reviewed, but we conducted a 30-center retrospective study that included over 5,000 patients, and we wanted to look at how long patients should be observed using the time from first epinephrine to last dose epinephrine based on initial reaction severity. And what we found is for patients without respiratory or cardiovascular involvement, 105 minutes was an optimal observation period. For patients with respiratory but no cardiovascular involvement, 109 minutes was an optimal observation period. And for those patients with cardiovascular involvement, which you can see was uncommon with only 495 patients having cardiovascular involvement, 161 minutes was the optimal length of observation period. Again, this data is unpublished and should not be used to influence clinical care, but it does show and confirm what is clinically intuitive, that patients with less severe reactions can likely be observed for shorter periods of time than those patients with more severe reactions. Now I want to move on to how to manage patients who are going home from the emergency department. Given that there is a risk, even though it's a low risk, of patients developing recurrent reactions when leaving the emergency department, it's essential that they have epinephrine auto-injectors to treat those reactions. Additionally, patients may have allergen re-exposure, which may result in a new reaction. Auto-injectors come in twin packs, and that's because up to 10% of reactions necessitate at least 2 doses of epinephrine. It's also essential to counsel patients and caregivers to avoid allergens, and also to provide them with an anaphylaxis action plan. This can be used as an educational modality to teach them about the indications for when to use epinephrine auto-injectors, and as a tool during potential subsequent reactions for patients and caregivers to use to make determinations about whether to give epinephrine. It's also essential for patients to have allergist follow-up. Allergists can help identify culprit allergens and also discuss whether patients would be candidates for different therapeutic options to mitigate their risk in the future. In summary, anaphylaxis is a clinical diagnosis. There's no gold standard diagnostic tool, and clinical criteria, while helpful, should never replace clinical judgment. That also means that the determination of whether to administer epinephrine should be up to the treating clinician. And usually there's very little downside of giving epinephrine if there's a high likelihood that someone has anaphylaxis. For patients that have persistent or recurrent symptoms, clinicians need to administer repeat epinephrine doses. And for the sickest of the sick, those patients with refractory anaphylaxis or anaphylactic shock, it's wise to start a continuous epinephrine infusion and titrate that to effect. It's also helpful to tailor management strategies based on reaction severity. This includes the use of adjunctive therapies, as well as how long to observe patients to monitor for persistent biphasic reactions. And also, when patients do go home, although it's unlikely that they're going to have recurrent reactions when they leave, it's important that they receive high-quality discharge care. This ensures making epinephrine auto-injectors readily available, counseling patients on allergen avoidance, using anaphylaxis action plans as a way to educate patients and caregivers, and also ensuring that patients have follow-up with the allergist going forward. Thank you very much. It's been an honor to speak with you today. Have a great day.
Thank you very much, Dr. Tim Ribbon. Now we will have a break for like 10 minutes. I just would like to emphasize for those who keep asking actually about do we have to register? And I noticed that they keep registering writing their name, their Mumaris Saudi Council number, their email and everything. You don't have to. Once you enter the Zoom, automatically it will calculate how long you spend the day of activity. And based on that, you have to complete 70% to get the certificate of the 3 days. Okay? We will collect now the question, and you can just enjoy your break, like for 5 to 10 minutes, and then we will go to the next group of lectures. Thank you very much. Khulud, you can stop recording till I tell you, please. Just put the, yeah, just keep it. Don't start till I tell you, please.
Is going to talk to you about BRUE. Can BRUE or brief resolved unexplained events, can these be safely discharged home? And I'm professor of clinical emergency medicine and pediatrics at the David Geffen School of Medicine. I practice at Harbor UCLA Medical Center clinically, and I'm the interim CEO at the Lundquist Institute for Biomedical Innovation. So let's go ahead and get started. I have nothing to disclose. And today I'm going to focus on the transition from ALTI to BRUE. And this, it turns out it's significant. And this practice guideline came out in 2016, but everybody is still, you know, evaluating what the issues are, especially in the pre-hospital setting, as well as in the hospital setting in terms of the implementation of these new guidelines. Here is the algorithm that was published by the American Academy of Pediatrics, and you can see it's somewhat complex, but I will break this down. It is really not as challenging as this algorithm might suggest. First of all, the key thing is this a brief resolved, okay, unexplained event in a child under 1 year of age? And I'll talk about what that is in a second. If the child is not well appearing, they have abnormal vital signs, cough, respiratory distress, fever, then it's not a BRUE, it's something else. Okay, now we used to characterize all of these things as ALTIs, and so they were really sick kids, and it was oftentimes the children that did not have had a brief event and otherwise did not have any signs and symptoms got an extensive workup, and we know that that is not necessary. And so let's kind of work through this. So any infant under 1 year of age that is sick with fever, cough, respiratory difficulties, etc., needs an evaluation in ED, and a determination is made whether the child is admitted or not. But we're now abandoning the term ALTI, and we're using brief resolved unexplained event. So if you characterize an event as sudden, typically it's under a minute, and now resolved. So it includes cyanosis, absent, decreased, or irregular breathing, marked change in tone, and altered responsiveness. If they had one of those, but it was brief and is now resolved, okay, then it is a BRUE. If you notice, choking is not there because there are so many kids presented with choking, and it can be a higher risk, especially for young infants and those that it's actually, choking is actually very, very common. And some of these kids, especially with feeding, that would get a full workup. So it is now not considered a criteria for BRUE. They need to be evaluated, and a decision is made on what type of intervention would be done. So the key thing is well appearing, and they had a brief and now resolved event. So this is one or more of the following, and you can see here from the algorithm, and I list them again. So this compares BRUE and ALTI. A brief resolved unexplained event includes the things that we've already outlined. And ALTI had some combination, apnea, color change, marked change in muscle tone, choking, or gagging. And again, this distinguishes multiple factors and one or more of the following, but again, needs to be resolved. And that is typically less than 1 minute. The patient returns to baseline, has normal vital signs and appearance. That could be a BRUE. If they have serious underlying symptoms, etc., then it's something else. Unexplained, there's no identifiable medical conditions. So if indeed you find something else, such as GERD or any other findings, it's not a BRUE. Event with cyanosis or pallor. Now you can see breath holding that can occur, and I've seen, the youngest I've seen a breath holder is 4 months of age. But the bottom line is, if it truly can be explained as breath holding, that is one thing. So that would not be a BRUE if it is identifiable. I can tell you with the young infants, sometimes it's really hard to tell, and I will often admit them just for evaluation. Those that have had repeated episodes or known breath holding is very easy, or in older infants. Marked change in tone, hypotonia and hypertonia. If there's an obvious evidence of seizure, it is not a BRUE. It is a seizure and needs to be worked up appropriately. And then loss of consciousness, altered mental status, lethargy or somnolence for less than a minute, and now back to baseline, that is a BRUE. And if not back to baseline, then you need to consider serious illness or occult trauma. So very important that BRUE is brief resolved. And again, an emergency clinician should diagnose a BRUE only when there is no explanation for a qualifying event after conducting an appropriate history and physical exam. So where is the risk here? Where does the, as we say, where does the rubber meet the road? Like, when is it that you need to consider that you need to do some diagnostic testing? So with BRUE, there's a risk assessment. Is it a low risk BRUE or a high risk BRUE? So let's talk about that. Age greater than 60 days, so 2 months. Prematurity greater than 32 weeks, and corrected gestational age greater than 45 weeks. So older children or those that had some prematurity but not significant prematurity, meaning under 32 weeks, could be considered low risk if their corrected gestational age is greater than 45 weeks. First BRUE, duration less than a minute. No CPR is required by a trained provider. No concerning historical features. No concerning physical findings. So here's an algorithm which looks at that lower risk BRUE, which we just talked about, and higher risk BRUE. So if there's any concerns on physical exam, the patient less than 60 days, if they're premature, if they're less than 32 weeks, or corrected less than 45 weeks of age, if CPR is done, if it lasts greater than a minute, or if there's multiple events, these are higher risk BRUE, and you need to respond accordingly, and we'll talk about that. So you do the risk stratification. You say it was short, and the answer is yes to this. No, it's a higher risk patient, and that typically involves a greater workup, okay? So higher risk BRUE, or those with obvious signs of another condition, you're going to evaluate that child based on that condition. And higher risk patients are not low risk BRUE, and these are the things that you could do. One of the things is educate the caregivers on what to look for anticipatory guidance. And you can offer, like you do any patient or any parent, CPR training, because I think that is important overall. You may obtain, based on signs and symptoms, these things. I typically would do a 12-lead EKG, make sure there's no signs of prolonged QT. For low-risk BRUE, you do not need to do all of this stuff. For high-risk BRUE, all bets are off because these babies are at higher risk, and you may consider viral testing and other things based on signs and symptoms. And again, low-risk BRUE are older, no repeat, no need for CPR, and no first event, less than a minute, and no significant findings on history or physical exam. So low versus high, and this is truly the risk. What kind of management? So low risk, you monitor in the ED. I would get an EKG. There is an option to do testing, but I wouldn't do that routinely. And then educate the family about BRUE and when to follow up with their pediatrician. High-risk BRUE, you want to evaluate for cause. I would consider doing some testing, and then I would admit. So high-risk BRUE are those who are not a BRUE but has ongoing signs and symptoms, you would admit. So let's do a couple of cases. Okay, so you can see the heart rate, the respiratory rate. So what are you thinking here, you know, with this BRUE? The baby was born at 25 weeks. So what do we know about low and high risk BRUE at this point? Although the baby's 2-month-old, right? The issue is the baby was born at less than 32 weeks. So automatically puts this baby in a higher risk category. The other thing is mom started CPR. Now the guideline says is started CPR by a trained provider. So really this baby meets high risk BRUE based on prematurity. I will tell you that when I have caregivers that actually do CPR, not pat on the back, etc., but actually do CPR, chest compressions, I would be concerned and consider admitting, although that is not the criteria. So predictors, at least in studies related to ALTI for the need for pediatric critical care, is resuscitation attempt before EMS arrival, cyanosis, greater than 1 ALTI, or significant past medical history. So in this particular case, the significant past medical history includes prematurity and therefore is higher risk, even with the previous guidelines. All right, so what is the management? They present as a BRUE, meaning they had a short cyanosis, loss of tone, or stopped breathing for a short time, apneic, or had trouble breathing for a short time, but is now resolved. But they have other concerning signs or symptoms. These are children who you want to consider based on whether they have a serious bacterial illness, sepsis syndrome, could have an invasive bacterial illness. And so you would evaluate based on that immunization status, whether RSV positive or not, enterovirus positive. You might consider doing some type of workup. If they're truly ill appearing and signs of sepsis, then you do a full septic workup. And we're going to talk about fever and what to do in the really young infant, because the guidelines have changed. But any child, no matter, regardless of the age, if they're toxic appearing, lethargic, with fever, you're going to do a significant workup and admit. I would always consider about inborn errors in the ED. As you know, that testing for inborn errors isn't perfect. And so any ill-appearing child that you do not know what's going on with that child, and that could be undifferentiated sick kid is the way I look at it, I would send labs for possible inborn error, and those include glucose, lactate, ammonia, and ketones. And then you need to consider occult trauma as well. So let's talk about the outcome of our 2-month-old boy. This little baby who was premature and now 2 months old, was admitted to the PICU, developed apnea later that evening, and was intubated. Turned out was RSV positive and ultimately discharged home after a week. So let's look at another case. This is a 5-month-old boy brought in by EMS with an episode of choking, apnea, color change per minute. Now at baseline and physical exam and vital signs are normal. Growth and development is normal, and there's no concerning past medical history, family history, and no prematurity. So is this a low risk or a high risk BRUE? And what should be done? What should the extent of the workup? Does this infant require admission? So really we think about the age of the infant, so greater than 60 days, so meets low risk criteria, at least on that. Features of the incident, and had some choking and color change, but does not have associated symptoms. You need to consider if there's recurrent neurologic syndromes with minor illness, such as a URI, that the child becomes lethargic, requires hydration admission. Still consider metabolic disease, inborn errors, in your differential. Sibling death, that is a marker of potentially underlying problems that are congenital, such as, or inherited, such as inborn errors, prolonged QT, and then you need to consider child abuse. So you ask about the siblings, are they alive and well? And if the answer is no, then you need to consider these things, and family history of sudden death. You need to do a complete physical, vital signs, pulse oximetry, cardiac monitoring. Perform a complete physical. Several studies have shown that if the child has gastric contents in the nose or mouth, to consider GERD as a possibility. We do know that 50% of infants can have GERD, and they typically grow out of it. As you know, as they get older, it improves. And so something to consider. And GERD is one of the most common potential causes of ALTI in the past, and going forward, probably GERD too, if you don't take a good history and physical. Fever, you want to consider sepsis, obviously COVID, and other infections. Wheezing or coughing, a respiratory infection, RSV, Bordetella, could be other things too, influenza, parainfluenza, metapneumovirus, human metapneumovirus. And then you assess for signs of maltreatment. And again, look for decreased muscle tone, jaundice, and rash, which in children may indicate a more serious infection. Rash, maybe not, but certainly decreased muscle tone and jaundice. So for low risk BRUE, like this child is, this infant came in, older, had signs of BRUE, but is now back at baseline. Really no tests are absolutely needed. My testing strategy is I watch them for a couple hours and I get an EKG. And then if it falls well, they go home with next day follow-up. So let's find out what happened with this infant. This infant had an EKG, which was normal. There was no prolonged QT. We observed the baby in the ED for 2 hours total from the time I first saw the baby, and the baby did well, and we sent them home for next day follow-up. So here's the algorithm. Again, it was formerly known as ALTI, and sudden brief, now resolved in a child less than 1 year of age. Cyanosis, with cyanosis, absent, decreased or regular breathing, or change in tone, or altered responsiveness. Again, you only need one or more to be a BRUE, unlike ALTI, which was a combination and included choking. H&P, really important to do a thorough H&P. And again, if they have abnormal vital signs, they're not a BRUE. No clear explanation and low-risk features. If that's the case, you give education. It's possible to do other things. I typically would just do an EKG. If the baby's otherwise well and alert, I don't necessarily do a glucose or a pertussis. And you should not obtain blood work or imaging in the low-risk patient. In the high-risk patient, then you're going to need to use your own discretion and make a decision about what are some of the things that you would do to evaluate this patient. So the bottom line, the BRUE ED management is based on the presentation and age. And again, comorbidities. If low risk, there's an option to discharge with a period of observation. I typically would do 2 hours. I'm a little more concerned in the younger than the older patient, so approximately 2 hours, and I would get an EKG to try to pick up some things like prolonged QT. If higher risk, you stabilize and admit, and that's the bottom line. All right, we'll take some questions. Again, feel free to email me. You can put it in WhatsApp question and we'll get back to you. And with that, I say thank you and please send me any of your questions. Thanks so much.
صالح.
Yes, Dr. Mohammed, 1 minute. طيب, بسم الله الرحمن الرحيم. Our next topics will be about what are the updates, literature's review with Dr. Mohsen Saeed Nejad. Mohsen Saeed Nejad is Professor of Pediatrics and Emergency Medicine from David Gibbons Schools of Medicine at UCLA. He's a director and Institute for Health Service and Outcomes Research, and also the Landquist Institute for Biomedical Innovations at Harvard, UCLA. Welcome, Dr. Mohsen.
I'm Professor of Emergency Medicine and Pediatrics at the David Geffen School of Medicine at UCLA, and I'm also the Director for the Institute for Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation at Harvard, UCLA. And today I'll be speaking to you about what the latest are of the update in the literature review, state of the research in pediatric emergency medicine. First article I wanted to talk about is Pediatric Mental Health Emergency Department Visits from 2017 to 2022. This is an article that we recently published in Academic Emergency Medicine that looked at the trends and characteristics of visits by children with mental and behavioral health disorders. Essentially, our goal was to evaluate the impact of COVID-19 on the pediatric mental health visits. We included children between the ages of 5 and 17, so just before the 18th birthday. We had 9 hospitals who enrolled in the Pediatric Emergency Care Applied Research Network Registry. The study period was between 2017 and 2022. And we found some very interesting items when we were looking at this database. Mental health visits were lower than what we expected during the early part of COVID, during the lockdown period where people were having stay-at-home orders, so between March to December of 2020, and also was a little bit lower than we expected during the later phase of the pandemic in 2022. But during the middle of the pandemic, late 2020 to 2021, the numbers were as we expected. We also noted that girls were disproportionately affected in late pandemic, more visits by adolescent females compared to males. We also noticed that schizophrenia, mood disorders, and substance use disorders were also very well represented and overrepresented during the late pandemic period. So the next study I wanted to talk about is the study of school shootings in the United States. As you may have heard or know, in the last few years, we've had quite a major problem with shootings in our schools, and elementary school, middle school, high school. Those numbers have just gone up tremendously. It sounds like it's every week that there's a shooting. So as of 2019, gun violence has become the #1 cause of death in children under 19, and this has surpassed motor vehicle collision deaths, which up to 2019 were always the #1 cause. So the study looked at the actual number of school shootings. There were over 1,400 school shootings between 1997 and 2022 in the United States, and almost half of these, actually more than half of them, were just in the last 5 years. So the number of mass shootings, which basically would be more than 4 or 5 children killed in one shooting, those numbers have remained the same. But the fatality for each mass shooting has increased from less than 8 to 14 in the last years or so. So that means that there's more lethal means and more firepower, I guess, for each of these mass shootings, so that each mass shooting has more deaths than it used to be. So a little bit of a highlight, as you can see here, that over the 5 years, the number of shootings has really increased quite exponentially, and the thought is that COVID-19 may have something to do with this, especially that in the last couple of years, this number has jumped by quite a lot more. And as you can see, mass shootings pretty much are steady. Every other year or so, you see 1 or 2 mass shootings, and those numbers have basically remained steady. If you look at by school year, same thing, that it just represented over certain years, but as you may see, the number of fatalities have increased over the total number of shootings. The next study I'm going to talk about is respiratory syncytial virus associated with hospitalizations among children under 5. So this study published in Pediatrics in February of this year looked at children under 5 with acute respiratory illness. The study spanned 7 sites, and from 2016 to 2020, over 13,000 cases of acute respiratory illness in inpatients under 5 years of age. Of these, about a third of them ended up being RSV positive, and more than half of them did not have any predisposing underlying condition or any history of prematurity or anything that put them specifically at risk for bronchiolitis. And the study also found that the highest rate of respiratory syncytial virus was among the babies between 0 to 2 months, premature infants, and those that did have comorbidity. They had a higher likelihood of testing RSV positive. In the next study, I wanted to do a couple of ultrasound studies because there's so much going on in terms of research with ultrasound. So this study looked at ultrasonography versus radiography for suspected pediatric distal forearm fractures. So the question is, can that first test be an ultrasound as opposed to being an X-ray? So this was a multicenter non-inferiority randomized trial looking at children between the ages of 5 and 15. And the criteria was that this child would have had to come in with an isolated forearm injury, not a multisystem trauma, and there's need to be no obvious deformity that would cloud the judgment of the sonographer or the radiographer, but mostly the sonographer, because that is a operator-dependent evaluation. So patients who came in were randomly assigned to either a point-of-care ultrasound in the emergency department or a radiography. And the primary outcome was to look at return of function to the affected arm within 4 weeks. These patients were followed up to 8 weeks, but the question was, what is the rate of return to function, meaning interventions that were done in the ER just on the basis of what the ultrasound found versus what the X-ray found. And the conclusion was that the use of ultrasound as the initial modality was not inferior to radiography in terms of 4-week return function. So it's reasonable to use ultrasonography. Again, I have to state that this has to be in the hands of somebody who is trained in ultrasound. So obviously it needs to have an operator that knows how to do these tests. But if ultrasound as a test detection ability was the factor, that it's not inferior to the use of radiography. And the other ultrasound study that I wanted to mention is a validation of clinical decision rules for ultrasound identification of MRSA skin abscesses in children. This study was published in Pediatric Emergency Care earlier a few months ago in June of 2023. There was a retrospective study of skin and soft tissue infection. The study was aligned to use the same validation tool that adult study had used about identifying MRSA skin abscesses through ultrasonography. So patients who were under 21 who came to the ED and had a formal ultrasound and wound cultures for gold standard to confirm MRSA. The study included a sonographer who was trained physician sonographer in the ED, and also the sonogram was evaluated by at least 2 different physician and a radiologist, so that to confirm inter-rater reliability. And of the patients that they enrolled, there were 209 patients, 33% of them were confirmed MRSA positive on a wound culture. And when they applied their decision rule to those who were positive for MRSA, the sensitivity was reasonable at 86%, specificity was kind of low at 32%. Positive predictive value was 38%, negative predictive value 82%, but likelihood ratios for positive 1.26 and negative 0.45. So the conclusion is that this study performed very similarly to that of the adult study, and it's considered to be moderate reliability. So the use of ultrasonography to detect MRSA skin abscess might be able to help with the identification of antibiotic choice, and that is before the culture comes back, obviously at the time of discharge from the ER. So it might be a reasonable approach. I think this study requires larger scale studies to validate this more. This is a single center study, but it is an interesting finding. This one is just a recent publication in Annals of Emergency Medicine looking at the efficacy of antibiotic treatment for children diagnosed with acute otitis media. And I put that in there because there's great amount of variation among clinicians in the emergency department about who gets antibiotics, what is considered the true definition of acute otitis media. There is that group that does a lot of wait and see prescriptions. There are the ones who believe in self-resolution, and there are those who give a lot of antibiotics. So there have to be a happy medium there. So this study looked at children who present with acute otitis media who are treated with antibiotics, and found that over the course of treatment that they have slightly reduced pain early in the course, but then that's at the expense of having more side effects such as diarrhea, vomiting, and rash. So this is sort of a study where it's difficult to make an interpretation on, but if the goal is no pain, then antibiotics are showing to be efficacious in that sense. But then if the goal is not to have side effects, then the antibiotics don't do a good job there. Again, a lot of different studies land on different sides of this issue, but this is one of the latest studies I ran into. I figured I will share that with you. This is a study that is one of the oldest ones I'm going to present here. This is from September of 2022. I promise you everything else I have said and I will say will be from the last year. This one, just because it was an important study, we've been waiting for it for a long time, I figured I will share this. This is the study of looking at serious bacterial infections in young febrile infants who have positive urinalysis. It used to be that in the first 2 months of life, if you had a positive urinalysis or urine culture, the thought was that that bacteria can disseminate into the CNS, and therefore you probably should do an LP in the second month of life, even if you weren't going to do it otherwise. So this study was important to find if a febrile infant younger than 2 months of age has an abnormal urinalysis that suggests UTI, do they really need to have a lumbar puncture performed or blood work done? So the study spanned 12 years from 2008 to 2019. It was a subset of the febrile infant biomarker study, 7,180 infants, total of 1,090 or 15% of those had a positive UTI or positive UA result. And in the first month of life, those who had positive UA had 1% associated risk of meningitis. And if you had a negative UA, then you have also 1% risk of meningitis. So the UA status did not make a difference for the under 1 month of age. But in the second month of life, of all of the children who had a positive UA, nobody had a meningitis. So that suggests if you're UA positive in the second month of life, you probably have a limited or minimal risk of meningitis. In terms of bacteremia, though, UTI positive babies had a 6% chance of bacteremia versus the UA negative, who is 1%. So risk of bacteremia was 6 times higher if your UA was positive, even though risk of meningitis was almost 0. So the conclusion is, in the infants 29 to 60 days with a positive UA, lumbar puncture is probably not necessary, but given that there is a risk of bacteremia, the recommendation of still doing a CBC and a blood culture may be considered. So I think this is a very important study because lumbar puncture is always a challenging and an ethical dilemma to do on babies, whereas a blood culture and CBC not so much. So this is a good study. In the tail of this study, there's also outcomes of infants who are febrile aged 29 to 90 days who were discharged from the emergency department. That's an international study. It's a multi-center retrospective cohort study of children between 1 to 3 months. It was performed over a 3-year period. These are all the children who were evaluated in the ED, getting the full evidence-based diagnostic testing and treated appropriately. And the outcome measures for this was how many of these will actually return to the ED, and of those who return to the ED, how many would have been missed in the first visit, meaning they ended up with invasive bacterial infection, PICU admission, or death. And so it turns out that the rate of return was very high. 20% of all of those patients in the 1 to 3 month old age group that were discharged ended up returning back within 5 days of that first visit. The risk of UTI was pretty much similar to most other studies. About 7.8% of children, babies between 1 and 3 months who are febrile do have a UTI, so that was not unusual. The risk of invasive bacterial infection in that group was very small. So the conclusion was, even though almost 20% of these babies who were discharged from the ER came back within 5 days, but in terms of anything serious, there wasn't really anything going on. This was just a matter of coming back, maybe because the fever was persisting, maybe they weren't getting better fast enough. So that's kind of an interesting study. It probably needs a larger scale validation to see if that's actually true. But again, bear in mind, they're staying away from the first month of life because that's a little more tricky. So the study is actually 29 days to 90 days. This study I put up there because, as some of you may have heard, the Pediatric Emergency Care Applied Research Network, or PCARN, is coming out with a new decision tool for imaging for cervical spine injury for children involved in a trauma. And this is going to be a very, very transformative document that's going to change practice. We are waiting for it any day now for it to come out, but is going to have significant impact on the way we image C-spine. So this study here that is a Cochrane review coming out right before this PCARN article is supposed to be published is really interesting because this is a search of multiple databases. It looks at data from January 2015 to December of 2022, included all studies that compare diagnostic accuracies of any of these 7 different decision rules, and the new PCARN decision rule is actually being called a decision tool so that it doesn't make it sound like a rule, but there are other ones that are called rules. There are 5 studies that were published in the last 20 years with 21,000 participants that met the criteria for this review. They looked at prevalence of C-spine injury that ranged between 0.5% to 1.85% between the different studies. The 7 decision rules that they looked at are the Nexus, the Canadian C-spine rule, the PCARN retrospective criteria, the Leonard de Novo model, and actually Julie Leonard is the one who's going to be the lead author of this upcoming C-spine decision tool. There's also the NICE, or the National Institute for Health and Care Excellence, as well as the clinical guidelines 56 and 176 and PD spine. So after reviewing all of these, the Cochrane review basically established that there was not sufficient evidence to determine the accuracy of any of these decision rules to detect clinically important cervical spine injury in children following a brunt trauma, especially those who are less than 8 years of age. So they are not really endorsing or supporting or finding anything with any of these decision rules. So we will see what happens when this new one comes out. This one is a paper that I was the lead author for. I actually mentioned this also in my mental health talk. This is a comprehensive policy statement and technical report on how to manage children and youth with pediatric mental and behavioral health emergencies. This is a really great document. It took us, many of us, all these people you see in this authorship group, almost 3 years to get this publication done. We had to get consensus from the American Academy of Pediatrics, the American College of Emergency Physicians, and the Emergency Nurses Association. So it's definitely a joint policy statement between all of these organizations. The important thing about this publication is that we did get a lot into the disparities and lack of access in certain groups by demographic, by geography, and talk a little bit about telepsychiatry and how to improve access to care in different areas. We also have a section on children who have developmental disabilities, neurodivergent children, and we talk a little bit about pre-hospital environment and a bit about safety planning for discharge. So it's a really comprehensive mental health recommendation and policy statement document. This is one of the papers that's associated with pediatric readiness. The pediatric readiness is a very important topic for us now, and I'm involved myself with pediatric readiness work, and Dr. Kate Remick and Dr. Marianne Geshe-Hill, who you know, both of them are going to be speakers at this same conference as well, are deeply involved with pediatric readiness. And this paper by Dr. Craig Newgard, one of our colleagues, actually looked at the cost of emergency care for children across different levels of pediatric readiness in the emergency department. And the important thing is that while being a pediatric ready emergency department has shown that significant improvement in outcomes of care can be achieved both for injuries and medical illness, but it actually doesn't cost that much to be pediatric ready. So the difference of cost between a pediatric ready and a non-pediatric ready could be as little as $72. So it is very important. It's a high yield to get emergency departments to become pediatric ready, and there is not a major associated cost with it. So this was a really, really important paper that looked through that. Next one, I put in the systematic review of effectiveness and safety of droperidol for pediatric agitation. I do a lot of work on pediatric agitation and mental health in general. And I know our goal is to do verbal de-escalation and behavioral modification before we do any kind of restraint using medications or physical restraints. And the choice of medications that we use, really, we would like them to have good side effect profile, safety profile. We don't want them to linger for too long, and we don't want them to have complications. So this medication, droperidol, seems to have really favorable side effect profile and could be a good use for pediatric agitation. And this paper actually reviewed the safety and efficacy of it and found that using IV droperidol for management of acute agitation in patients under 21 years of old is effective and safe for acute agitation. But we currently don't use that, and we don't have it in our algorithm because droperidol for many years in the United States was black boxed and we were not allowed to use it, but has now been recently okayed to be able to be used again. So papers like this, hopefully more and more of them will come out. And hopefully, I don't know what the rest of the world is doing with respect to droperidol for pediatric agitation, but this sounds like a promising and relatively safe option if you needed to medicate a child who is acutely agitated. Again, the idea is to try to do non-medical first, but this might be a good choice. In my other talk for mental health, I will mention all the different medications that we use for managing pediatric acute agitation. And this one is kind of one of those easy ones just for the end of my talk. We obviously as physicians don't really take very good care of ourselves. We end up over time becoming stressed out and burnt out and contemplate retiring or leaving our institutions. And this is a bigger issue in academic facilities where you just work so hard. And in addition to your clinical work, you also have to be academically productive, which means you're going to take away from your family time, from your well-being time, and becomes a difficult task. So this study published in JAMA Open, December of 2023, was a cross-sectional study of over 37,000 attending level medical specialists at 15 different academic institutions. And the study spanned 2019 through 2021. I would say just mostly during COVID, but a little bit before it started. So about a third of them, the people who were surveyed, say that they had either moderate or higher intention to leave their institute within 2 years. So they were tired of it, they wanted to leave. So burnout, lack of professional fulfillment, and other well-being factors was noted to be associated with these feelings. And there's many papers like this that are out there about physician wellness and burnout. So I figured this one was the latest one, interesting paper to share with you. And that's it. I put my email address here. If you have any specific questions for me about any of the articles, or I'm going to do this talk at different times as well. If you come across any article that you think was impactful to your practice and you want to share that with me, I'm happy to accept that, and thank you for it in advance. And thank you again. I hope you enjoyed the rest of this conference. I wish we could all be there in person, but maybe a different time. I'm looking forward to being out there actually in person. But thanks again for listening, and I appreciate this opportunity to speak with you.
Thanks, Dr. Mohsen. Our next speaker will be Dr. Fadia Al-Khattabi. Dr. Fadia, she's from King Faisal Specialist Hospital, and she's also
Dr. Fadia, she is with us. Thank you, Dr. Fadia, for attending. And if there is any question for Dr. Fadia, please, it's our pleasure to receive questions and she can answer. Or we can go and proceed to the next lecture and leave the question after the next lecture. I see there is no. Let me see. صالح في question للدكتورة فادية؟
So from my side there, there's no questions, but let me see, look to the.
Yes. Many thanks, Dr. Fadia. All the attendees, they are really happy with this presentation, excellent presentation, and we are waiting for you for your next presentation, inshallah, after tomorrow for child abuse and approach. Or I will leave the microphone for Dr. Saleh to present the next speaker. Go ahead, Dr. Saleh.
جزاك الله خير دكتور محمد. So our topics next about the head trauma, when to be worried. The speaker is Kathleen Adelageis. She's professor of pediatric emergency medicine. She's principal investigators at Colorado AMS for Children State Partnerships Program. She's emergency department Children's Hospital Colorado at the University of Colorado School of Medicine. Welcome, Dr. Kathleen.
Thank you for having me talk on this next topic, head injuries, when to worry. My name is Kathleen Adelageis, and I'm a pediatric emergency medicine physician and EMS physician at the University of Colorado and Children's Hospital Colorado. The objectives of this talk are to do the following. First, to review the epidemiology of pediatric head injuries. Next, to discuss the diagnostic tools, including screening tools and imaging studies. Third, I'll cover some elements of management of children with traumatic brain injury. And finally, we'll discuss prevention. And my hope is to get through all of this in 25 minutes or less. Let's talk about head injury by the numbers. Pediatric head trauma is the leading cause of death and disability in children. It's very common, with a worldwide incidence varying by country between 47 and 280 per 100,000 children. Common causes of pediatric head injury include falls, motor vehicle crashes, and when children are struck by vehicles. Abusive head trauma is the most common cause of head injury-related death in children under 4 years of age, and an important cause of both morbidity and mortality globally. Pediatric head trauma is classified by the following: mild, moderate, and severe. And these classifications are based on the presenting Glasgow Coma scale that results from the head injury. Mild traumatic brain injury is identified as a head injury with an associated Glasgow Coma scale between 13 and 15. Moderate traumatic brain injury has a Glasgow Coma scale between 9 and 12. And severe traumatic brain injury is that in which the child has a Glasgow Coma scale of between 3 and 8. The outcomes of traumatic brain injury do vary based on whether it's mild, moderate, or severe in nature. Mild traumatic brain injury has a very good outcome overall. These injuries are known as concussions, and there is some risk of post-concussion syndrome. Moderate traumatic brain injury has variable outcomes from either good to mild disability or associated post-concussion syndrome. And severe traumatic brain injury has the broadest range of outcome, with some having mild disability to death. The types of head injuries that we're talking about include the following: intracranial hemorrhage that can be either in the subdural, epidural, or subarachnoid space; diffuse axonal injury, which is an associated traumatic brain injury where there is extreme cerebral swelling from generalized hypoxia and ischemia and damage to the axons. Skull fractures can be isolated or comminuted and often are associated with an underlying hemorrhage. There can be penetrating injuries, which are overall rare in children. And then finally, concussion, which is a form of mild traumatic brain injury that is radiographically negative, but the child is somewhat symptomatic. Let's talk first using a case. A 6-year-old girl is riding a bike and hits a rock and falls to the ground going over the handlebars. The accident is witnessed by her mother, who sees her strike her head. She wasn't wearing a helmet at the time of the fall, and the mother thinks she briefly lost consciousness for about 1 minute. The emergency medical services team arrives on scene and finds an awake, alert child crying with a bruise on the forehead. Let's use this to frame the evaluation and management of a child with a traumatic brain injury. First and foremost are the 3 main core elements of assessing any trauma patient: assessing the airway, their breathing, and their circulation. With regards to the airway in a child with a head injury, it's important to globally assess mental status, as well as ensuring that the airway is open with stabilization of the cervical spine. This may require inline cervical spine stabilization with a jaw thrust maneuver in the event that their airway is not open. Assessing breathing is generally to assess for regularity of respirations, and then circulation with an importance to note attention to the heart rate as well as the presence of any hypertension, which might suggest increased intracranial pressure or Cushing's triad. When children are injured, there are multiple anatomic elements that you need to examine and assess for, particularly in the case of a head injury. It's important to look overall at the scalp and the cranium for any bruising, hematoma, lacerations, or deformities, and also check the fontanelle in young infants. When examining the face, it's important to do a fundoscopic exam and check the pupils to make sure they're brisk and reactive and equal bilaterally. Checking the nose for the presence of any rhinorrhea, which might suggest a cerebral spinal fluid leak, and checking the ears for any otorrhea, also from a potential cervical or cerebral spinal fluid leak, and the presence of any hemotympanum that might suggest a basilar skull fracture. Examination of the face also allows for an assessment of the cranial nerves. It's important to examine the spine and check for any tenderness with palpation along the spine, particularly the cervical spine, and then to use your extremity exam to get a sense of their overall motor and sensory exam and check their deep tendon reflexes. These are all critical physical exam components of any child who has had a head injury. The pediatric Glasgow Coma scale is shown here, and in general, it is a challenging scale to do in young children, and the overall inter-rater reliability is actually poor. In general, the motor component, which some have used as a basic scoring tool for assessing the severity of traumatic brain injuries in adults, using the motor score alone, has not been well established in young children. So we are left to do a full GCS, which, as in the prior slide noted, is the actual scoring system for mild, moderate, and severe traumatic brain injury. When looking at the eye examination, getting a shout for a child less than a year will get you a score of 3 if at baseline their eyes are closed, as children under a year don't respond to verbal commands. The motor response is assessed through the standard process of localization of pain, withdrawal, or abnormal flexion extension. For children under a year, moving spontaneously and purposefully would get somebody a motor score of 6. And then the verbal response is also challenging in preverbal children, getting a score of 5 for any child who smiles, coos, or has some appropriate verbalization, and getting a score of 4 for any child who cries but is somewhat consolable, the ways that we measure that in preverbal children. After doing a full exam and getting a sense of their mental status, as well as any potential disability with the Glasgow Coma scale, one must ask whether imaging isn't warranted. And there are 3 types of imaging that can be used for assessing for intracranial injury. The computed tomography, or CT scan, has multiple benefits. It's fast, it's great for fractures, and also can identify acute hemorrhage. The disadvantage with a CT scan is the ionizing radiation. Magnetic resonance imaging is better in terms of no ionizing radiation, but it is very slow, takes quite some time to get done, and often children who are very young require sedation, which would often require airway management. The fast MRI is a new technology that's available that is almost as quick as CT scans with no radiation, but it can miss fractures. So the question comes up, who needs a CT scan, especially when we're trying to be judicious with radiation exposure to young developing children? This was a prospective study published in 2009 through the PCARN Research Network through EMS for Children of greater than 42,000 children aged 0 to 18. The mean age in this study was 7 years, and 25% of the children enrolled were less than 2 years of age. The large majority of children had a GCS of 15, and 35%, 1/3, underwent a CT scan. The goal of this study was to identify who had clinically important traumatic brain injury, and specifically the goal was to develop a clinical decision rule that had greater than 99% sensitivity or specificity for clinically important traumatic brain injury. And that was defined as either death, the need for neurosurgery, being intubated for greater than 24 hours, or admission to the hospital for greater than 2 nights for IV fluids. Ultimately, in this study, 780 out of the 42,000 had a visible traumatic brain injury, and that was 5% of those children undergoing CT scan. 376 required acute intervention, or 1% of the total study population. 60 of those, or 16%, required a neurosurgical procedure. The PCARN head injury decision rule is shown here in a schematic that's available on the EIIC website. It is stratified by greater than 2 years of age and less than 2 years of age. It provides guidance for when to observe. For children less than 2 years of age, the presence of altered mental status or a palpable skull fracture would indicate a likelihood of needing a CT scan. However, for children with a loss of consciousness greater than 5 seconds, no non-frontal hematoma, not acting normally or severe mechanism, with normal mental status and a GCS of 15, those children can be observed or, based on physician discretion, get a CT scan. Anyone without any of those does not need a CT scan by the rule. For children greater than 2 years, similarly, any altered mental status or GCS less than 15, or the signs of a basilar skull fracture would be an indication to get a head CT. For children with any loss of consciousness, vomiting, severe headache, or severe mechanism, options include either doing CT imaging or monitoring. For any child without any of those symptoms, a CT scan is not recommended based on the head injury rule. One key thing to know is that for each hour of observation, there is a reduction in the likelihood of a physician decision to get a head CT. And in a prospective study of almost 1,400 children where this was evaluated, there were no missed head injuries, and there was a significant reduction in the use of head CT across all categories of acuity, i.e. acuity according to the PCARN decision rule. So observation is definitely an appropriate way to first evaluate and manage these children. What is the utility of fast MRI for injury evaluation? This study was conducted at my own institution, exploring both the feasibility and the accuracy of a CT versus a fast MRI. The median imaging time was 6 minutes, which is quite quick. And compared to CT scan, it was 92% sensitive for detecting traumatic brain injury. The things that were missed included isolated skull fractures and 2 subarachnoid hemorrhages. Overall, the study concluded that it was feasible and reasonable as an alternative to a CT scan in acute care settings. I would say the large majority of fast MRIs are often used for children that are medically complex, with VP shunts to evaluate for VP shunt malfunction as a radiation sparing modality. So going back to this case, the child remembers the fall from the bicycle and she has no altered mental status. Her Glasgow Coma Scale is 15. Her exam is reassuring without evidence of scalp hematoma, and she has no focal neurologic exam findings. But she does report that she has a headache and nausea, but no vomiting. She states that her vision is blurry, but on assessment, her visual acuity is normal. This is an example of a mild traumatic brain injury. Mild traumatic brain injury is a trauma-induced alteration of mental status or cause of somatic symptoms. It may or may not involve a loss of consciousness, also known as a concussion. There is a disturbance of CNS energy pathways, but there's no evidence of something on a CT scan. Mild TBA has a neurometabolic cascade that is well evaluated. First, there is a calcium ion influx, followed by an increase in glucose consumption, followed by an increase in metabolic demand. And functional MRIs can detect shifts in fluid on cellular level, identifying the stretching of neurons or the widening of neurons in children with mild traumatic brain injury. The symptom inventory to assess for a mild TBI is quite long, but important to do. Mild traumatic brain injury or concussions can be classified with symptoms across 4 different categories, including physical, cognitive, emotional, and sleep-related. Somatic symptoms include headache, nausea, vomiting, dizziness, visual disturbance, phono or photophobia, and poor balance, while cognitive symptoms include memory disturbance or feeling slowed down, some difficulty concentrating or difficulty with attention. And these are most apparent in school-age children who report this and are having a difficult time at school. The emotional symptoms can include being easily frustrated, sad, or nervous, and then there can either be sleep-related disorders, including increased tiredness and trouble sleeping or sleeping more. These symptoms may or may not be present at initial evaluation, and the follow-up of these children is paramount in order to assess whether any of these symptoms develop and to make sure that they get appropriate treatment as needed. The complications of concussion are also well documented. Patients can have post-concussive syndrome, which is the duration of symptoms lasting greater than 2 weeks or up to several months. Second impact syndrome is a life-threatening condition that results from a rapid rise in intracranial pressure after re-injury from diffuse axonal injury. And chronic traumatic encephalopathy is the result of recurrent chronic concussion. There are memory and speech difficulties and headaches, depression, and suicide. This is well described in the US population, where many professional football players develop chronic traumatic encephalopathy. And an example of what a CTE brain looks like is shown there on the slide compared to a normal brain. It's quite devastating in its impact. The approach to the concussed patient involves getting a detailed history and physical, followed by rest, observation, fluid administration if needed, analgesia and antiemetics, but no neuroimaging is indicated in these patients. And discharge counseling is critically important. First, it's important to tell families the expected symptoms and time course, and then reasons to return, including worsening of symptoms or new symptoms. It's important to discuss a time frame for follow-up and protective equipment, and then finally those key elements for older children of any return to sports or activities and return to cognitive activity. This after concussion return to normality, a guideline here is from the National Health Service of the UK and gives guidance to physicians on when children should stop and rest, when it's okay to rest, but then starting to move, and then returning back to normal activity. The QR code on this slide will bring you to this diagram. So let's transition to a second case. A 14-day-old female was accidentally dropped by her sister onto the floor. She cried right away, and upon arrival to your emergency department, the family is actually giving the infant a bottle. On assessment, airway is open and the child has a strong cry. Breathing shows a child with clear breath sounds, no increased circle breathing, and a respiratory rate of 50. Circulation is normal with brisk capillary refill. The mental status of a 14-day-old, the baby is alert and moving all extremities with good flexor tone. And on exposure, the child is dressed in a snap suit, but when removed, no bruising is seen. So primary survey and the pediatric assessment triangle, appearance is alert, breathing is easy, and circulation is well perfused. But on secondary survey, the head shows a boggy hematoma that you can see here. Lungs are clear, but there's no chest wall trauma. Heart is regular. Abdomen is soft, non-tender, no bruising. As noted before, extremities show no deformities or non-tender to palpation. And neurologic exam, again, shows good flexor tone. So what do you do now? You have an infant who was dropped, has normal mental status, but has an exam that's consistent with the likelihood of a skull fracture given the boggy hematoma. So by the P-Carn head injury rule, this would be a patient where a CT scan is indicated. CT imaging actually shows a very large subepidural hematoma. And in this case, the child comes back from the CT scan and the trauma team is activated. And during a spinal motion restriction and immobilization, the child becomes apneic and pulseless. The ED team needs to immediately begin back mask ventilation, advanced airway management, chest compressions. The patient gets an IO and is given fluid, blood, and epinephrine and is able to go to the operating room. This is a case of severe traumatic brain injury. It affects all 435,000 children in the US each year and accounts for 1/3 of deaths in all children. The challenge with traumatic brain injury, both mild, moderate, and severe, is that the primary injury is a done deal. It happened, and the overall goal is to prevent any secondary injury through the support of the brain with oxygen and also seizure prophylaxis. This diagram shows the pathophysiology of brain injury. After the impact, there is cell membrane disruption. There's then dysregulation of the electrical ions that affect nerve impulses that travel along neurons. This results in increased intracellular calcium that then results in activation of the NMDA receptors, increased mitochondrial calcium, and then release a reactive oxygenation species. There's also a degradation of the cytoskeleton, ultimately all leading to cell death. What happens with the brain when there is an intracranial mass such as the epidural hematoma? The standard brain has a mix of cerebral spinal fluid, venous blood, arterial blood, and brain, all in balance. When a mass begins to take up space, the compartments of the cerebral spinal fluid and the venous compartment begin to become compressed. The arterial blood going into the brain does not change, and the brain matter itself does not change. As that mass continues to grow, ultimately, the cerebral spinal fluid and venous fluid gets significantly compressed, and the intracranial pressure begins to rise rapidly. As a result of this, it's critically important to support the brain, and the challenge with resuscitating the brain is shown here. In cases of hypotension or hypoxia, there will be a much worse outcome. The first few rows of this graph show, or this table show, that in children with a normal blood pressure or undocumented or not documented blood pressure with a median Glasgow Coma scale of 4, in severe traumatic brain injury, 7% of these children in this study will die, and 30% will have a poor Glasgow outcome scale. The presence of hypotension with treatment or the presence of hypotension without treatment results in a much higher risk of both death and a poor Glasgow outcome scale. Similarly, with hypoxia, children who presented with severe traumatic brain injury with no evidence of hypoxia still had an 11% chance of death and a 16% chance of a poor Glasgow outcome scale. However, hypoxia with treatment and or hypoxia without treatment portend much worse outcomes, both death and poor neurologic outcome. The bottom line of this study was that 1/3 of the children that presented with severe traumatic brain injury did not get a blood pressure or pulse oximetry in the out-of-hospital environment, and 1/2 with documented hypotension were actually not treated. The failure to correct hypotension is 3.4-fold increase in the odds of death compared to children who even received an attempt at correction. The younger and the sicker the child, it was found in this study that it was less likely that the child was completely monitored or treated. It's critically important to correct and treat hypotension and hypoxia. The additional management include using intracranial pressure monitoring and supporting cerebral perfusion pressure by maintaining mean arterial pressure and cerebral perfusion pressure through pressors and fluids. There's also a critical need to reduce any cerebral swelling, including the use of mannitol or hypertonic saline, and also suggestions in current TBI guidelines around mild hyperventilation. That is to keep the partial pressure of CO2 between 30 and 35. Targeted temperature control to prevent fevers and or severe increased metabolic demand of the brain is also key. Nutritional management, and then seizure prophylaxis in children is particularly important, given that children have a lower seizure threshold. In this case, the child was resuscitated and able to go to the operating room. The CT scan, which revealed a large epidural, ultimately a burr hole was placed in the ED before going to the OR, and in fact the child returned back to the ED at 6 months of age for a fever and was doing well at that time. Preventing traumatic brain injury is really the first and most important thing to do. The leading causes of traumatic brain injury are shown here, with 55% being related to falls. There's 24% with unintentional blunt trauma and motor vehicle crashes. And then finally, sadly, child abuse and neglect. And so the prevention strategies are accordingly. Children should be in child safety seats when they're in vehicles. Children should be wearing a helmet when they're out riding a bicycle. The installation of windows and guards on the stairs can provide safety at home. And then finally, avoiding shaking any children and resulting in shaken baby syndrome is also key. And public safety and guidance for families and support of families to understand the dangers of this to children are ongoing. So in summary, traumatic brain injury is common and deadly for many children. Critical recognition and management is key. And please post any questions as needed and we will respond. Appreciate your time. Thank you for having me talk on this next topic, head injury.
Thanks, Dr. Catherine Abdulgais. Inshallah, our next session will be at 1 o'clock. There will be now a break and ظهر prayer until 1 o'clock, inshallah.
If you allow me, Dr. Saleh, I can make an announcement for our audience. If they wish to have like after ظهر prayer, we can start at 12:30, if this is okay with them. So we can finish today early, because I can see some people, they were asking whether we can finish early, and also whether the time. I think according to the schedule, we'll finish by 4 o'clock. But if we can start early this afternoon, and Dr. Hamad Al-Madi will be with you at 12:30, we can finish inshallah at 3:30, يعني وقت صلاة العصر. If this is okay with you, please.
Yeah, looks most of them, they agree about 12:30, inshallah.
They agree? Yeah, I can see they are all agree. So inshallah, خلاص, Dr. Hamad, he's available, and he will join you inshallah at 12:30. And thank you very much. And if you have any question, please just send it in the box, the question and answer box, and we will answer you all. Thank you very much.
في هذا التخصص لدينا برامج تدريبية تنافس البرامج الموجودة في أمريكا الشمالية، وأصبح لدينا أيضا برنامج للزمالة للطب طوارئ الأطفال يتدربون فيه عدد كبير من الأطباء من دول الخليج ومن الدول المجاورة، وذلك بسبب النجاح، وإن مستواه يعني مماثل للمستوى في شو اسمه في استغفر الله في نورث أمريكا، في أمريكا الشمالية. طبعا بالنسبة للنقاش سؤالك إيش اللي راح يناقش في المؤتمر، طبعا كيف تحسين الوضع في أقسام الطوارئ، كذلك الجديد في علاج بعض الحالات اللي تجي لقسم الطوارئ، مثلا التحسس الشديد من بعض الحلويات، من بعض الأدوية، من بعض القرصات وكذا. خبراء من أمريكا راح يناقشون هذه الأمور. إيش التحديات اللي تواجهنا في أقسام الطوارئ، الازدحام في أقسام الطوارئ، إيش أسبابه وإيش حلوله. كذلك نتحدث عن إيش الجديد وإيش الأبحاث والدراسات اللي تمت في آخر سنتين في مجال طب طوارئ الأطفال. نتحدث كذلك عن الاحتراق الوظيفي للممارس الصحي في قسم الطوارئ. كما تعلمين انه يعني في قسم الطوارئ الطبيب او الممارس الصحي يواجه معاناة في قسم الطوارئ بسبب الضغط والستريس، ولا يخفاك برضو الحالات اللي يواجهها، قد يواجه حالات حروق، قد يواجه حالات وفيات، فتكون صعبة. إصابات الرأس وكيف التعامل معها، إيش الجديد فيها، وكذلك التحسس والحساسية عند الأطفال، الحرارة عند الأطفال، في الأطفال يعني حديثي الولادة وكيف التعامل معها. متى يجب أن احنا نقرر أن الطفل يجب أن يتنوم، وخاصة أنت عارفة مع ازدحام أقسام الطوارئ نحاول قدر الإمكان يعني أنه نضع يعني المعايير التنويم لحالات معينة فقط، دون أن نمشي على القرارات القديمة. في الربو والحساسية عند الأطفال ما هو الجديد في علاجها، تضيق التنفس عند الأطفال، وأمور كثيرة كل ما يخص الأطفال بصراحة. سوف يناقشوا هذا المؤتمر.
نعم، شكرا لكم دكتور، نتمنى لكم التوفيق. يعني الرائع أيضا في حديثك أنه الأمر لا يقتصر فقط على تحسين التجربة العلاجية، إنما أنسنت هذه المرحلة بشكل كبير، لأن كما ذكرت يمكن في ضغط نفسي كبير على العاملين في القطاع الصحي حين يعالجون طفل من حالات صعبة، وضغط نفسي حتى على طبعا الأهالي بكل تأكيد. في تجربة ألم الطفل تجربة مضاعفة بالنسبة للجميع. نتمنى لكم التوفيق وسعيدين بما سمعنا منك الدكتور محمد الفيفي، وأنت رئيس المؤتمر العالمي لطب طوارئ الأطفال.
يعطيك العافية دكتور. ينطلق اليوم المؤتمر العالمي لطب طوارئ الأطفال بجامعة الفيصل بالرياض بمشاركة أكثر من 2500 طبيب وممارس صحي من مختلف دول العالم. يهدف المؤتمر لزيادة الوعي، معرفة الجديد لدى الممارسين الصحيين والمتعاملين مع الأطفال في الطوارئ.
للحديث أكثر ينضم معنا عبر الهاتف الدكتور محمد الفيفي، وهو رئيس المؤتمر العالمي لطب طوارئ الأطفال. دكتور صباح الخير، أهلا وسهلا بك معنا في اليوم.
يسعد صباحك دكتور.
أهلا وسهلا، حياكم الله.
الله يحييك. يعني دكتور، حول هذا التخصص طب طوارئ الأطفال نتحدث عن مؤتمر عالمي، على ماذا ستركزون؟
طبعا بسم الله الرحمن الرحيم. شكرا للإخبارية والتي دائما ما شاء الله تتابعنا في معظم المؤتمرات والنشاطات اللي دائما يقدمها الأطباء. طبعا المؤتمر هو استمرارية للمؤتمرات السابقة اللي كنا من أكثر من 15 سنة قاعدين نقدمها، وطبعا الحمد لله بتوفيق رب العالمين وبدعم من المسؤولين استطعنا ان احنا، وهذه الأول مرة على مستوى المؤتمر في العام الحالي هذا، انه نجمع اكبر جمعيتين على مستوى العالم في طب الاطفال وطب طوارئ الاطفال، وهي الجمعيه الامريكيه لطب الاطفال والمرجع في WHO للاطفال، وكذلك جمعيه الكليه الامريكيه لاطباء الطوارئ وهي المرجع لاطباء الطوارئ. فاستطعنا ان احنا يعني يكونوا معنا كو-سبونسر كمشاركين وكمسؤولين في المؤتمر، وهذا يعتبر إنجاز، وهذا طبعا بدعم وتشجيع من الجمعية السعودية لطب الأطفال، وكذلك جامعة الفيصل ممثلة في رئيسها الدكتور بروس الهيازع ونائبه الدكتور قطان. فالحمد لله، وهذا توفيق من رب العالمين أولا وآخرا. طبعا زي ما ذكرت الحضور حوالي 2500 طبيب وممارس صحي من مختلف العالم يناقشون الحديث والجديد في طب طوارئ الأطفال، وطبعا عن بعد على منصة زوم. طبعا هذا استمرارية في التعاون اللي بين المملكة وبين أمريكا في المجال الطبي، واللي هي تعتبر الأمريكا الشمالية هم الرواد في الطب، وهذه هي الرؤية والهدف أن نوصل إلى أن نكون من أفضل المراكز على مستوى العالم. والحمد لله الآن الحضور في المؤتمر من أمريكا، من أوروبا، من فرنسا، من كل مناطق العالم الحمد لله. وصل المشاركين إلى هذا الصباح تقريبا 2500 مشارك يناقشون جميع حالات الأطفال اللي تراجع أقسام الطوارئ من حالات مرضية إسعافية كحرارة، كنزلات معوية، إصابات، كسور، جراحة. طبعا جميع الممارسين الصحيين ينصح بحضور هذا المؤتمر على مدار ال3 الأيام القادمة اللي هي اليوم الثلاثاء والأربعاء والخميس، وكذلك يشارك في مع نخبة من الأطباء السعوديين المتميزين والاستشاريين من مستشفى الملك فيصل التخصصي ومركز الأبحاث بالرياض ومدينة الأمير سلطان الطبية العسكرية، وكذلك مدينة الملك خالد الجامعية بالرياض.
نعم.
بالإضافة زي ما ذكرت لكم متحدثين عالميين طبعا من أمريكا.
جميل. دكتور محمد، يعني من أهداف المؤتمر هي زيادة الوعي يعني معرفة الجديد لدى الممارسين الصحيين المختصين بطب طوارئ الأطفال. ما المعلومات الجديدة في هذا القسم؟
أيوة طبعا المحاضرات عندنا أكثر من 20 متحدث راح يتناقشون وراح يتحدثون في أوراق عمل جديدة في الجديد في طب الأطفال. يتكلمون مثلا عن طبعا بدأنا المحاضرة بتاريخ طب الطوارئ في المملكة وتاريخ طب الطوارئ وطب طوارئ الأطفال في المملكة، والحمد لله الآن نحن متميزين في هذا التخصص، وأصبح لدينا برامج تدريبية تنافس البرامج الموجودة في أمريكا الشمالية، وأصبح لدينا أيضا برنامج للزمالة للطب طوارئ الأطفال يتدربون فيه عدد كبير من الأطباء من دول الخليج ومن الدول المجاورة، وذلك بسبب النجاح، وإن مستواه يعني مماثل للمستوى في شو اسمه في استغفر الله في نورث أمريكا، في أمريكا الشمالية. طبعا بالنسبة للنقاش سؤالك إيش اللي راح يناقش في المؤتمر، طبعا كيف تحسين الوضع في أقسام الطوارئ، كذلك الجديد في علاج بعض الحالات اللي تجي لقسم الطوارئ، مثلا التحسس الشديد من بعض الحلويات، من بعض الأدوية، من بعض القرصات وكذا. خبراء من أمريكا راح يناقشون هذه الأمور، إيش التحديات اللي تواجهنا في أقسام الطوارئ، الازدحام في أقسام الطوارئ إيش أسبابه وإيش حلوله. كذلك نتحدث عن إيش الجديد وإيش الأبحاث والدراسات اللي تمت في آخر سنتين في مجال طب طوارئ الأطفال. نتحدث كذلك عن الاحتراق الوظيفي للممارس الصحي في قسم الطوارئ. كما تعلمين أنه يعني في قسم الطوارئ الطبيب أو الممارس الصحي يواجه معاناة في قسم الطوارئ بسبب الضغط والستريس، ولا يخفاك برضو الحالات اللي يواجهها، قد يواجه حالات حروق، قد يواجه حالات وفيات، فتكون صعبة. إصابات الرأس وكيف التعامل معها، إيش الجديد فيها، وكذلك التحسس والحساسية عند الأطفال، الحرارة عند الأطفال.
Okay, Dr. Saleh, if you allow me, please, because there is some few questions حتى يحضروا الوقتية. Okay, خلود انتظري، الله يخليك، يخلي الدكتورة بروفيسور مريان تنتظر شوية عشان في بعض الأسئلة والاستفسارات اللي أرسلوها الزملاء في الموقع في الكويشن بوك، وأنا أعتقد أنها تحتاج إلى إجابة. طبعا بعضها بتوجه إلى نفس المتحدثين، أوكي، والبعض الآخر إن شاء الله راح يتوجه إلى يعني بعضها أمور فنية، يسألوا مثلا عن is it important to write my name here and my I think we have said so many times, and Dr. Saleh mentioned it also, and he wrote it too in the box answer and question box, that there is no need to write your name or your mobile or your email or your Momaris number. Please, once you enter, you will be automatically hours will be credited for you, and you have to attend more than 70% of the activity. What is the indication of admission to patient who with anaphylaxis? Those who are still under cardiopulmonary distress, they need to be admitted. But all these questions, it will be directed to their speakers, and we will send it to you. You will have it by the end of the day or tomorrow in word sheet. كلها موجودة زي على السكرين. كل الأسئلة وتحتها الأجوبة. Okay. Some of you asking about can we get the lectures and videos and these things. This will be available on the website of the company Future Vision, and you can review it there. If you like to record it, it's up to you. Also, some was asking about the certificate and what time we should get the hours. طبعا it will take like 3 to 5 days till it will be in your Momaris. I don't think there will be a problem. I think Saleh, you can start now with the Dr. Mariana, please go ahead.
Okay, Dr. Mariana, we're going to start with her as challenge cases that really looks a challenge in the pediatric emergency. Kindly start, Dr. Mariana. Welcome.
I am Dr. Marian Gaushi-Hill, and I'm going to present a case of a 4-year-old girl with altered level of consciousness. All right, this is a 4-year-old who was brought in by paramedics with altered level of consciousness. Her grandmother called 911 after discovering the girl lethargic. You can see her temperature is normal. Her heart rate was 60, respiratory rate was 18, and blood pressure was 80/60. Pulse ox is 98% on room air. I'd like you to think about her vital signs and her presentation in figuring out what the differential is. So this is a child who came in. If you think about the pediatric assessment triangle on this gal, now the three arms of the triangle are appearance, work of breathing, and circulation to the skin. Her appearance was clearly off, but her work of breathing was normal. Her vital signs were normal. Now she was in the normal range for heart rate, but her heart rate was low overall. For a 4-year-old, you wouldn't expect it to be 60. But she didn't have any skin signs, no respiratory distress, no other signs of shock. As you saw, her blood pressure was in the normal range for her age. So I would call this CNS metabolic. And when we think about this, the things that drive management for this is going to be checking oxygen level, checking a glucose as an example, and thinking about potential causes. She had no seizure activity as well. So back to AEIOU tips, you can see all the different things that it could be. Those highlighted in red are things that I thought about. Overdose, could she have overdosed? She was at grandma's house. Trauma, could she have fallen down? Poisoning and seizure. Now, it's not that I had ruled out all of these other things, but I did, these were the highest things that I was thinking about. I'm going to go ahead and stop my video here for a second, just so you can see the whole slide. So what key historical fact gives a clue to the cause of the lethargy? And yeah, she was at grandma's house, right? And so you always think, what about medication? Grandmother says she is only taking vitamins and no other pills. And this is really interesting because this was a lesson that I learned. It's how you ask it. So remember, there's many routes to medication, right? So I said, are you taking any medication? And she interpreted that as pills and said, no, she only takes vitamins. But it turns out there's other deliveries, right? There's pills, there's salves, or, basically ointments, patches, right? Injectables, eye drops, and holistic meds, or could be what some would say either holistic meds or organic meds. These are like your St. John's wort or other types of medications, which people don't think of as medications, but they are. In this case, I really thought it could be a toxin, but then I needed to consider what route is it? Ingestion, inhalation, transdermal, injection, what method is it? Anyway, she was altered. We put on a monitor. We checked her rapid glucose was normal. Her hemoglobin was normal. I did a 12-lead EKG. We also drew bloods. I sent inborn error labs. So the glucose was normal, but ketones, ammonia, and lactate, I sent those. We did a chest x-ray on her, which was negative, and she was getting ready to roll to the scanner when I wanted to evaluate all of her skin. And this is another lesson. Make sure you look at all of the skin, right, as part of your evaluation. And we found this on her right knee. And what this is a clonidine patch. And clonidine is an antihypertensive, an alpha-2 agonist. It also can be used in the treatment of opiate withdrawal. It can be used for ADHD, but in adults, it's typically an antihypertensive. And some will use this transdermal system with a patch in order to get a more even delivery of the medication in older patients. But severe toxicity has been shown in children with as little as 0.1 milligrams. It's in the one pill can kill category. You can see the list here: calcium channel blockers, clonidine, obviously, lamotol, salicylate, sulfonylureas, tricyclic antidepressants are in the list, but this is not an exhaustive list. It's just something to consider. So overdose, what do? You can observe for 4 hours if no symptoms, consider discharge if it's if it's a small amount. If it's greater than 0.2 milligrams, it may be best to admit. You would stabilize the airway. Her airway was fine, so there was no need. She wasn't hypoxic. Now, I've tried naloxone, but it's not clear if it affects outcome. In honesty, I've not seen it work. Others have reported that it has worked, but I haven't seen it. And then I would do skin decontamination. Obviously, we removed the patch and then we scrubbed the skin and cleaned the area. And then GI decontamination. Often these kids are really altered, like our patient. So I probably wouldn't do it. This patient's too sedated and it's really not that helpful. And given that the sedative effect is much greater than the cardiovascular effect in children, you probably don't want to do that. You could give atropine for bradycardia. Now, she was close to the borderline, but we didn't give it to her because I felt she was stable enough. And once we removed the toxin, I felt that she would recover. And you can use pressors. So what happened is she fell down and scraped her knee, went to find a Band-Aid, found this clonidine patch in grandma's, medicine cabinet, pulled it out and placed it on her boo-boo. And that's meaning scrape or abrasion. And that's when boo-boo is a name that children use in the United States for an abrasion. So we removed it and scrubbed it, as I mentioned. She was admitted to the PICU because she was still altered. And she literally woke up about 3 hours later and said, what happened? She was really scared, but she did well and was discharged from the PICU. And I think the take home for this case is one, keep your differential broad, but consider toxins. And when you're asking about exposure, consider all routes. And that includes, as I said, organic, holistic, or herbals. And also patches, drops, injectables, and eye drops too can be utilized. So with that, I will see if there's any questions, and thanks for listening.
Thank you, Dr. Marianne. I think we should go to the next case, please. And if there is any question, please send it to the inbox of question and answer. Okay, so let's start with the next case, please. Okay, go ahead.
This is Mary Ann Gauchi Hill, and I'm going to present a case of a 12-year-old girl with vomiting. So this is a 12-year-old girl who presents with 2 days of vomiting and abdominal pain. She was seen yesterday at a local hospital and given a diagnosis of acute gastroenteritis. You see her vitals, she's a little tacky, respiratory rate is 16, blood pressure 100/70, and she's afebrile. Exam is normal, except mild lower abdominal tenderness, right greater than left, and there's no rebound. So what's wrong with this diagnosis? So AGE implies vomiting and diarrhea, and the patient only has vomiting. So when you think of vomiting alone, you have to be worried that it's a nonspecific symptoms, but it could be a harbinger of a serious diagnosis. Could be, as an example, UTI or pyelonephritis, sepsis, meningitis, and you can see the many things: toxin, ingestion of alcohol, metabolic such as DKA, and abdominal. When we think about abdominal causes, for children, we have to think about what are things that present at what age. So hours to days, you consider necrotizing enterocolitis, weeks, pyloric stenosis. There could be other things here too. Weeks to months, midgut volvulus, although most occur within the first month of life. It's a susception, less than 2 years is most common, but it can occur at any age, but it's the most common cause of abdominal obstruction in children or intestinal obstruction. Greater than 2, think about appendicitis, ovarian torsion. You could have PID, pregnancy, and any age you consider medical causes. I mentioned UTI as well. So what happened? We examined her. She did not have an acute abdomen, but she did have some significant abdominal tenderness. So she was given 1 liter normal saline. We did some testing, and an acute abdominal series was ordered to look for, let me back up one, to look for signs of intestinal obstruction. So what labs are missing here? I think it's really important, based on what I said, to hit a UA, to get a UA. And she's 12. She had started her menses at age 11. And so it is a consideration. I have seen children who are pregnant before they have their first menses. So it is important to, and that was from child abuse. But with that said, preteen, teen, it's definitely a consideration. In fact, about 30% of teenage girls get pregnant at least once before they reach the age of 20. So the urine pregnancy test in this case was negative, and her UA was negative as well. Here's her, it just shows the pelvis part of her KB and upright. You can see she has teeth located in her pelvis. So this was ovarian torsion secondary to a benign cystic teratoma. I think today I wouldn't have got a KB and an upright unless I had some significant concerns. Probably what I would have done, given that her tenderness was really in the lower quadrants, I would consider whether it was an API, maybe doing an ultrasound. And when we do API ultrasounds, we also send them for a look, females for a look at the ovaries. So that would have helped us in this particular case as well. But it just so happened this is a time that this child presented that we did do a KB and an upright and noted teeth in the pelvis. 37% of teratomas are found in the ovary tumor with at least 2 germ layers. So I wanted to talk about ovarian torsion in pediatrics. We don't think it exists because it's not as common in adults, but it turns out that it does. And about 10 to 15% of cases occur in the pediatric age group, so under the age of 18. It's been reported in a neonate to postmenopausal women. The mean age in pediatrics is 10 years old. And the causes are cysts, teratomas, and malignancy is relatively uncommon. In terms of diagnostic imaging for this, ultrasound is most useful diagnostic aid with color flow Doppler. But you need to understand that there are, and we'll get into this in a second, that there is a dual blood supply to the ovary from a uterine artery as well as one at the ovary. So the issue is that you may see normal flow, but still have ovarian torsion. So you're going to have to use clinical judgment along with the signs and symptoms, as well as this diagnostic imaging with ultrasound to establish the diagnosis. And if you can't, then they often undergo laparoscopy. Anyway, what you may see is something enlarged like we did with our patient, but in this, it's obviously cystic. Hers was a cystic teratoma. The median volume of cases of ovarian torsion is 12 times that of the contralateral ovary. So again, normal flow does not exclude torsion. It may be present in up to 2/3 of patients because it receives blood supply from the uterine and ovarian sources. And then, as I mentioned, laparoscopy may be the only way to do it. The way we have done it, you suspicious, if there's a mass, we consider ovarian torsion. If indeed the patient remains significantly symptomatic, we get OBGYN involved. The other thing you can see are these cortical follicles, and it's demonstrated here. There's cortical follicles, so it is something that you may see as a sign of ovarian torsion. Computed tomography could be utilized. We did not use that in our patient. We just did an ultrasound and it was positive. But you can see the cortical follicles present even in on CT scan, and you obviously see a cystic mass. So here is our patient. Ultrasound demonstrated the large teratoma. We consulted GYN and she underwent laparotomy and oophorectomy on the one side, but the large mass, and it clearly had twisted multiple times at the time of surgery. Take-home points, not all vomiting is early AGE, and of course you really have to think more broadly and consider serious disease with vomiting alone, as well as don't forget to keep ovarian torsion in your differential for relatively sudden onset abdominal pain, even in the pediatric age group. And with that, I'll take some questions. Thanks so much.
Thank you so much, Dr. Marianne, for these really interesting cases. I think we will leave the question till we finish all the cases is better. So please keep writing your questions. So we'll go ahead with the next case. Go ahead, please.
Hi there, my name is Dr. Marianne Gaushi-Hill, and I'm going to present a case of a 13-year-old with altered mental status. Okay, let me share my screen. So as you walk in for your shift, the night MD is walking with a boy to the scanner. The patient has a history of juvenile diabetes and is on insulin, complains of sudden onset of headache and altered mental status. Patient is alert, non-diaphoretic, afebrile, but with confusion and able to answer questions slowly. The nurse reports that the glucose is normal. And we actually checked it twice because I was concerned about the history of diabetes. Vital signs are normal for age. There's no hypertension. There's no toxidrome. Pupils are normal. There's no papilledema, concern for basically intracranial hypertension. It doesn't have that. He was able to state his name, had trouble with complex questions. He couldn't even do simple math like 2 + 2, and he had difficulty with any executive functioning, such as finger to nose tests and things like that. Although he had a non-focal neuroexam, he had normal gait, strength, and sensation. I asked his mother what his favorite course was in school, and it was math, but it was clear that he was not able to do math at this time. So differential, what do you think about here for altered level of consciousness or altered mental status? So I like to use the mnemonic AEIOU tips. This is from APLS, the Pediatric Emergency Medicine Resource. And I've added kind of my own things to this. The key thing with mnemonics is you've got to know what it stands for. So it could be alcohol. He's, old enough to try drinking, even though he shouldn't. Ammonia, and that's for inborn error, abuse, atypical migraine, electrolytes, encephalopathy, encephalitis, infection, overdose, and oxygen, hypoxia could do it. Uremia, very uncommon in children. Trauma, and you have to think about child abuse as well. Tumor, insulin, intussusception, he's old for that, although it can occur in any age. It's the most common cause of abdominal intestinal obstruction in children under the age of 2. Inborn errors, it can occur at any age. And so asking if this has happened before or family history would be helpful. Psychiatric, poisoning, shock, stroke, seizure, and seizures is possible. You could have a petit mal status as an example, shunt, and then probably the most serious thing is subarachnoid hemorrhage. So I listed those. The ones that were high on my differential are in the orange that you can see here. Here's some key questions, and I think this has really been very helpful for me for recurrent syndromes. Has this ever happened before? In this case, the answer is no, but if it had, you think about inborn error, I would think about potential for seizure as well. Has he ever had a headache like this before? And the answer is yes. There's a family history of migraine headache, but his headache never was associated with altered mental status. Any drug use, depression, toxins in the home? And the answer is no, and no one else in the family with similar symptoms. The answer is no, and that's really helpful. Anyway, I began the treatment for migraine. First of all, he had a CT, and labs were normal. CT was normal. Now what? So I began the treatment for migraine. I also thought about petit mal status, but with a history of migraines in the family, and he's had headaches before, I began compazine or prochlorperazine and diphenhydramine, and he definitely was improved, but remained a little bit confused. So we did an LP on him. His opening pressure was normal, and everything else was normal. There was no organism seen. So really, the issue is, what should we do next? And because he had some resolution of symptoms, although it wasn't back to normal, I decided to try a second-line agent for migraine, and I gave him 20 milligram per kilo of valproate, and he became a straight A student, meaning he really turned back to baseline. And I felt that this was a confusional migraine. So I wanted to present this, to talk to you about this, and the differential, again, as you saw it, petit mal status to me, once his CT was normal, I knew he didn't have subarachnoid hemorrhage, that petit mal status would be a consideration, but with the history of headaches, typically with petit mal status, there's no headache associated with that. So I diagnosed him as confusional migraine, but it could present exactly like that, short of the headache, meaning sudden onset of altered mental status, so a consideration. So migraine variants, turns out they're relatively common they're not common, but they're not uncommon. So they're more common in children than they are in adults. And so the types of atypical migraines are hemiplegic migraine. So there'd be concern it's a stroke mimic. Ophthalmoplegic migraine, again, that also could be a stroke mimic. It also can present with cranial nerve palsies. Basilar artery migraine, and these are more common in girls and associated with vertigo. Confusional migraine, and this is what our child had, changes in personality, behavior, orientation, or memory deficits. He really did not have good executive functioning. And then Alice in Wonderland syndrome. I had a friend whose daughter presented things looked big, and then they were small, and they were big. And so distortions in vision or time, and then abdominal migraine, and my son had abdominal migraine. So I was very interested in these various variants. A few more to consider is paroxysmal torticollis and then ocular migraine, which can be associated with loss of vision, and you have to think of amaurosis fugax or a vascular cerebrovascular event. So what do you do with the migraines, atypical migraines? I would treat like a typical migraine. Obviously, you need to rule out other issues and as part of the differential and see if the symptoms resolve. Typically, I use compazine and diphenhydramine. Ketorolac has been used successfully, but I find compazine works better, and there's been some randomized trials that show that. So what we did, this patient got completely well. I referred them to a pediatric neurologist through their pediatrician. And you may want to consider, if it's an unknown cause, I would obviously admit the child. But with that said, that is my case, and we'll take any questions. Thanks so much, and it's great being with this conference.
Thank you so much, Professor Marianne, for these interesting cases. And I think it's better to leave the question till we finish all the cases, because I'm sure our audience, they have a lot of questions regarding these 3 cases. We are going now. Khulud, can you please invite Professor Mohsen Sanjed? Yes. Now,
Saidinashad, I'm a professor
Go ahead.
of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. I'm also the director for the Institute for Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation at Harbor UCLA. And today I'll be presenting to you a challenging case presentation of a recent case we've had in our emergency department. And the title of the case is Newborn with Vomiting and Lethargy. So this is a case of a 15-day-old baby girl who's been vomiting for 4 to 5 days, has become progressively more sleepy. Patient's mom brought the patient to the hospital in her own car to the ambulance entrance and asked for help. This patient was seen 3 days earlier at a different emergency department because mom reported forceful spitting up, decreased drinking, irritability, and less wet diapers. In the other emergency department, they did an evaluation. The baby's physical exam appeared to be okay. Patient also had an oral challenge and was able to successfully tolerate 60 cc's of formula. In addition to that, mom reports that they did an ultrasound of the baby's abdomen, and they reported that the ultrasound was negative, in fact. Then today, mom has brought the patient to the hospital to us because the baby is now absolutely refusing to drink anything at all and seems to be sleeping almost the entire day. So the question we're going to focus on first is, was there anything else in that first visit that would have triggered any additional workup? So I put that in a box here to think about for a moment. Would you have done anything differently for this patient? Okay, now moving on to the case, we wanted to say, okay, so this baby has been having spitting up. Does that necessarily need a workup beyond what they did? The answer is maybe, maybe not, but it depends on what kind of red flag issues we would see. Now, we know that the prevalence of spit up in babies that are healthy is very high. As many as half of the babies who are perfectly healthy do spit up on occasion and sometimes a lot. Babies tend to spit up because either they're overfed, or maybe they have gastroesophageal reflux, or they don't like the taste of the formula that they have, especially if there's been a recent change. The baby also in the other ER tolerated feeding, and the exam was fine, and the ultrasound we're assuming that was done for pyloric stenosis was negative. So that by itself doesn't raise any questions. And again, these are 2 resources to review how frequent spit up it actually is and how parents are given reassurance about spitting and what specific things to look out for that would trigger something other than a regular spit up diagnosis. So in this case, though, the baby was irritable, the baby had reduced wet diapers, was drinking less, and the spit up was forceful. So this is a little bit kind of more concerning than just a baby who spits up. So in our emergency department, the baby was tachycardic, tachypnic, slightly hypotensive, but the temperature was okay, saturations were okay. The exam, as you can see, sleepy, difficult to arouse, and distinctly delayed capillary refill, weak pulses, only response to painful stimulus, and this is the GU exam, which was not really commented as abnormal, according to mom from the previous visit. In terms of birth history, baby was delivered at home at 37 weeks of gestation, so pretty much full term, and there was no issues reported at the time of birth. So we placed the patient on a cardiac monitor, we placed an IV. We tried to place an IV, we were unsuccessful. We ended up placing an intraosseous line. We started 20 cc per kilo through the intraosseous line, and then with further attempts, we were able to establish an intravenous access. We ordered labs, chest x-ray, and an ECG. Here are the labs. As you can see, metabolic acidosis on the blood gas. The CBC looks generally okay. The BMP is concerning because sodium is 125, potassium is high, bicarb is low. Even I would argue BUN is very high and creatinine is high for age. But most importantly, baby is also hypoglycemic and has a high lactate. So what do we do next? We do have to do some corrective actions here. So first, we think of metabolic problem of salt-losing enteropathy. So we're doing an ECG also because of the potassium being high. And we thought about mineralocorticoid deficiency that gives you low sodium, high potassium. So hydrocortisone 25 milligram IV was started. This was the ECG, as you can see, peak T waves that confirms the hyperkalemia that we saw in labs. So that makes you consider the next action for that being considering calcium gluconate. So back to the case, our problem list, we have hypoglycemia. We start an immediate dextrose dose, and we gave 5 cc per kilo of D10. We could also do 2 cc per kilo of D25. At my institution, we don't really use D50, but if you did D50, it would be 1 cc per kilo, so 5-to-1 as our rule. And we also have some evidence of hypotensive shock with the slightly lower blood pressure and poor perfusion. So we did end up reevaluating the patient after first bolus was done. There was a slight bit of improvement. Cap refill was slightly improved. And blood pressure had slightly improved as well. So we gave a second bolus now that we have the IV established. We have even better blood pressure now, a little bit better cap refill, and the patient is now becoming more alert, which is great. But we decided to give the patient a third bolus, and we can do up to 60 cc per kilo typically if after every evaluation of 20 cc per kilo, the baby is looking like they are not decompensating. Hyperkalemia, we did 10% calcium gluconate. This table here shows the agents that we would consider for our hyperkalemia, the immediate acting ones, the medium acting ones, and the late acting ones. So calcium gluconate is what we used. We could also use hypertonic saline, which we didn't in this case. We just went with the calcium gluconate. You could also use shifters such as insulin and albuterol that usually take between 20 to 30 minutes to kick in. And then you can also use additional like sodium bicarbonate can take hours. We're very careful with sodium bicarbonate. Our pediatric ICU doesn't love sodium bicarbonate, but when we do it, it has to be under great care to do that. CBC was normal, so no action needed. Chest x-ray is shown here. Chest x-ray also looks normal, no action needed there. So then we just continued to manage our electrolytes as we were doing. We admitted the patient to the pediatric intensive care unit, and we consulted pediatric endocrinology. So this was a case of congenital adrenal hyperplasia. As you can see, the clitoromegaly and posterior labial fusions on the image was part of the diagnosis. This is an autosomal recessive condition. The most common type of congenital adrenal hyperplasia is the CYP21A enzyme deficiency. The 21-hydroxylase deficiency accounts for the great majority of these cases around the world, 1 in 15,000 live births. There's also another variation, which is the 11-beta hydroxy deficiency, and that's more common in individuals of Middle Eastern descent. That rate is 1 in 1,100 live births. Usually, as you know, it results in excessive or deficient sex steroid production. It causes a risk of adrenal crisis with hypoglycemia. So that hypoglycemia that we had was part of that sign of a potential adrenal crisis. Usually it's triggered by an infectious etiology. So maybe the preceding illness was how it was discovered. But we did not really have any evidence other than refusing to feed and irritability. On this patient, no fever was reported, no URI symptoms, but that is some of the considerations to have. There's also changes in first primary and sexual characteristics, as you saw, that was on that examination in this patient. We have congenital adrenal hyperplasia listed in the universal newborn screening in the United States and many countries, but as you remember, this baby was born at home, so therefore did not have any screening for that most likely. This again, I just put in there to show you that the crux of the problem is elevated ACTH resulting in elevated androgens, which was the case in our presentation. Take-home lessons for this: you have to have an index of suspicion. There were a few things during the first visit that could have deserved more workup, and that includes the irritability, the forceful vomiting, which beyond pyloric stenosis may be potentially worth evaluation. The reduced wet diapers and reduced drinking was a problem that should have been further evaluated. And the baby was born at home, which is something that could be considered. I added this really cool article here for reference for you from New England Journal of Medicine. It's an old article, but it's really, really great. It essentially goes through all of the different elements that are involved in congenital adrenal hyperplasia. Thanks very much. Just wanted to say this case was inspired by a similar case that was on the SIMCARs that's found on Apple Books. Not exactly the same case, but it's similar in many ways. So I just want to give credit that I did see that case presentation similar. So when I saw ours, I decided to kind of line it up in terms of presentation with that. So I appreciate that. And here's my contact information. Please feel free to email me with any questions. And again, thank you very much for the opportunity to speak with you today.
Thank you very much, Prof. Muhsin. We will go now to the next case, also with Dr. Muhsin. It's about abdominal pain, I think. Okay, go ahead.
Professor of Emergency Medicine and Pediatrics at the David Geffen School of Medicine at UCLA. I'm also the director for the Institute for Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation at Harbor-UCLA. And today I'll be presenting you one of my interesting case presentations, a child with fever and abdominal pain. The case is an 18-month-old male who presents with vomiting, diarrhea, and fever. Mom reports that he's been sick for 2 days, but has gotten a lot worse this morning. Slept most of the morning, feels very hot to touch, and mom reports that he's been grunting. Patient was brought in their own private car and was immediately taken back from triage because the baby was not looking very well. This patient was seen 2 days earlier in a different emergency department and was diagnosed with acute viral gastroenteritis and was discharged home with supportive care. His vitals, as you can see, he has a high fever, tachycardic, tachypneic, and hypotensive. He looks sleepy, arousable only to pain, has extremely dry mucous membranes, and delayed capillary refill. Cardiovascular-wise, just has tachycardia. His abdominal exam is significant for diffuse tenderness to palpation throughout the abdomen. He does guard, but it's very hard to determine if he's actually having rebound tenderness or not. His GU exam is normal. So what is differential diagnosis for this sleepy, dehydrated baby who is having abdominal pain and has had episodes of high fever? So again, acute gastroenteritis is a reasonable diagnosis to continue with, especially viral gastroenteritis. There could also be bacterial or parasitic, depending on travel history or exposures. Having a urinary tract infection with acute pyelonephritis is a possibility. Although he's a male over the age of 12, the risk of UTI is lower on him, but still a possibility. With diffuse abdominal pain, you can also consider acute cholecystitis. Again, he's not the right age for that, but it's on the differential. Appendicitis is more rare in children who are younger, but appendicitis can definitely be a possibility, especially given the guarding and the diffuse abdominal pain. Intussusception, the fever doesn't really go with it, but perhaps the fever is a marker of an acute viral illness that caused mesenteric adenitis that could act as a lead point, and that could be leading into intussusception because he's in the correct age. Intussusception is usually between 6 months and 36 months, so that's on the thought. New onset diabetes, hyperglycemia, definitely on the list. Again, the fever doesn't go with it, but it could be on the differentials, as are medications, ingestions, other inflammatory bowel disease, and definitely testicular torsion should be considered because any boy that comes in with diffuse abdominal tenderness should have a testicular exam. Again, fever doesn't go with that, but these are the list of differentials that we generated for this patient. We placed an IV access. We gave 20 cc per kilo of normal saline. We gave acetaminophen 15 milligram per kilo per rectum. He was not able to tolerate anything by mouth. For us, we have a range of 15 to 30 milligram per kilo, and depending on the weight of the patient and the size of the suppository, we will range it between 15 to 30. We also did the blood investigations, as you can see here, including a viral panel. And for imaging, we decided to consider a abdominal ultrasound to see if we see anything like appendicitis or intussusception. Our labs, as you can see here, metabolic acidosis, white count is elevated, differentials are left shift, slight hyponatremia and acidosis, as you can see. Liver function tests are normal, lactate is elevated. UA shows this is a clean catch urine, not a catheterized urine, and this was 4 to 5 WBCs with trace leukocyte esterase and negative nitrate. Sorry, I apologize. The urine was catheterized, and that's the result. In terms of abdominal imaging, we did the ultrasound. The ultrasound showed moderate free fluid in the pelvis with no evidence of diffuse inflammation. They were not able to visualize the appendix, which is not unusual at my institution. We don't have really great appendix visualization on our ultrasounds. We're somewhere between 5 to 10% visualization. In an ideal scenario with a sonographer who's trained in pediatrics and has done a lot of appendicitis evaluations, you can get as high as 70% in terms of visualization. But in our institution, we unfortunately don't have great rates. So this was not an unexpected finding. So because of that, and because of the fever and the white count and the diffuse abdominal pain, we decided to go ahead and do a CT with IV contrast. The CT was actually diagnostic. It showed a partial visualized appendix with a fecalith that is almost 1 centimeter, moderate fluid and fat stranding, and the radiologist read that as ruptured appendicitis. And here is the CT showing where the fecalith and the ruptured with the fat stranding and periappendiceal processes here. So pediatric surgery was consulted, IV antibiotics started, and pediatric surgery decided to take him directly to the operating room because of the risk of complications associated with a ruptured appendicitis. So in terms of appendicitis, it's one of the most common non-traumatic surgical emergencies in children. 250,000 cases of it reported each year, but they're mostly in the adolescent age group. The incidence for smaller babies up to 4 years of age is only 1 to 2 per 10,000 children. But when you get into adolescent age group, that increases to 25 cases per 10,000. There is a male to female slight predominance of 1.4 to 1. And appendicitis also affects different segments of the population differently. On my other talk that I'll be doing, the non-traumatic surgical emergencies, I go through the epidemiology of appendicitis there, since we have more time on that talk. So in children under 5, there's some challenges. First of all, appendicitis does not present a typical fashion. You don't get rebound tenderness and right lower quadrant pain in almost a third of the cases. So because of that, it's easy to miss. Children under 3 also have a faster progression to perforation. So from the time that it starts until it ruptures could be as little as 2 days, which is why you often catch them as they're already ruptured. And that is why the morbidity is significantly increased for appendicitis in small children. And all of the appendicitis scoring systems that we use, and there's a few of them, and I'll talk about them in a second, they don't really perform well for small children. And some of them actually say don't use the scoring system for children under 5. This paper that I referenced here to the right talks a little bit about the challenges in managing and diagnosing appendicitis in children under 5. This is one of our appendicitis scores that are used. We don't use this at our institution, but many do. The issue for that scoring system is you do need to get a CBC in order to get the leukocytosis and the absolute neutrophil count. And again, it just very yes or no oriented. 5 or under is a no, 6 or higher is a yes. And the elements include evaluation of pain, anorexia, vomiting, and fever with the addition of the leukocytosis. This is another one. I don't think this one even performs as well, but this is the Alvarado score. Just wanted to show you the different types of appendicitis scores that we use in the United States. And that some of these are integrated into the electronic health system, so people can actually go and do their scoring. This one has a probable, possible, so it doesn't go exactly yes, no. And then this one, the one I like the most that I work with is the Pediatric Appendicitis Risk Calculator. This one takes into account how long you've had pain. It also sorts it out by male or female because of the prevalence. Looks at prevalence of pain with walking or jumping, and whether the pain is maximal tenderness is in the right lower quadrant. And again, it says here in the instruction, use in children above age of 5. So again, we can't use this for this patient, but it's a scoring system that I do use. Also, there are a couple others, the AIR scoring system and the Xenakis. The Xenakis is interesting because, as you can see on the right, presence of positive ultrasound scan finding of appendicitis gets you 6 points, and you need 8 or more to have diagnosis of appendicitis. So 6 points already out of 8, that means you're almost there with just the ultrasound finding. But as I say, the challenge is whether or not you're going to get an unequivocal ultrasound finding that says, yes, appendicitis. So take-home points for this is that appendicitis is a very common, one of the most common non-traumatic surgical emergencies in children. There are as many scores, none of them perform well really in the smaller age group. Ultrasound can be helpful. It's very operator dependent, so it depends on your institution. You must have a clinical suspicion to be able to think about it and be able to then do gold standard, maybe CAT scan to diagnosis. Or if you're 100% sure, then don't do any imaging, just call surgery. We have had cases where the case is so obvious that we have avoided imaging, and that's very important. Rebound tenderness is good diagnostic accuracy. Children under 5, remember atypical presentations and a quick to perforation. Thank you so much. I really appreciate the opportunity to speak with you about this case. And if you have any questions, please feel free to email me. If you also have any interesting cases that you want to share with me, I'll be happy to take those, and we can try to have a composite of all of the different cases if you are interested. Thanks again.
Thank you. Thank you very much. I think now we will go to the last case with Prof. Mohsen, and I think it will talk about seizure, odd case with like a seizure-like activity. So you can start, please.
Hi, I'm Dr. Saidinejad, and I'm a professor of emergency medicine and pediatrics at the David Geffen School of Medicine at UCLA. I'm also the director for the Institute for Health Services and Outcomes Research at the Lundquist Institute for Biomedical Innovation. And today I'll be speaking with you about my third challenging case, a child with status epilepticus. So this case is a 3-year-old female who has had 5 to 6 day history of cough, fever, and rhinorrhea. This morning, she became extremely irritable, and mom noted a brief seizure. The patient then went on to have an even longer seizure, at which case the mom called the ambulance to bring the patient to the hospital. During the transport, the patient continued to have a seizure despite receiving a dose of intramuscular midazolam that was administered by the paramedic. So the patient arrived to the emergency department still actively seizing. Total seizure time about 12 minutes at the time that we received the patient. Vitals, you can see here, the patient has a fever, slightly tachycardic. Respiratory rate is on the lower side for the tachycardia. Blood pressure is 68/50, and O2 sats are 94%. Patient is actively seizing, has a fixed gaze eye deviation. Exam, other than tachycardia, is normal and reassuring. No other findings noted. So what is the differential diagnosis of this child who has a generalized tonic-clonic seizure with a few days worth of URI symptoms? So infection is on the list. Of course, this could be a viral illness that causes a febrile seizure. It could be a bacterial illness that led to a febrile seizure. Seizure could be due to electrolyte abnormalities or toxic ingestion. It could be an unapparent trauma. So these are basically the differentials that we think of in terms of seizure, but of course, when you put the fever into the picture, some of these are taken out of consideration because they will be afebrile seizures. So we gave a second dose of midazolam, this dose of 0.2 milligram intramuscular, 2.2 milligram per kilogram of intramuscular midazolam. We usually do either intramuscular or intranasal unless we establish an IV line in the emergency department. But our paramedics are usually giving intramuscular or intranasal dose at the 0.2 milligram per kilogram. We also gave a dose of saline, acetaminophen 20 milligram per kilo PR. Our range dose for that is 15 to 30 milligram per kilogram. We also gave ondansetron for vomiting. We sent viral panel, basic metabolic panel, CBC, UA, lactate, and as you can see the rest. The patient then appeared to have stopped seizing, has a fixed eye deviation still, and hypertonicity remains. So they're no longer convulsive, but the exam is still showing baseline subclinical seizure activity. The labs, white count is very elevated, differentials are high. The basic metabolic panel is generally okay, a little bit of a decrease in bicarb, but not anything really interventionable. Lactate is 4.5 and viral panels are pending. Our UA was negative. Then we ended up giving the patient a dose of levetiracetam, 60 milligram per kilo. This is our second-line agent. We do use one of 3 second-line agents, either levetiracetam, or valproic acid, or phosphenitoin. In this case, we decided to go with Keppra or levetiracetam. That's the one we use more. After that, as the dose was infusing, because this levetiracetam infuses over 15 to 20 minutes, so during the infusion, appeared that the seizure stopped. Patient became briefly post-ictal, but then slowly started waking up and becoming responsive. She then started complaining of a severe headache. She stated that she couldn't see, and she was having trouble moving her arms and legs. She had an immediate CT performed, which was negative. We did a lumbar puncture, which shows a mild to moderate pleocytosis with an increased protein. We also applied a Cerebell device on the patient during this time, and Cerebell is a portable EEG monitoring device. We can do this because we actually are part of a national study of the Pediatric Emergency Care Applied Research Network. The study is called PEDIDOS, for children between 6 months to 13 years of age who are brought by paramedics who are witnessed seizure in the field. So this patient also qualified for the study. And because of that, the study uses the cerebral device. So we're able to actually put the cerebral device on the patient as well, which was great. Then in terms of progression, the patient was admitted to the hospital, received broad spectrum antibiotics, became less responsive overnight, had more seizure activities, and one of the seizure activities became extremely difficult to stop. And neurology recommended that the patient be started on phenobarbital infusion. Patient had been intubated overnight as well because of the fact that she was having intractable seizures. Remained comatose on ventilator support. We did an MRI the next day, which was diagnostic. And as you can see, that's the slice of the MRI. So this patient ended up having viral panel that was positive for Epstein-Barr virus, started on systemic steroids. She slowly began recovering. It took 10 days. So this was a case of acute disseminated encephalomyelitis that presented with seizure and URI. It's very similar to multiple sclerosis, but it's transient and reversible. Very, very difficult to catch unless you're really looking for it. One of the hallmarks is that fever onset is very rapid. You also have that characteristic ataxia, motor coordination issues, and visual complaints are also part of this. So the blindness that the patient was saying she couldn't see, and the fact that she couldn't see move her arms was a telltale sign. Just something quickly on seizure treatment. We need to identify, of course, the cause of the seizure. First line, always we go with benzodiazepine. The goal is to stop the seizure within 20 minutes with the benzodiazepine. If not, we go to a second line agent, which I said is one of those 3 agents. And then our third line agents, which are phenobarbital, propofol, ketofol, ketamine. We have a variety of third line agents. We basically chose to go with phenobarbital infusion. This on the right is a table or a figure that is from an article published in New England Journal of Medicine in 2022, I believe. No, I'm sorry, not actually 2019, that compared efficacy of these 3 second-line agents. So their dose equivalents with the same ability to stop seizure, but the dose is 60 milligram per kilogram for levetiracetam, 20 milligram per kilo for phosphenitoin, and valproic acid 40 milligram per kilo. So at those doses, they are equivalent in their efficacy in reducing, stopping seizures. So quickly wanted to talk about some of the work that we have done. This is a disclosure that I have to make about being funded by the Health Resources and Services Administration of the United States Department of Health and Human Services as part of an award that totals $2.5 million, with all coming from governmental resources. The contents that I present here related to our work is my personal statements, and in no way is endorsed or represents the views of the HRSA or the US government. So we have developed this educational content called PEAK, or Pediatric Education Advocacy Kits. I also mentioned this in my mental health talk because we do create these as part of a federally funded project. So we actually have a PEAK specific to status epilepticus. Everything we have is open access, no password needed, no fees. It's freely downloadable, shareable, without any restriction. And this QR code here is to take you directly to the PEAK site for status epilepticus. And the PEAK site, we have several elements there. We have articles on multi-center evaluation of prehospital seizure. We actually have a brief video that shows how a nurse prepares in the emergency department for an arriving patient who is seizing. There's also webinar, podcasts. We have different formats suitable for different audiences. We have pre-hospital content, patient and family content, and we also have an algorithm on how to manage pediatric status epilepticus, and you see a version of it that is on the right side here. These are also downloadable. You can print them. You can make posters out of them. So they're really useful. And we have bottom line recommendation on how to care for status epilepticus, including a medication table. We talk about our first and second line agents. So that's also available on that same site. So with that, I will close and thank you very much for allowing me to speak to you. If you have any questions, please feel free to email me. My email address is listed right there for you. Thanks again very much.
Thank you very much, Prof. Mohsen. And I think now we will go to the questions and answer. Okay. And still there is some questions which they are keep repeating this question. I don't know what's the problem, but anyway, it sounds like they didn't get the answer again. Some they are asking about the how do they get the hours? As we told you several times, that the hours will be automatically in your Mumaris at the Saudi Council. Okay, and the other some they are asking about the full program. You can go to the website www.icpem.co, and there is a program, the full scientific, and we are following the program very strictly. Okay. Now, for example, Dr. Yusuf bin Amir, he will present his lecture, but we are just answering now the.
I will start my session. Or?
No, wait, please. I will tell it. Okay, and so now, but just we are answering the question that we have like 5 minutes still until Dr. bin Amir will be joining us. He's already now with us. And but before that, we have to answer the question that we have received so far. There is do you screen patient? This is for Dr. Fadia Khattabi. We direct the question to her and she will answer and let us know. For those who answer for Dr. Timothy Dribbin about the anaphylaxis, I think there is 2 questions for him. And let me just give you the question and the answer. Okay, here is one question for Dr. Dribbin. What are the criteria for hospital admission in a patient experiencing anaphylaxis? And Dr. Dribbin, his answer, hospital criteria is uncertain, but would include hypotension or receiving more than 2 or more than doses of epinephrine, or persistent non-skin mucosal finding, like cardiovascular finding or respiratory finding. The second question is, what distinguish delayed anaphylaxis from biphasic anaphylaxis reaction? If a patient experienced severe anaphylactic symptoms that resolved before arriving to the emergency room and presented immediately after symptoms resolved, is there any room for epinephrine administration necessary during the ER visit? The answer was, if symptoms resolve by the time arriving to the emergency, okay, there is no need to treat with epinephrine. Many reactions resolve on their own or with antihistamine, and you should treat these symptoms and you should treat these symptoms in front of you rather than after resolving. So there is no need to give epinephrine. Another question, can you please send me the full agenda of the lecture so I can arrange my time? Okay, as I said before, all the lectures on the website, you can go to the website. It's very easy to access it, and then go to program. Once you click on www.icpem.co, it will take you to the program immediately. Okay, and okay. The rest of the question, please keep sending your question and we will answer it one by one. I will leave the microphone now for Dr. Hamad Al-Madi, who will present the next group. Dr. Hamad, you can start, please.
Thank you, Dr. Muhammad. Thank you for the invitation to be with you. We'll start the last session of our activity today. We'll start, this is my pleasure to introduce or present the first presenter or speaker. A patient present with child rash will be presented by Dr. Yusuf Ben Amir. He's the chairman of the Department of the Dermatology at King Faisal Specialty Hospital and Research Center at Riyadh. Welcome, Dr. Ben Amir.
Assalamu alaikum. Thank you for organizing committee and the scientific committee for inviting me. A special thanks to Dr. Al-Fifi for inviting me. As a dermatologist, you are seeing that a lot of consultation in the pediatric emergency room for kids with rash. In this presentation, I'm going to talk about common presentations that you might see in your clinic and that will help you in guidance and to manage and then to triage or refer them to appropriate channels. I don't have no conflict of interest related to these presentations. So when and what? How to identify an important skin eruption and when to manage and how to manage and then when to refer. These are the questions we hope to answer at the end of this presentation. If not, that I can't describe or discuss a lot of dermatological condition, I have chosen a few of these. The first case is a 3-year-old boy with this rash. It started 3 days after low-grade fever, runny nose, and cough. If you see, for the first look, you see this child with this erythematous macules and papules with some white papules on the buccal mucosa on erythematous background. These mucosa involvement, we call it Koplik spots. Fever, runny nose, cough, as well as skin rash. You think about measles. This is why it's very important to know the vaccination history of each patient and even to know what is the trend worldwide. You know that during the COVID pandemic, there was a lot of questions and delay in the vaccines. And one of the delay was in Philippines as well, where they do have an epidemic of measles. At the same time, there was questions about the vaccination by dengue fever and the complication of the vaccine. This is why some people postpone some other vaccines. So it's very important to know the epidemiology of the vaccination status of your patient and your community to keep measles in the back of your mind for fever, rash, and mucosal involvement. So the outbreak, it was in the Philippines during the COVID pandemic because of the delay in the treatment. And these patients present with the fever, cough, skin rash, as we mentioned, and the vaccination, it makes this very, very less likely to be seen. However, it's now going up and rising on the horizon as well. The other patient I will show you here is that a 2-year-old boy with the fever had a skin eruption, regular fever, runny nose, and if you examine them out, there are small ulcerations. And there is a maculopapular rash, mainly over extremities. Some of them are vesiculation. If you have fever, mucosal involvement, hand and feet involvement, this is a classic hand-foot-mouth disease. However, this triad, hand-foot-mouth disease, we see it only in 60% of patients. Sometimes we have hand and foot only, or we have mouth and foot only. So sometimes we have atypical cases as well. The cases of the hand-foot-mouth disease usually comes in clusters. What I mean by this, if you see one case of hand-foot-mouth disease, probably you're going to see another case either in the same shift or maybe the next day. So usually they comes with a change of the seasons. Usually they are more than one patient on the same day. And the thing that you might have 2 siblings. One of them, he has the full-blown pictures of hand-foot-mouth disease. The other one has atypical with like partial picture. And this is, we see it commonly as well nowadays. So one characteristic of the hand-foot-mouth disease, if you are lucky to see the vesicles, these vesicles are conical in shape. So they are not like purely rounded, but these are vesicles are rounded, are conical in shape. Let's go back again. You see the involvement of the hand-foot-mouth disease usually on the anterior mouth cavity. So you don't have it on the posterior mouth, on the tonsils. The one on the posterior mouth, usually herbangina, and the hand, the foot, usually in the anterior part. So if you have the mucosal involvement alone, you might think, oh, it could be mucositis of herpetic. But if you have the mucosal involvement with vesicular, mainly over arms and legs, or like maculopapular rash on arms and legs, this is hand, foot, mouth disease. So it comes in outbreaks as well. People with severe atopic dermatitis, they might have superimposed Coxsackie virus infection. And this looks like almost like eczema herpeticum, but we call it eczema coxsackium. So this is, again, the same thing. And if someone has like an infection with the Coxsackie virus A16, for example, he might develop some immunity against the virus. The problem that this virus or this infection, it's caused by many viruses. This is why if you have once hand, foot, mouth disease, you might have another attack of hand, foot, mouth disease by another virus. This is why the vaccination program for this hand, foot, mouth disease wasn't successful, because there is no only like a specific type, and there is no cross reaction or cross antigenicity or cross sensitivity between one virus and another. This is why the vaccination program was unsuccessful, and it was done in China, but it wasn't that successful. When do you have the patient absent from the school? Usually the patient becomes contagious from the day of the fever and 1 week after. So if you have a kid with the fever and suspecting hand, foot, mouth disease, and today is the 3rd day, you tell him that for the rest of the week you have to be absent from the school. So the main route of transmission of hand, foot, mouth disease is fecal-oral transmission and contact. However, respiratory droplets can be also the source of infection, but mainly fecal-oral as well as the contact, but respiratory droplets and airborne could be another sources. Most contagious, as I mentioned earlier, in the 1st week, and classic location almost like 60% of patients, with incomplete forms with oral lesion only in 21%, and the hand-foot lesion without oral involvement, maybe it's in 11%. So sometimes I see the full-blown picture in one sibling. The other sibling, he might have atypical cases as well. The next one, when you have a fever and then a rash, and this rash happened with the fever mainly on the cheeks. And this is almost like we call the 5th disease, or the slab cheeks, usually in kids, usually at a school age. Sometimes they do have lacy pattern on the arms and legs. This usually self-limited infection. However, you have to be careful in patients with aspleninemia or sickle cell disease, and of course in pregnancy it might have more complication. So this is the parvovirus. Classically, the measles we call the 1st disease, scarlet fever 2nd, rubella the 3rd, and the 4th that is not more common anymore, and the 5th erythema infectiosum or slab cheeks, and the 6th roseola infantum. Roseola infantum, the rash appears after subside of the fever. A very common question here is that, is this rash a drug reaction or a viral exam? There is some features that might help us. However, sometimes we don't have any clue what's the reason. If we have itching more with the drug reaction. Viral exanthem, usually it is asymptomatic, no itch. So your patient has a fever, and the next day he develops a rash. His looks okay, it is non-itchy. This is most likely viral. The viral rash usually is cephalic caudal distribution, while the drug-induced more of the caudocephalic distribution. And the presence of other features as well can help if you have preceding infectious causes or not. Do we see eosinophilia? Not necessarily to have eosinophilia with the drug-induced. If you have a child with oral ulcers, and this child, these ulcers mainly in the back of the tonsils, on the back of the mouth, this is most likely herbangina, and these affect the soft palate and the tonsils posteriorly. HSV and hand, foot, mouth disease are more anterior pharynx, while the herbangina is more posterior. The treatment for this is usually improve oral intake, and also antipyretic. Sometimes they need hydration and IV fluid if the patient cannot swallow, especially in severe primary gingival stomatitis, and this is the indication to give admit the patient. The next question here is that, is antiviral required? Usually we don't give antiviral for these patients unless they are immunocompromised or with disseminated disease. The patient with herpangina or hand-foot-mouth disease or HSV, they have the same symptomatic treatment, and then they have the same precautions as well. Now, in the era of vaccination for the varicella, we don't see the classic varicella commonly as before, but what we could see that we have, after like 10 years of vaccination, we might have some sort of varicella, but it is atypical form, milder form than the classic one. This is maybe due to the immunity start to subside. However, sometimes we start to see a zoster. Zoster can be seen in two conditions, and sometimes in patient post-vaccination, after 1 or 2 years, they might have zoster without history of classic varicella, and this is one of the explanation, maybe because they have been vaccinated, or sometimes if they got a varicella in utero without any complication, they might develop in the first year a zoster. So zoster, keep it in mind that it is possible in the pediatric population as well, and because of the vaccination, you might see atypical cases of varicella. So the classic case of varicella, we are seeing less and less with time. So typically they are milder and they're less frequent in children less than 10 years, and most cases in people who are vaccinated between the age of 10 and 14 years. 1 of 4 studies has shown an increase in zoster incidence after varicella vaccination in the United States in 2010. If you have a blister in a child and he's visiting the emergency room, the first question to ask him, for how long he has these blisters? Are these blisters acute or chronic? If they are acute, most likely you are dealing with infectious process, period. If they are chronic, you have to open your mind to chronic blistering disorders in children, which are they are uncommon. The next question, if they are chronic, are they acquired or hereditary? Hereditary, like epidermolysis bullosa, are differently managed than the acquired one. If you have acquired blisters, acute acquired blisters in a child, and if you see the blister, they are very superficial, and most of the time they will be sloughing of the skin before you see these blisters. Usually the child looks well, he's not very sick, and if you are lucky to see blisters, they look like this. We call them flaccid blister. Flaccid means they are superficial. Why they are superficial? Because then the cleft they are targeting these toxin, something called desmoglein 1. Desmoglein 1, it's located in the upper part of the skin at the junction at the level of the stratum granulosa, which is called the granular layer. So the cleft is superficial. This is why most of the time we didn't see the blister as in these pictures. And most of the time, it doesn't leave any scarring or pigmentation because it is in the granular layer. And commonly to have multiple lesions, and the patient, he will look well. So this is the most commonly seen pictures. And characteristic, sometimes you will see this correlate of scales. This is the remnant of the blisters. And this is in bullous impetigo. The bullous impetigo, it's one of the least dangerous or the least severe form of this disorder. If you have a lot of bullous impetigo, a lot of toxin, at the end of the spectrum, you will have staphylococcal scalded skin syndrome. So SSS is the severe form of bullous impetigo, usually in children, sometimes seen in adults with renal compromise, and the cleavage usually at the granular layer, which is at the superficial part. This is why you didn't see much of blisters and doesn't leave any scarring. This is due to exfoliotoxin A and B, and they are targeting desmoglein 1. The treatment here is with a beta-lactamase resistant antibiotic with isolation and local wound care. When you do bacterial swab from these blisters and bullous pneumonia or from the skin of SSS, usually it is negative. Why? Because it is toxin-mediated disease and is not bacterial mediated. It is the toxin produced by the Staph aureus. In the Staph aureus disease, you will have the fever, malaise, but characteristically, the skin is very tender. So the tenderness of the skin is one of the clues for patient with Staphylococcus aureus skin syndrome. There is diffuse erythema. There is the sparing of the oral cavity, and this is very important. The oral cavity is not involved, and there is perioral pallor. So there are perioral pallor, the mouth is spared, the skin is tender, with fever in a child with a rash. This is Staphylococcus aureus skin syndrome. The next one is scarlet fever. It happens in children in less than 10 years of age, mainly for group A beta hemolytic streptococci, and they produce toxin A, B, and C. They have fever, sore throat. They look more sicker than SSS, and they usually have oral involvement. And the rash started one day after the fever. And if you touch the skin, it is rough skin. We call it sandpaper skin. And this followed by erythema on the napkin area, and then desquamation in the palms and feet after 1 week. If you do a clinical exam, you might see some petechial line at the antecubital fossa, and this is why happening due to capillary fragility. They will have initially white tongue, and with time it will change into something called a red strawberry tongue. Sandpaper, which is rough skin, almost like gauze pump skin, with fever, faint erythema, with oral involvement. This is scarlet fever. These are pasteurine, where you have capillary fragility with petechial rash. And then we have perioral pallor again, but oral involvement. So here you have sandpaper. With time, there will be desquamation of the palms and soles. And this is the white strawberry tongue, with time change in the red strawberry tongue. You might have this child present to you in the emergency by parents with almost nodule and oozing in the scalp. This is a tinea capitis. This is chirion. This is inflammatory type of tinea capitis caused by zoophilic animal brawn or animal type of fungi. Usually it is Microsporium canis from cats, and this is now the most common type of tinea capitis. So this is not bacterial infection. This is a fungal infection. How do we treat it? They need griseofulvin orally. If you don't have griseofulvin orally, you can give terbinafine orally. Usually we give them course from 4 to 8 weeks, and this is contagious. This is tinea capitis, which is the chirion. Another complaint to your patient as well, sometimes when they come to see you, is that they did have an infection. After 1 or 2 days, they start to have itchy rash. These are urticaria. They are red, raised, itchy plaques on the body that happen most of the time in children after infection, either clinicals or subclinical infection. Most common upper respiratory tract infection, but even UTI can cause this problem. What other possibility causes? We call the 4 I's: ingestion from food, inhalation in the environment, injections, or most commonly infection. So the most common cause of urticaria in pediatric age group is infection. If there is only skin involvement, we call it urticaria. If there is a mucosa involvement, we call it angioedema. Usually it is treated with antihistamine. We don't give a steroid unless it is very severe. And when we give antihistamine, we need to give them usually non-sedating antihistamine, and we have to give them the appropriate dosing. Nowadays, for antihistamine, Usually we have to increase the dose 2 times or even 4 times the usual dose to control the disease. I do recommend that you use antihistamine for at least 2 continuous weeks after the attack. Why? What I see in my practice, you were giving antihistamine for 3 days, he's improving, you stopped it, and then they relapse. So I recommend that to use antihistamine for at least 2 weeks from the attack, so to decrease the chance of recurrence. Could urticaria recur? The answer is yes. Do I need to do investigation for food allergy? We don't need to do any investigation for food allergy unless there is a clear reason of food allergies. Urticaria transits with pruritic well-demarcated wheals. It is asymmetric. They last less than 24 hours. This is the question. This is the key thing you have to ask your patient. And it is secondary to histamine release from the mast cells. Symptomatic treatment with non-sedating antihistamine, rarely oral steroids are required if you think about underlying conditions, connective tissue diseases, could be possibility, or like some periodic fever disorder, but these they have continuous chronic urticaria, and these urticaria last more than 24 hours. What do you mean urticaria lasts more than 24 hours? Single lesion, if you have, for example, urticaria in my hand, this lesion lasts more than 24 hours, this is less likely to be acute urticaria, more likely to be secondary urticaria. So what we mean by less than 24 hours is the single urticarial lesion. What about this? These are urticarial lesion, but if you see in the background, these are brown macules. These brown macules are accumulation of the mast cells. If you rub them, they will have an urticaria. So this is, we call it a mastocytosis. This is mastocytosis or urticaria pigmentosa. We see it sometimes in children as well. Atopic dermatitis is very common in your emergency room. You will see it all the time. My recommendation is that use a lot of moisturizer and use topical steroid for flares. If this eczema is like very bad, you can refer to dermatology after the controlling the acute dermatitis. Usually we prefer an ointment. Why? Because ointment, they do have less preservatives and less stinging. So for example, in arms and legs and trunk, we prefer mid-bottled steroid like betamethasone, and on the face, we prefer to have very low steroid like 1% hydrocortisone ointment. So I do prefer the ointment. They are much stronger and less preservatives and less stinging or irritation. It's very important that to discuss with your patient that the food rule in atopic dermatitis is very limited. Usually, I see a lot of people, they are claiming for this the cause of dermatitis. Actually, patients with atopic dermatitis, they are more likely to have food allergy as another disease, as a comorbidities. But the food allergy is not the cause of atopic dermatitis. Sometimes I have seen the parent, they are trying to prevent many times, and they are restricting food from their children, and the child develops food nutrition deficiency. I have few patients who develop like zinc deficiency, secondary to severe restriction of food, assuming that the cause is food allergies. This is the classic, you see it behind the knees and in the antecubital fossa, and these we treat with topical steroid mid-bottled for a few days. If they are recurrent, probably they need a referral to dermatology. Patients with atopic dermatitis, they do have deficiency in the cathelicidin and beta defensin, and this is a sort of antimicrobial peptide which help in the innate immune system. This is why we see this patient more prone to get infection. In this patient, if you have this honey-crusted appearance, this is you think about impetigo. Non-bullous type impetigo, they give you the honey-crusted appearance here. If it is limited, you can give topical piperacin. If it is widespread, probably an oral anti-bacterial agent like penicillins or cephalosporin can be given for these patients. Moreover, these patients are more prone to get herpetic infection, eczema herpeticum. How can we know this? They are usually present with punched out papules. Punched out papules, these are the classic features of the eczema herpeticum. So in eczema herpeticum, you have layers of his atopic dermatitis, but there is the punched out papules, which are representing herpetic infection. If the patient or the baby less than 1 year of age, you need acyclovir. The absorption of acyclovir in children less than 1 year is very poor. So this is why you need an IV. More than the age of 1 year, you can give an oral. So this is eczema herpeticum. So eczema herpeticum, due to a herpetic infection, superimposed atopic dermatitis, as well as a bacterial infection, which causes epidermolytic eczema. In this child, the parents are trying to restrict many food, and this develop a zinc deficiency and give you like acquired acrodermatitis enteropathica with dermatitis almost like U-shaped there. So it's very important that to discuss with your patient and the parents that they shouldn't avoid food unless there's a clear history of allergies. If it is widespread atopic dermatitis and doesn't respond to a proper management, think about the other rare cases of atopic dermatitis: hyper IgE syndrome, immune deficiency, Washington-Ardbeg syndrome, as well as Netherton syndromes, phenylketonuria, omens, acrodermatitis enteropathica as well. Before we conclude, I would like to show you this case, which is called Betritis rosea, usually seen sometimes in children. Usually we see it also in crops. That means in like there is like a few patients, they will come in the same week because it is due to a viral infection, human herpes type 6, and this is usually circulating between changing the season. They present with a single agent, look like a tinea corporis, but within 1 to 2 weeks, they are spread. They do have an oval shape with the scales at the periphery, and they are following the line of the cleavage. This is why they give them like a term, a Christmas tree. This is Betritis rosea. One thing that you might see a patient in the emergency room with a hemangioma. If you see hemangioma on the nose, lips, eye, on the beard area, on the groin, you need to refer to dermatology within 1 week. This is very important because now we have medication to treat hemangioma very effectively. If you see hemangioma on the trunk 1 or 2, you don't worry about it, but the one hemangioma on the vital organs that affect the function or the cosmetic appearance on the nose, eyes, ears, lips, beard area, or on the groin, please refer to dermatology, and they have to be seen within 1 week. The last thing is this hemangioma. If you have a blue nodule on the child, please don't label them as hemangioma unless you are very sure by doing imaging as well as by doing sometimes biopsy, and refer to dermatology. And this is, if you see a patient like this, what we think about it: sometimes congenital infectious, as well as sometimes rhabdomyosarcoma, histiocytosis, and other disorders. And this, I conclude my presentation. I hope you have learned something in dermatology, and I'm willing to take any questions. Thank you.
Thank you, Dr. Ben Amir. Really is very interesting topic, and it's very common to see this is rush in our field. We'll keep the question and answer. Any question, we keep this one at the end of the session. You can just address your question in the box, then we'll try to answer that question at the end of the session. Next speaker will be speak about a very interesting topic, Catherine Rimac. She is the one of the executive leads of the AMS for Children Innovation and Improvement Center, assistant professor of the Pediatric of Dell Medical School at the University of Texas at Austin, medical director of for San Marcos High County AMS, associated medical director for Austin Travis County AMS system and emergency physician at Dell Children Hospitals Center for Central Texas. Welcome, Catherine. She will speak about very interesting topic, how to what's the early goal for direct therapy for septic patient in emergency department. Welcome.
Hello, my name is Kate Remick. I am a pediatrician, a pediatric emergency medicine physician, as well as an EMS physician, and I am going to be speaking about the recognition and management of pediatric sepsis. And I'd like to give a special thanks to Dr. Holden Scott for her assistance with this lecture. So I have no disclosures to report, and I assume responsibility for the scientific validity of this lecture. In terms of the objectives for this particular talk, my hope is to help with the identification and signs and symptoms that help make the diagnosis of sepsis. Second is to develop an approach to the use of IV fluids in pediatric sepsis resuscitation. And lastly, to describe the goals for antibiotic and vasopressor delivery in pediatric sepsis. So I'd like to start with one child's story. This was a 7-year-old boy who presented to the emergency department with a 3-day history of nausea, vomiting, and diarrhea. Unfortunately, though, his symptoms had been going on for quite some time, and his story began really several hours before he showed up in our emergency department. Over the past week, his entire family had experienced similar symptoms of illness with vomiting, diarrhea, occasional abdominal pain, but everybody had recovered except for this particular child. He had had a history of congenital heart disease, specifically a ventricular septal defect that was large, and it had been repaired surgically. And at this juncture, he's otherwise well. He's followed by a pediatric cardiologist approximately once per year, but doesn't require any medications or other management or monitoring. The morning of his presentation, the mom had known that he had becoming increasingly more listless and lethargic, really wasn't able to tolerate any oral fluids. The night before, he'd gone to sleep around 8 p.m. and the following morning, he still hadn't awoken from sleep. So she decided to call the pediatrician's office to schedule an urgent appointment. And she was told that he was welcome to come in at 3 p.m. Later that afternoon. The day that she went to her pediatrician's office, the child ended up sleeping until 12 p.m. And even upon awakening, he remained quite listless and lethargic, just really wasn't acting like himself. By the time she arrived at her pediatrician's office, he was mottled. He had a capillary refill time of 5 to 6 seconds. He was very pale and extremely ill appearing. His initial temperature was 103.7 Fahrenheit. He had a heart rate of 180 and a blood pressure of 68/36. At that time, the EMS was called, and they tried to assist with moving him as quickly as possible to the hospital. Miraculously, they were able to obtain IV access peripherally and start fluid administration. Unfortunately, however, by the time he came to the emergency department, despite every effort at resuscitation, we were unsuccessful, and he ultimately succumbed to his diagnosis of septic shock. The Surviving Sepsis campaign is really an international initiative to reduce mortality associated with pediatric sepsis, and to do so through the adoption of evidence-based clinical practice guidelines. And these were best described in the most recent Surviving Sepsis Guidelines publication that came out in February of 2020. And in these guidelines, they describe an initial resuscitation algorithm for children who present to the emergency department with suspected sepsis and what should be done to manage them as quickly as possible. One of the greatest challenges with the identification of sepsis is that it is not all uniform in terms of presentation. The infection can be different. It can be pneumonia or a urinary tract infection or a bloodstream infection or meningitis. And sepsis can occur equally in healthy or immunocompromised, medically complex children, such as those with cancer. Oftentimes in the early phases, sepsis looks like any other routine illness until the child becomes critically ill. And when that happens, there is a need to treat them as quickly as possible, and even before a final diagnosis is confirmed, in order to increase their opportunities for survival and high functional outcomes. Sepsis, however, while it may not be easy for some to define because of its heterogeneous nature, it is an extremely useful concept for the first hours of diagnosis and treatment, particularly in the emergency department setting. But it is important to remember that it is not a single biologic entity. The best description of sepsis was perhaps given by Dr. Seymour in publication in JAMA, where sepsis is described as a life-threatening organ dysfunction caused by a dysregulated host in response to infection. The reason we care so much about sepsis is it is a leading cause of morbidity and mortality and healthcare utilization for children around the world. Sepsis alone has a mortality rate that ranges between 7.5% and 25%, and it is the implicated cause in approximately 19% of all global deaths, almost 50% of which occur in children. About a third of survivors of sepsis fail to return to their baseline quality of life 1 year following the event. Sepsis accounts for 5 of every 1,000 pediatric hospitalizations, and within pediatric intensive care units worldwide, the prevalence is 8%. When we talk about sepsis, we have some very clear definitions that are important to recognize in the early management of this complex disease entity. First and foremost is that when we talk about sepsis, it's in the setting of either a suspected or proven infection. And again, it does not have to be proven in order to begin the clinical resuscitation algorithm of sepsis. The infection may be caused by any pathogen, or it can be the clinical syndrome that carries significant probability of underlying infection. When there is an exaggerated systemic inflammatory response or a systemic inflammatory response syndrome in the presence of infection, we refer to this as sepsis. And the systemic inflammatory response syndrome is defined by having at least 2 of 4 specific criteria, one of which must be either a temperature change or a white blood cell count change. So in these cases, the 4 categories are either a core temperature over 38.5 or less than 36, tachycardia or bradycardia, tachypnea, and an elevated white blood cell count or a significantly depressed white blood cell count. Severe sepsis is defined as sepsis with the addition of either cardiovascular dysfunction or acute respiratory distress syndrome, or 2 other forms of organ dysfunction. Septic shock occurs when we see sepsis in the setting of both cardiovascular organ dysfunction, and this is typically identified by elevated lactate, the need for vasopressors, and most specifically, hypotension. So why should we care about organ dysfunction? Well, organ dysfunction is an independent risk factor for mortality in the setting of sepsis. When we think about organ dysfunction, there are really 6 primary organs that we worry the most about. First being cardiovascular, where we'll see signs of hypotension, elevated lactate, and the need for vasopressor use. Respiratory compromise, which will often present itself as early signs of respiratory distress or respiratory failure, requiring the need for positive pressure ventilation. Neurologic signs, which include severely altered mental status, renal injury, including either elevated creatinine or other acute kidney injury. Hepatic abnormalities included elevated liver function tests that can be bilirubin or transaminases. And lastly, hematologic findings such as low platelets and or disseminated intravascular coagulopathy. As mentioned, sepsis is defined as any suspected or proven infection in the setting of organ dysfunction. Most organ dysfunction, in order to diagnose, requires laboratory testing, most specifically renal, hepatic, and hematologic. But the diagnosis does not require microbiological confirmation. In other words, we need not know the exact infection. We just need to suspect it and see demonstrated signs of organ dysfunction to make the diagnosis or suspected diagnosis of sepsis. Cardiovascular findings such as hypotension, positive pressure ventilation, and altered mental status do not necessarily require laboratory testing to diagnose. But as mentioned, renal, hepatic, and hematologic findings do. And in some cases, these are the initial organ dysfunction that's seen. If we suspect sepsis based on infection and or any signs of organ dysfunction, the recommendation is to go ahead and start treatment. If once laboratory values come back and they do not support either infection or the organ dysfunction, it's always possible to consider de-escalation as the clinical picture suggests. When it comes to sepsis recognition, as mentioned, the first step is really identifying organ dysfunction in the setting of suspected infection and moving forward with due diligence of basic laboratory testing. But the clinical signs most associated with sepsis are altered mental status, hypotension, and the need for ventilatory support. And whenever we see these signs, it's important to activate maximal resources to address the patient's clinical needs. The Surviving Sepsis campaign outlines an initial resuscitation algorithm for children with suspected sepsis, meaning those for whom an infection or a specific pathogen has not yet been confirmed. In these cases, the recommendation is to complete within 3 hours of initial suspicion the sepsis algorithm. This means that there needs to be an expedited diagnostic evaluation, laboratory findings to assess for degree of organ dysfunction, and early administration of fluids. Whenever there is a sign of hypotension, though, this shifts the patient from sepsis or severe sepsis to the definition of septic shock. And in these cases, treatment is urgent. Ideally, any emergency department will develop electronic alert notifications that will help to notify the lead physicians immediately when any child is suspected of being in the state of septic shock. Remember that the Pediatric Advanced Life Support Guidelines recognize hypotension as being anything under 70 plus 2 times the child's age in years. In children typically over the age of 16 or of adult size, the recommendation is for any systolic blood pressure below 90 millimeters of mercury. And there have now been guidelines that help with identifying cutoff values that are associated with increased risk of mortality. And you can see those outlined here through PALS, APPLES, PEWS, PRISM. These are all clinical recommendations and guidance for systolic blood pressure cutoffs. So let's jump into what happens if we identify septic shock. In these cases, the goal is to initiate antibiotic treatment within 1 hour of recognition of septic shock. And this involves obtaining IV or IO access, obtaining blood cultures, and starting empiric broad spectrum antibiotics. So as directed from the Surviving Sepsis campaign algorithm, in children with septic shock, antibiotics should be started within 1 hour of recognition. And there is a very strong recommendation for this particular guidance. In children who are not in septic shock but have sepsis associated with any form of organ dysfunction, then the goal is to start antimicrobial therapy as soon as possible, but ideally within 3 hours of recognition. And this is a week recommendation. Lastly, for additional recommendations regarding antimicrobial therapy is that we begin antibiotics with broad coverage and then narrow coverage once we identify the specific pathogen or source of infection. Studies have demonstrated that the duration of hypotension before initiation of antimicrobial therapy is critical in determining survival or predicting mortality risk. This was a study conducted over a 15-year period on 2,700 adult patients with septic shock. The overall mortality rate among this group was high at 56.2%. You can see from the graphic on the right-hand side that those patients who had prolonged hypotension prior to the onset of antimicrobial therapy demonstrated very low fractions of survival, in this case as low as less than 10%, for those whose antimicrobial therapy was initiated more than 1.5 days after initial recognition. However, for those patients who received antibiotics within the first hour of treatment or first hours of treatment, we see a trend towards much higher survival rates, approaching as high as 80% of the pediatric of the population in that group. In the pediatric population, we recognize these 3 elements as the key steps in early management of septic shock: obtaining an IV or IO access, initiating antibiotics, obtaining blood cultures, and providing IV fluid boluses. You can see on the bottom left corner that, similar to what we found in adult populations, is that the time to antibiotics matters. And in those patients that received the antibiotics early had much lower rates of in-hospital mortality than those who received the antibiotics later. And what's important to recognize is that it's not just the administration of antibiotics alone, but the sum of these activities working together in order to save the life of each child. Developing a clinical decision support tool or algorithm, such as the one depicted here, can be extremely helpful in trying to standardize and or create more equitable care. In this particular algorithm, it demonstrates that if a patient has suspected infection and signs of critical illness or suspected sepsis, then they are to follow this category or this path. First question is, do they have a serious allergy to penicillin or cephalosporins? If so, the recommendation is to administer levofloxacin. If not, then the next question is whether the patient is immunocompromised or has a central line. If yes, then they should receive a 4th-generation cephalosporin such as cefepime. If the answer is no, then there's a final question asking whether or not there's any evidence of musculoskeletal sources such as pyomyositis or osteomyelitis. If the answer to this is yes, then the recommendation is to administer a 5th-generation cephalosporin, which is listed here. All other patients, however, should be administered the 3rd-generation cephalosporin ceftriaxone, as it provides broad coverage for these patients, and subsequently vancomycin if there's any concern for organ dysfunction and severity of illness. If any kind of anaerobic organism is suspected, such as an abdominal source for the infection, then metronidazole should also be started. And subsequently, in this particular clinical decision support tool, if there's any suspicion for toxic mediated infection, such as toxic shock syndrome, then the recommendation is to also administer clindamycin. Such pathways can be really extremely helpful in expediting care and standardizing treatment to the best possible outcomes. The next step in the management of septic shock is to measure lactate level. Studies have shown that lactate is a predictor of mortality risk in the setting of sepsis. This study demonstrates that for patients with high lactate levels, the probability of 30-day mortality increases exponentially. Lactate is considered to be one of the best and easiestly accessible laboratory markers for pediatric sepsis severity. In this study, Dr. Scott evaluated children with lactate levels less than or greater than 4 millimolars per liter. In those patients with high lactate levels, they had much higher 30 and 3-day mortality rates than those patients with lower lactate levels. The 30-day mortality risk, the relative risk, was 2.9. There have since been subsequent studies looking at the association between early lactate levels being elevated and pediatric SIRS response, and also the association between early elevated lactate levels and mortality in clinically suspected sepsis. The next step in the pathway is fluid therapy. The recommendation in most healthcare systems and in the guidelines is to administer up to 60 milliliters per kilogram of fluid boluses over the first hour. It's important to note, however, that this should be titrated to clinical markers of cardiac output, including heart rate and blood pressure, and also that it should be discontinued if there are any signs of potential fluid overload. Studies have shown that higher fluid administration is associated with increased survival. In this manuscript published almost 20 years ago by Dr. Carcillo and colleagues in JAMA, they found that those patients with 40 mils per kilo or greater of fluid administration had much higher survival rates compared to those with lower fluid administration rates. And additionally, in 2008, Dr. Oliveira and colleagues demonstrated that, again, higher fluid administration rates over 40 mils per kilo are associated with decreased mortality here at 33% compared to those that receive few fluids, where the mortality rate approached 75%. So what happens when children receive a fluid bolus? This was a study looking at 41 children with septic shock. And what they found was immediately following the fluid bolus at 5 minutes, there was a median increase in the overall cardiac index by as much as about 18%. And that 63% of these patients had an increase over 10% in their cardiac index. Unfortunately, 60 minutes after the initial fluid bolus, there was a reduction in their cardiac index back to baseline, or in some cases, even below baseline. At the end of 60 minutes, only 4 patients of the 41 had demonstrated a cardiac index increase of greater than 10%. So the question that this bears is, what should we do with our patients? Do we give them fluids or don't we? Well, the recommendation is that we give fluids first, unless it's contraindicated. But the goal really is to maintain normotension, and that can be done with a combination of IV fluids and vasopressors. This algorithm depicts the importance of walking through each of these 4 components of initial assessment and management. First, starting with an IV fluid bolus of up to 20 mils per kilo. This should be isotonic crystalloid fluid, and typically is delivered via push-pull method or rapid infusion to expedite the administration. Next, starting antibiotics and completing antibiotics coverage as quickly as possible. Reassessing the patient for signs of normotension, hypotension, or fluid overload, checking vital signs, obtaining serial lactates, considering any kind of central venous pressure monitoring, and then if there's still signs of hypotension, beginning vasopressors within the first 60 minutes. It's important to recognize that if a patient shows signs of decompensation, hypotension, or worsening organ dysfunction, that this patient should be escalated to a stat status or alert to make sure that the entire care team is working as quickly as possible to manage this child. Following these initial cycle of fluids, antibiotics, vasopressors, and reassessment, it's important to ensure that all antibiotics have been administered, that laboratory tests have been ordered so that we can evaluate for lactate levels and other signs of organ dysfunction. And in the case of suspected adrenal insufficiency, administration of steroids should be considered. Lastly, if there are any signs of suspected abscess or hardware infection, then surgical services should be consulted. The last step in the management of sepsis is really thinking about vasoactive interventions. And as mentioned previously, lactate levels can really be helpful in monitoring mortality risk in these patients. Normalization of lactate, indeed, is also associated with increased survival. So serial lactates can be used to help guide resuscitation efforts. In this study, Dr. Scott looked at normalization of lactate levels among patients who initially demonstrated organ dysfunction and found higher survival rates among those patients with lactate normalization. In the case of administering vasoactive agents, the recommendation is really to focus on fixing the hypotension or getting the child back to a normotensive state. And it's important to remember that, again, all vasoactive agents should be administered in weight-based dosing. And the most important piece is making sure that we don't make a medication dosing error. The first recommendation is for norepinephrine because of its significant systemic vascular resistance response. Most patients will do well to receive norepinephrine as the first-line agent. Epinephrine is also recommended, particularly for the younger patient and those with community-acquired gram-positive pathogens. These patients may have a tendency towards more significant cardiogenic component or cardiovascular dysfunction, and therefore the inotropic effect of epinephrine can be particularly beneficial in this population. Lastly, if we don't have the availability of either of the other two vasopressors, or they're not demonstrating signs of effectiveness, then dopamine can be used as a secondary agent. The challenge, however, is that dopamine is not a clean single effect agent. It has variable effects at different doses. It also can be arrhythmogenic and decreases growth hormone and prolactin levels. For this reason, dopamine is no longer considered a first choice agent in the management of septic shock. Developing standardized protocols saves lives. And while the Surviving Sepsis campaign outlines a wonderful initial algorithm, it's important that in every emergency department, we develop a standardized clinical decision support tool, such as the ones that were presented here. And in order to optimize outcomes, the recommendation is to implement a pediatric sepsis order set, increase adherence to fluid and antibiotic administration through the implementation of that order set. And finally, that this will result in decreased organ dysfunction, decreased ICU admission, decreased hospital lengths of stay, and ideally will decrease overall mortality secondary to pediatric sepsis. And with that, I'm happy to take any questions. Thank you so much for the opportunity to speak on the importance of pediatric sepsis and how best to manage it.
Thank you, Dr. Catherine. It's very interesting topic and very important. It is very important to discover that patient with suspected sepsis and to start early management to be impact on the outcome of the mortality and morbidity. It's very crucial step to start the early antibiotic and start early management for that patient. We'll move now from that important topic of the sepsis. We'll go now for that important and challenging part for every emergency physician that's facing in the ER. The patient present with fever in the first 3 months of age. So it's my pleasure to be introduce or present Marie Koshahel. She is a professor of the clinical emergency medicine and pediatric. Dr. Koshahel is director of the emergency medicine medical service and director of the AMS and pediatric emergency medicine and fellowship at Harper Oakland Medical Center in Torrance and California. She is very nationally known for her work as AMS researcher and educator, and for her leadership in the field of the pediatric emergency medicine. Welcome, Gosha.
Hi there. My name is Dr. Marianne Gaushi-Hill. I am professor of clinical emergency medicine and pediatrics at the David Geffen School of Medicine and an interim CEO of the Lundquist Institute for Biomedical Innovation. And I'm going to be discussing fever less than 3 months, what's next? And I have nothing to disclose. And I'll go ahead and stop showing my video so you can see all of the slides. But we're going to talk a little bit about some definitions. We consider a fever significant if it's 38 degrees centigrade or greater. And over 60 days, so 60 to 90 days, we think of it as greater than 38.5 or 38.6 and above. Fever without a source is an acute febrile illness in which the etiology of the fever is not apparent after a careful history and physical. And again, greater than 3 months, we consider 39 as a significant fever. So what is toxic appearing? A child who comes in who's febrile and toxic appearing is lethargic. There's signs of poor perfusion. There might be marked hypoventilation or hyperventilation or cyanosis. In other words, these kids look really sick. In terms of invasive bacterial illness, in the upper right, you can see a child with a bacterial meningitis because of the nuchal rigidity. And the lower X-ray demonstrates probably multilobar pneumonia. So we think about invasive bacterial illness as meningitis, bacteremia, sepsis, bone and joint infections, urinary tract infections, pneumonia, and a bacterial enteritis. So again, that involves infections that go into the tissues or into the bloodstream. In terms of increased risk of invasive bacterial illness, ill appearance, really high fevers, hyperpyrexia, depending on the age, the risk of invasive bacterial illness goes up. The underimmunized or unimmunized at prematurity, and that declines with increasing post-conceptual age. Comorbid illness or chronic disease and maternal illness prior to delivery are all risk factors. The other things that we consider in the ED is immunization status. If they've had at least 1 round of immunization, so greater 2 months, 2 weeks past their first immunization, their risk is far lower than if they had received no immunizations to date, at least a Hib and Prevnar. And then height of fever, as I mentioned earlier, underlying medical problems, including prematurity, clinical presentation, signs of toxicity, and then the presence of high-risk criteria. And we'll talk about this, inflammatory markers. So concern for serious infections are all of these things that I've mentioned. If there's a high suspicion for herpes simplex virus infections, you can see focal bacterial infections such as Anaphylaxis can result in significant morbidity and mortality in young babies. Clinical bronchiolitis, meaning they're very symptomatic. There's also some risk there for associated urinary tract infections and then those who have chronic medical conditions or congenital issues. So basically, you have a concern if there's anything wrong with the baby early on for serious infections. Some other categories to consider: if there's clinically identifiable viral infections, it reduces the risk, but not in young babies. So we'll talk more about that. Other viral infections, infectious illness like acute gastroenteritis or upper respiratory infection. And then is there identifiable bacterial illness? Because that changes what you do. For young babies, it's going to be admission most likely. And we'll talk about that, especially as it relates to UTI. Otitis media can, in most infants, can be handled as an outpatient. And then cellulitis is, depending on the presentation, but a low threshold for admission in young babies, but older children, no. And then obviously occult infections is what we're already worried about. All right, here's the current state. Which testing would you do automatically in a infant under 1 month of age, or 28 days is typically what we use. You would do selective imaging. So if they were tachypnic, hypoxic, of course you would do imaging of the chest. Again, plus minus viral studies in all ages based on what their presenting signs and symptoms are. And then whether or not you would admit and give antibiotics. Under a month, we typically would do blood cultures and evaluate for sepsis, which includes CSF studies, and then give antibiotics and admit. Greater than that, we would consider whether or not we would do CSF studies and whether or not we'd admit. Typically under 60 days, we often would do an LP. Depending if there's signs of viral infection, we may end up just doing a UA as an example, and then the decision to admit after that. And you consider prevalence of illness, perinatal history, and gestational age. All right, so under 7 days is the highest risk, and we do a full admission and treat. The issue is, and this is based on recent published guidelines on care of children under 60 days of age. There's really no mention of what to do if tactile fever at home. Typically, I believe that most kids, most infants, that there's a tactile fever at home will develop a fever within the first 24 or 48 hours of admission. We typically don't use serious bacterial illness anymore. We're really defining what it is and whether or not there's a sepsis associated with it, and also if there's invasive bacterial illness. The other thing that we consider is whether or not you feel that the neonate looks well or ill. I think this is going to be very important, especially when we get to the 22+ day infants. And then the issue is there's differences now in access to tests around the globe, and that will make a difference. And then obviously appropriate follow-up. The new guidelines today have more shared decision-making, and I think this is very important to talk with families about testing and what the benefit of testing is. If we look at some of the rates that are quoted, greater than 10% of febrile infants will have UTIs, so that's something we need to consider. Less than 2% will have bacteremia, so much lower than in previous years. Bacterial meningitis is exceedingly low, I think, within the neonatal time period, so under 28 days, it's certainly of consideration. And the risk of invasive bacterial illness in viral, meaning the viral testing is positive infants under 28, can be as high as 2%. So again, this warrants additional testing, and generally, depending on the age, might be, will be a UA. And then for 29 to 60 days old, the bacteremia rate for virus positive infants is much lower. So really, it's under 28 days that we are most concerned. All right, so what about newborns? There's really at 0 to 7 days, there's no change in practice. You still do a full septic workup and still give antibiotics that are listed here and strongly recommended to admit. So we do a full septic workup, which includes a plus minus a chest x-ray, but I often do them because the admitting team wants it, but certainly signs, you would do it of tachypnea or hypoxia. And then you would provide antibiotics and admit. So when do you add acyclovir? Obviously, neonates at higher risk include those where you see disease localized to skin, eye, or mouth. Encephalitis, even in the absence of findings on the skin, eye, or mouth. A disseminated infection. And then if the, ill appearance, seizure, abnormal LFTs, pleocytosis, you would consider doing that as well. What if fever at home? If it's measured greater than 38 at home, even if a febrile and ED, I just would do the workup, especially in this population. All right, let's talk about 8 to 60 days of age now. If they're well appearing, and again, the temperature is greater than 38, this is what we're now going to begin to do some, we have some differential testing based on age. So current or recent antibiotic use in infants greater than 2 weeks requires some kind of individualized interpretation in terms of everything that's done. So 8, they're well appearing and they're not hospitalized under observation, even if respiratory symptoms, whatever, we are going to consider differential testing. So let's look at under 28 days. A urinalysis, urine culture, and blood culture is a strong recommendation under 28 days. For infants 8 to 21 days, there's no change from standard practice, and an LP is strongly recommended. Evaluate for herpes simplex, administer appropriate parental antibiotics, and admit. So what about 8 to 21 days, so well appearing, what is suggested? A urine culture and any leukocyte esterase, positive nitrite, and greater than 5 WBCs per high-powered field. And then a positive urine culture is 10,000 colony-forming units of a uropathogen, a singular uropathogen. CBC, blood culture, and LP, and antibiotics and admission. Inflammatory markers can guide inpatient management, but they won't help with the admission decision per these recent guidelines. All right, so the H21, we admit and treat parental antibiotics. If there is a high extended spectrum beta-lactamase organisms within the community, such as against E. coli, you would use gentamicin instead of ceftazidime. Let me back up 1 second. It's interesting here, if it's intervirus season, which in the United States is summer and early fall, antibiotics could be stopped or withheld. So just because concomitant interviral and bacterial meningitis is really, really low. If CSF pleocytosis or herpes simplex risk factors, you can get an herpes simplex PCR polymerase chain reaction and give acyclovir. And it's really fairly uncommon. Again, I would do interviral PCR on the CSF. And these are the risks for herpes simplex. So now let's move to 22 to 28 days. So this is a little differential. I said under 28 days, you really do have to consider potential for more invasive disease, and certainly testing is important. So 22 to 28 days, it's important to get inflammatory markers because that will help guide. Any positive infectious source requires admission, so a focal source. If the LP is not successful or not attempted, admit. If the inflammatory markers, that's IM, is abnormal, you give antibiotics. If negative, you may hold antibiotics. And in rare cases, if everything is negative, this is a child that could be sent home pending cultures. So let's look at this. Certainly getting a UA, CBC in a blood culture, inflammatory markers, and those are high temp. So if that's high temp is positive. ANC if is greater than 4,000, less than 1,000, you're concerned for sepsis. CRP is greater than 20 milligrams per liter, and it's probably better than the WBC or ANC. And PCT is procalcitonin, and you can see that's the best of all. You can skip the LP in this age group if there's the inflammatory markers are negative, so no high fever, negative procal, negative CRP is an example. Blood cultures and urine cultures are obtained. Infant is hospitalized. You can skip the LP. And you may also skip the LP if the UA is positive, because you can treat with, depending, you can treat with parental antibiotics plus minus oral antibiotics. In terms of the LP, number needed to treat is 1 positive LP per 1,000, 2,000, a little under 2,000 patients. Procalcitonin helps a little bit in this to risk stratify. Should do the LP if any inflammatory markers abnormal, if you want to manage the patient at home, or if there's HSV risk factors. Again, the treatment and disposition, admit if there is signs of focal infection and that IV antibiotics are needed. If CSF suggests bacterial meningitis, UA is positive, consider also admission IV antibiotics if the above is negative, but any one inflammatory marker is abnormal. So in this particular case, CSF is uninterpretable, so you can't say it's negative or suggest bacterial meningitis, that's obvious. UA is positive, and if the inflammatory markers are up. So anyway, this is a consideration of cefepime also instead of ceftaz, although both could be used. All right. If no LP done or LP attempted but no CSF, admit. This is a big change. The option to give antibiotics without doing an LP first used to be strongly discouraged. And the option to not give antibiotics is only given if you're admitting the patient. If UA and inflammatory markers are normal, CSF normal, or enterovirus positive, you may still admit, but you have the option now to manage as an outpatient for this three week to one month old. The conservative thing is to admit. You must give antibiotics either way, so that could be ceftriaxone. And again, a number of these patients can be managed at home. The criteria for UTI I mentioned earlier, and it's important to get a clean specimen if you can. Typically that is going to be a catheterized specimen. So what is automatic for well-appearing infant? You can see 0 to 7 days, 8 to 21 days. What is required, it's going to be admission and CSF studies pretty much. The difference is whether or not you give antibiotics, and that may vary depending on the age, and also whether or not CSF studies would be done. This is a new scenario for the older baby, and again, this is also a consideration, for the younger with everything negative. So now let's look at greater than 28 days, so 29 to 60 days. With the fever, the recommendation is to do a UA culture and a blood culture as a moderate recommendation, and then inflammatory markers. So well-appearing older, you can get a UA. You could consider skipping this in the circumcised boy for UTI. If there's vomiting or other signs that the patient may have a UTI, I would get it. CBC and blood culture, and then inflammatory markers. Again, if there's HSV risk factors, you still need to consider that even in the greater than 1 month old, although it's less likely. You may consider an LP in this, so under 2 months, they're going to be under immunized, at least for Hib and Prevnar. You may consider an LP if any inflammatory marker is abnormal. And in this population, let me go back. In this population, 4,000 successful LPs are required to avoid delay in detection of 1 case of bacterial meningitis. So not very common. And in this population, if the inflammatory markers are negative, then are normal, and this is new, and that includes a temp greater than 38.5, so 38.6 or above. Then if one marker is abnormal, you should get an LP. If none of the markers are abnormal, meaning they're all normal, you don't need to get an LP. The other consideration, if the CSF is positive for enterovirus, we talked about this before, concomitant bacterial meningitis is exceedingly rare. And then one of the things that is important to know, a positive UA in 29 to 68 day old used to be considered risk for CSF and would prompt an LP. Here, positive UA is simply treated and can use oral antibiotics if no abnormal and inflammatory markers. Again, if inflammatory markers are positive, you would get an LP and admit. So May skip parental antibiotics if CSF is obtained and normal. So you could give oral antibiotics. Again, CSF would have to be obtained for that. You give parental antibiotics if CSF not obtained, or you can't tell it's normal, and any inflammatory markers are abnormal. And no need for antibiotics if everything is negative. Hospitalize, here you go, if inflammatory markers are abnormal, CSF abnormal, and can be managed at home if CSF obtained is normal, UA negative, all inflammatory markers. And again, I think it's important for close follow-up for all of these kids. So if at all possible, within 24 hours. And you can see here. And then here's a summary again, looking at all the different studies. 0 to 7, we do everything when we admit. 8 to 21, we do everything, and plus or minus inflammatory markers. 22 to 28 days, there you plus or minus need for CSF, and same in the 29 to 60 day. The difference is the ability to consider sending a patient home. So here's our summary: 8 to 21, 22 to 28, 8 to 21, you do everything. 22 to 28, home with antibiotic option. 29 to 60, home and no antibiotic option, meaning if everything's negative. UA, you see the positivity, and those are the inflammatory markers, just as a review. I put in the slides, just for your knowledge, some of the empiric antibiotic workup, antibiotic therapy for well-appearing infants, 7 to 60 days. Here's a summary slide looking at the most conservative and the least conservative approaches for these populations. What do you do if they're older than 2 months? So now they have had one immunization, typically. So if they're fever without a source, but they have not gotten their immunization and they have high temp, I would consider risk stratifying them, and consider, especially greater than 39, doing the LP and treating. Immunized, no comorbidities, and well appearing. If they're 60 to 90 days, you can basically structure your workup based on risk. Oftentimes for girls, it's going to be a UA, and a chest X-ray could be done depending on the presentation. So with that, I'm going to stop and see if, and this is the expression in the US is don't throw the baby out with the bathwater. And so I'm going to go ahead and stop now and see if there's any question. Again, thanks to Dr. Al-Faifi and the Saudi Pediatric Association.
Thank you, Prof. Marianne. Really, it's very interesting. And there is a lot of change for approach for that patient present with fever. Today are less than 60 days. And now there is big difference now for approach. So it's very important to update yourself about the good approach for this patient, what you have to do for this patient, and how to approach. About the question, I don't know, Dr. Saleh, did you see any question? So I didn't see any question. So we will keep. If you have any question, you can keep in the box. Then we will try to answer this one tomorrow. If you didn't have any question, you can move and will be at the end of our session. And we'll see you tomorrow for the second activity. Dr. Taifi is around. Okay. So thank you. And this is our end of our activity and our session. So hopeful to be find some informative information from that our speaker. So tomorrow, inshallah, will be start our activity of second day.